Hello, welcome viewers. Hello.
Hello.
Welcome viewers.
Hello.
It's,
Yes, sir.
our pre-paper session at 11 o'clock now.
Yes, sir.
Okay, my station 3.
Sir, your voice. Can you please louder?
Station 3. Station 3.
Yes, sir. Station 3.
Session 3. Myself, Dr. G. Chandrasekhar.
Your name is Chandrasekhar G. Station.
Yeah.
Station 3, Session 1.
Session 1.
Yes, sir.
For session 3, session 1. My session.
Achha,
Okay,
you are
okay.
Chandrasekhar G, na, sir?
Yes, Chandrasekhar G.
Yes, sir. Station 3, Session 1.
Okay.
And your
Session 3, session 1. The first
yes.
is the first presenter is the lab.
First presentation
that is a
presenter
risk
name is
indicator.
Raghunath Reddy.
Raghunath Reddy. Yeah. Okay,
Yes, sir.
okay. I will check.
Ah.
Okay. I am ready.
Okay,
No
done,
issue.
sir. Done. Sir, presentation time is 7 minutes. 3-minute discussion, 7 minutes presentation. After 7 minutes, sharing is stopped.
Yes, sir. Welcome, sir. Hello.
Yes, sir.
The first presenter is the topic. What's the topic?
Topic is laboratory risk indicator.
Very good.
Yes.
Good. Thank you.
So the presenter time is 7 minutes.
7 minutes plus 3 minutes
3 minutes
discussion.
is Q&A.
So
After 7 minutes, sharing is stopped.
So totally 60 minutes total program. 1 hour.
Total 1 hour program. 1, 2,
Okay.
3, 4,
7
5,
plus
6,
3, 10.
6 presenter.
Okay. 6 into 10. So 60 minutes.
Yes, sir.
Correct. 7 plus 3. Okay.
Yes,
Right.
sir.
Thank you. Exact time you start. Okay.
No one is joined. Only you. You are joining.
Okay. If they come now, they will restart.
Done, sir. Done.
Webcam.
Yes, sir.
Where's the other panelist?
No, other panelist is not come, sir.
Okay.
One of name is showing commandant. I don't know easy.
Okay. Commandant.
Yeah,
Okay. This,
I'll send the chat. Please rename
Okay,
your
okay.
correct name.
Sure. Okay. Please coordinate. Thank you.
Dr. PK होता is come, sir.
Hello.
Welcome, sir. Dr. Chandrasekhar from Chennai, Tamil Nadu. Welcome, PK Kota, sir.
When you speak, sir, can you please switch on the camera because the live is going.
Hello.
Live is on.
Sir, good morning.
Yeah, morning. Dr.
How are
Hota
you?
speaking. How are you?
Oh, fine, sir. How are you, sir? Going
Absolutely fine. Yeah, yeah.
well. Good.
Chandrasekhar, after a long time
yes,
we're meeting.
I see.
Okay.
So, what are the other panelists, sir? You and myself, and what are the others?
Who is other? Raghunath? Who is other one?
Srinivas Rao.
Okay.
Srinivas Rao.
Yes,
Oh,
sir.
not a join.
Not a join.
Okay, fine.
And first two presenter is come, sir.
Presenters, they have come? They have joined?
Yes, sir.
If you come now, we start. No issue.
Mr. Raghunath and Satish ST is joined.
What about the other panel? Just you remain the
Raghunath
other
has
panels.
come? Satish
Yes,
has
Morning, sir.
come?
I'm Raghunath, sir.
Yes, sir.
Raghunath Reddy.
And
Okay.
other one is
Satish.
Shiva Kumar.
Satish.
Yeah, Satish. I think Shiva Kumar sir is left.
Connect ಮಾಡ್ಕೊಡಾ? ಮುಂದೆ.
Sharp 11 o'clock will start.
Sure.
Raghunath sir, can you please check your screen?
Sir,
Share your screen.
Hello, sir.
Yes.
I'm Dr. Raghunath Reddy, sir.
Yeah. Are you joined with the?
Hello.
Yes.
Hello, sir.
Clear. Raghunath Reddy, clear, very clear. No
Sir,
issue.
I'm Raghunath Reddy, sir.
Yes.
Okay, stop sharing. Sharp 11 o'clock you share.
Only at 11 o'clock we share and start.
Dr. Raghunath, you are using your laptop or your phone?
Sir, I'm
using
reading
the
from
phone.
the laptop and I'm presenting from the phone, sir.
Okay.
You are using your phone?
Sir, I have a laptop.
If you present,
Okay, if you use both system at the same time, some disturbance will come. So please care.
can you please?
Sir, we are doing
can
from
you
the
please,
library, sir.
join with the
All three are
laptop
here, sir. That's why, sir. I'll correct
because
it,
you presenting your mobile phone, your video is not coming.
Exactly.
Yes.
Video is not coming up.
Can you please stop sharing?
Hello. Okay. Hello, sir. Hello, sir.
Yes, Dr. Raghunath.
Yes, sir. I'm Dr. Raghunath Reddy, sir.
Now you have opened your laptop?
Sir, I'm speaking from the phone, sir, but I'm reading from the laptop, sir.
Microphone problem.
Okay.
There is some problem with the audio, sir.
Okay. It's fine.
Okay, Raghunath Reddy, please start at exactly at 11 o'clock. Okay.
11 o'clock.
Please, we can start.
Thank you.
Okay.
Thank you, sir. ಇವಾಗ ಸ್ಕ್ರೀನ್ ಶೇರ್ ಮಾಡಿದೀವಲ್ಲ ಗುರುವೆ
ಸ್ಕ್ರೀನ್ ಶೇರ್ ನೀವು ಅದಕ್ಕೆ ಹೋದ್ರೆ ಸ್ಕ್ರೀನ್ ಶೇರ್ ಆಗುತ್ತೆ ನಾವೇನು ತೆಗೆದ್ನಲ್ಲ ಅದಕ್ಕೆ ಹೋದ್ರೆ ಸ್ಕ್ರೀನ್ ಶೇರ್ ಆಗುತ್ತೆ ಅದನ್ನ ಆಪ್ಷನ್ ಸಿಗುತ್ತೆ
ಸ್ಕ್ರೀನ್ ಶೇರ್ ಮಾಡಿ ಮತ್ತೆ ಇಲ್ಲಿ ಬಂದ್ಬಿಡೋದಾ ಪ್ರೆಸೆಂಟೇಷನ್
ಹಾ ಸರ್ ಸ್ಕ್ರೀನ್ ಶೇರ್ ಅಲ್ಲ ಸ್ಕ್ರೀನ್ ಶೇರ್ ಇದೆ ನೀವು ಪ್ರೆಸೆಂಟೇಷನ್ ಹೋದ್ರೆ ನಿಮ್ಗೆ ಅಲ್ಲಿ ಹೋಗುತ್ತೆ வீடியோ இல்லாம டைரக்ட் ஸ்கிரீன் ஷாட் எப்படி
So you introduce the presenter or directly start? So you introduce the presenter or directly start?
Introduce the presenter. Just you call the name.
Okay, so
And the topic.
you can introduce the, I think, 10:58 or 10.
Okay. Just I mentioned the topic only. The presenter is automatically will come. Okay, no issue. Mention the topic. The first presenters is the presentation regarding the laboratory risk indicator of necrotizing fasciitis from other soft tissue infection. This exactly we started now.
Good morning, sir. I am Dr. Raghunath Reddy, sir.
Wait. You share from your mobile or laptop. You settled the problem. You settled
From the mobile, sir.
what webcam events? Please check that.
Share your screen.
Please share your screen. Start.
Shared, sir.
Yeah.
Shall I start, sir?
Webcam, is it okay sharing the mobile? Is this comfortable for us? Is it okay? Any disturbance?
okay.
If he is sharing the mobile, video is not showing.
Oh, the person.
Only presenter is presentation is showing.
Okay.
Okay.
It's okay. No problem.
Okay, sir. 10:58.
Okay. So in 2 minutes, it start.
Okay.
So welcome all the panelists and the speaker, okay, to our ASICON 2020, the first ever virtual conference of ASI. It's going well. Yesterday went on well smoothly. So today we start the second day, the academic events. Welcome all. Yes, sir. A few words for you, sir. PhD, sir.
Yeah.
So actually, this is our first experience about the full virtual conference in all over India. Yes, sir. Academic events. Very well. So great teamwork from our ASA office bearers, president, vice president, and academic council, and all our EC members. I congratulate on each and everyone. So the presentation is about 7 minutes and discussion about 3 minutes. The total time period is about 10 minutes. So please present crisply and tell your points very clearly and go for discussion.
Okay. Now, Raghunath, you can start.
Good morning, sir. Good morning, everyone. Today, I'm presenting the paper on laboratory risk indicator for necrotizing fasciitis, that is LRI NEC score, as a tool for differentiating necrotizing fasciitis from other soft tissue infections. Introduction. Necrotizing fasciitis is a rapidly progressive inflammatory infection of the fascia with secondary necrosis of the subcutaneous tissues. The speed of spread is directly proportional to the thickness of the subcutaneous layer. Necrotizing fasciitis moves along the facial plane. Early recognition and surgical intervention at the earliest is the sole factor in preventing the morbidity and mortality in patients with necrotizing fasciitis. The paucity of specific cutaneous signs to distinguish necrotizing fasciitis from other soft tissue infections such as cellulitis makes the diagnosis extremely difficult. So a scoring system which is easy to follow and cost effective with high positive and negative predictive value is required. One such scoring system is the LRI-NEC scoring system devised by Wong et al. In 2005, which claims to have a positive predictive value of 92% and negative predictive value of 96%. Aims and objectives: to evaluate the LRI-NEC score as a tool for differentiating necrotizing fasciitis from other soft tissue infections, to determine the prediction of necrotizing fasciitis based on LRI-NEC score among patients with soft tissue infections. Inclusion criteria: all the patients with significant soft tissue infections admitted in ESIC, MCPGI, MSR, Rajajinagara, Bengaluru, patients who are more than 18 years of age, patients who give consent for participation in the study. Exclusion criteria: pregnant women and all the patients who did not consent to be a part of the study, sir. Materials and methods: all the patients with soft tissue infections admitted in surgical wards. It is a prospective study started in January 2019 till June 2020, sir, of 18 months. Methodology: 55 patients with soft tissue infections were evaluated prospectively on the basis of LRI-NEC score. Based on the LRI-NEC score, as mentioned in the proforma, the patients were categorized as low, that is less than 5, intermediate between 6 and 7, and high more than 8, sir, to aid in the diagnosis of necrotizing fasciitis. Patients in each category were appropriately managed. All variables in terms of progression of the disease, associated comorbidity, number of debridements, outcome of the disease in each category were documented and statistically analyzed to evaluate the significance of LRI-NEC score in predicting necrotizing fasciitis and its clinical outcomes. This is the proforma, sir. Detailed physical examination, including nutritional status, the status of the vascular system, neurological system were recorded. Detailed local examination of the involved part was done. On admission, general and medical treatment of necrotizing fasciitis was done and followed by wound debridement as the definitive procedure. The patients were later managed by regular wound dressing, antibiotics, and supportive therapy for maintenance of blood pressure and renal status. And in a few cases, vacuum-assisted dressing were tried for faster healing. Once the wound was healthy, split skin grafting and secondary suturing was done in most cases. Some cases healed by secondary intention. Some cases had to undergo major amputation for control of infection and its spread. Diabetic patients and renal complications were managed as per protocol. Post-discharge, the patients were followed for up to 1 month regularly on OPD basis. These are the results, sir. The youngest patient was 26 years and the oldest was 83 years, sir. The maximum patients belong to 41 to 55 years age category, sir. This is the sex preponderance, sir. And the 10 patients among 17 necrotizing fasciitis patients has a total count more than 25,000, and 30 among 38 non-necrotizing fasciitis soft tissue infections has more than 25,000, sir. Hemoglobin 13 among that is 76%, 76.46% patients among necrotizing patients had hemoglobin less than 11, and 60.52% of patients among non-necrotizing patients had hemoglobin less than 11. Serum CRP. 88.2% necrotizing patients were positive for CRP, sir, and 2 were negative, sir. In non-necrotizing patient soft tissue infections, 2.7% were positive, sir. Serum patients for 76.47% of necrotizing patients had hyponatremia, sir. 26.31% among non-necrotizing patients had hyponatremia, sir. 88.23% of the patients in necrotizing patients had elevated serum creatinine, sir, and 39.47% non-necrotizing patients, soft tissue infection patients had elevated serum creatinine, sir. 5.88% necrotizing patients had less than 180 milligrams of random blood sugar, sir. 15.78% of non-necrotizing patients had blood sugars less than 180, sir. 23.52% of the necrotizing patients had undergone limb amputation to prevent mortality, sir. 2.63% of non-necrotizing patients had amputation to save the mortality, sir. 94.11% among necrotizing patients had their LRNE score more than 8, sir, and it was only 5.2% among non-necrotizing patients, sir. Discussion. Necrotizing patients was first described as a rapidly spreading gangrene of the subcutaneous tissue caused by beta hemolytic streptococci group A. This disease was later considered as a clinical entity rather than a specific bacterial infection. Many virulent organisms can cause necrotizing fasciitis. Most of the times, it is polymicrobial infection, sir. Necrotizing fasciitis is a surgical emergency. Early recognition and prompt aggressive surgical debridement of all necrotic tissues is critical for survival. Early diagnosis of the presence of a necrotizing soft tissue infection is critical. That necessitates surgical debridement from a non-necrotizing cellulitis. That's response solely to antibiotic therapy. Any delay in diagnosis is potentially catastrophic because the concomitant delay in appropriate surgical therapy has been shown to increase mortality. We have recognized necrotizing fasciitis whenever there is a necrosis of subcutaneous tissues extending through the facial planes. When the infection progressed despite treatment with broad spectrum intravenous antibiotics. It has been shown by numerous studies.
Time is over. Start Q&A.
Okay, sir.
Can you conclude, Raghunath?
Conclusion, there exists a statistically significant correlation between LRINEC scoring system and necrotizing fasciitis. LRINEC score is an additional tool to predict the necrotizing fasciitis among soft tissue infections and to differentiate necrotizing fasciitis from other non-soft tissue infections.
Okay.
Thank you, sir.
Okay, Raghunath, my one question to you that out of all these 54 cases, you diagnose this your necrotizing fasciitis clinically or after that scoring system, Lerinek?
But clinically with LRNEC score and pathologically we took pathologist opinion also, sir.
Now, what is the difference between how many cases clinically you diagnose as necrotizing fasciitis, but it didn't collaborate with your larynx scoring system?
Around 94%, sir.
94% cases.
Among 17 necrotizing patients,
Hmm.
94% had more than LRINE score more than 8, sir.
More than
High risk.
high
We
risk.
had,
Okay.
LRINE score we had divided as low risk, intermediate risk, and high risk, sir.
Correct. Huh.
84% people belong to the high risk categories.
So what's your ideal? Okay.
Yes, sir. Continue.
Yes.
Continue.
So what's your ideal plan for selecting this topic, this research?
Because the diagnosis of necrotizing fasciitis and other soft tissue infections is difficult, sir, clinically sometimes. And because of the lack of skin looks healthy, sir, from outside in necrotizing fasciitis in the initial stage. So we took this LRINEC score to aid.
So to manage as early as possible.
Yes, sir.
As early as possible, the early management of necrotic fasciitis is preserve the organ. Okay, preserve the organ and site. Okay, and also life-saving procedures.
Yes, sir.
Okay, what do you mean by the modified LRNEC procedure?
They add some more parameters for LRNEC score, sir, like
What are that?
LDH, like potassium,
erythrocyte, fibrinogen.
Yes, sir, fibrinogen.
You have to add it. Okay, so these are the additional factors for the modified LRNEC.
Yes, sir.
System. Okay.
Okay.
So good.
And Dr. Raghunath, thank you very much.
Thank you so much, sir. Thank you so much.
Thank you.
Next presenter, please.
Hello, sir. Good morning, sir.
Yes, here, please.
You are Dr. Shiv Kumar.
Audio is not coming.
Dr. Satish, audio is not clear.
Dr. Satish, your audio is not coming. No audio, sir.
You unmute. Satish, you unmute.
Okay, Satish, not clear. Share your video, this slide.
Sir, audio is not coming.
Hello, sir.
Yes,
Yes.
start.
Make it full screen.
I'm audible, sir, now?
Yeah, you are audible. Make it full screen.
Yes, sir, I will make it full screen.
Yeah.
Can I start now, sir?
Okay, you can start.
Make it slideshow.
Yes, sir, I will start, sir. Sir, good morning, all, sir. Today I am presenting a paper on comparative study of lift and fistulectomy in the management of transmetric fistula in ANO. Coming to introduction,
Satish,
associated with abscess reaccumulation followed by intermittent spontaneous decompression.
Your screen is not visible. Can you please share again?
Yes, sir, I will share. It is not visible, sir, now also.
No.
okay, webcam events.
No, sir, I am not.
So give time to him, then go for next.
We can come to next. You'll come at last. Satish, you make your slides, everything
Yes, sir.
ready. We'll call you in the end.
Shiva Kumar,
Okay.
Ready. Actually, we are ready, sir. Can I start now, sir? It is,
Okay.
on your video, sir.
Please present. Time is running.
Yes, sir. Transsphincteric fistula comprise of 20 to 25% of all fistula cases. Surgery remains the only modality for effective treatment of this condition. Coming to classification of fistula in NO, there are 4 classifications: Girth classification, PARS classification, St. James University Hospital classification, Standard Practice Task Force classification. We usually use that PARS classification. It is classified in 1976, in which intersphincteric, transsphincteric, supraelevator, and extrasphincteric fistula are seen. Different modalities of management fistula in fistulotomy, Seton technique, advancement flap technique, fibrin glue, laser surgery, Bora prosthetic. Coming to aims and objectives of the study, to compare between the fistulectomy and lift technique in the management of transsphincteric anal fistula with respect to operative time, post-operative pain, healing time, hospital stay, occurrence of post-operative complications like incontinence and recurrence. Coming to inclusion and exclusion criteria, all patients with transsphincteric fistula aged above 18 years are included. Exclusion criteria: patients with malignant fistula, patients with Crohn's disease, patients with intestinal tuberculosis, complex fistula, patients with diabetes mellitus, patient not willing to give consent. It is a prospective comparative study conducted in Department of General Surgery in ESI. Ethical clearance obtained from the institute. 32 in each group by computer generated randomization in sample taking for sample day. In study in period between January 2019 to June 2020. Coming to methodology, detailed history including demographic details, presenting complaints, duration of symptoms, history of previous episodes of anorectal sepsis and past surgeries, history of any comorbidity, the site and number of external opening, location of internal opening, evidence of abscess or presence of any other anal conditions like hemorrhoids or fissure, findings of preoperative routine blood investigations like CBC, RFT, LFT, serum electrolytes, RBS, PTABT, INR, serology, urine protein and microscopy, chest X-ray, ECG, imaging studies such as transrectal ultrasound, MR, fistulogram were observed, and preoperative physician and anesthesia fitness were taken. 32 patients were treated by lift technique and 32 patients were treated by fistulectomy. The procedure was done under spinal anesthesia in lithotomic position. After identification of the external opening, it was propped by 14-gauge cannula through which 2 ml hydrogen peroxide was injected and traced through endoscope inside anal canal to identify internal opening. Coming to technique, lift, a calvinar incision is taken at the intersphincteric groove. Intersphincteric part of the tract was identified. The tract was ligated close to internal sphincter with acryl 20 and cut distal to the ligature. The distal fibrous tract was then cored out or curated from the external opening to the external sphincter. Probe is passed through external opening to the internal opening in fistulectomy. Elliptical incision including fibrous tract along with unhealthy granulation tissue and external opening excised. All patients received prophylactic perioperative antibacterial medications including ceftriaxone and metronidazole. Severity of postoperative pain was assessed using a visual analog score on the evening of surgery before administering non-opioid analgesics. The duration of hospital stay was noted. Evaluation was done weekly till complete wound healing and time to complete wound was noted. After wound healing, patients were followed monthly for recurrence and incontinence till 6 months postoperatively. Data is analyzed using descriptive methods. Categorical data expressed in terms of frequency and percentages. For all statistical evaluations, p-value less than 0.05 is considered statistically significant. All data analyzed using SPSS 20 software. Coming to results, the mean age in the lift group is 36.28 and fistulectomy group is 36.09, which is not significant. In lift procedure, male include 27 patients and fistulectomy group 25. Female 5 patients in lift and 7 patients in fistulectomy, which is also not significant. Age, the youngest age is 21 year and the oldest is 51 year in the lift group, and in fistulectomy group, youngest is 24 years and oldest is 48 years. Majority between 30 to 40 years. Coming to sex, male postoperative. Coming to postoperative complication, difference between the fistulotomy and fistulectomy group. In pain, the perception of pain is less in lift compared to fistulectomy, which is statistically significant. And operative time, it is almost 33 minutes in lift group and in 40 minutes in fistulectomy group. Coming to time for wound healing is 5.75 weeks in lift group and more than 6.37 in fistulectomy group. The incontinence occurs in only one patient in lift group compared to fistulectomy group, which is 6 patients. Postoperative hospital stay is 2 in lift group and 2.6 in fistulectomy group. Recurrence is more compared to fistulectomy in lift procedure. It is 5 in fistulectomy group. It is 3 patients. Coming to discussion, fistula is a common in age group of 30 to 40 years in our study, with mean age is 36 years among the 2 study group. The more common in males, with male to female ratio is 4:1. Operative time is significantly less in lift when compared to fistulectomy. Post-operative pain is less in lift when compared to fistulectomy. The time for wound healing was significantly shorter among lift group compared to fistulectomy group. Lift shows low incidence of incontinence than fistulectomy group. In our study, lift has higher recurrence rate compared to fistulectomy, of success rate of 84.3%. Compared to other studies, similar operative time is there and pain is there. Post-operative hospital stay is more in our study compared to Pallavi VIR study. Healing time is also similar. In between, it will comes between the 5th to 6th week. Incontinence is shown in our study. No incontinence seen in Pallavi VIR study and Hasani in a study. Recurrence is more in our study, 5 compared to other studies, which is also in more in Alpach is et al. Study and less in Hassani study. Success rate is similar but more in Hassani study. Conclusion: despite slightly higher recurrence rate, lift procedure has certain advantage over standard fistulectomy in the treatment of transmetric anal fistula. Thank you. These are my reference.
Sir, can you please unmute yourself? You are muted.
Thank
Okay,
you.
what are
Hello.
okay. Please.
Yeah.
Yes,
Can you hear me, Dr. Satish?
yes sir, I can hear you. Sir.
Yeah. Dr. Satish, tell me, you have told that lift you have got a lot of recurrence as compared to fistulectomy. Can you give me one reason why it is so much of difference?
Sir, because we didn't ligate the proximal tract, sir. Only distal tract we ligated.
No, lift obviously proximal tract you usually we core it out
Yes, sir.
basically, or you exercise it is possible. Yeah.
Distal tract only will fistulectomy as core it out. Proximal tract we leave it by ligating it, sir. There are more chance of recurrent infection, and if it also presents means distal tract, distal fistula is present, sir.
What is absolute contraindication for this lift? Have you considered that point?
No, sir. Complex fistula usually not prefer. Recurrence.
Yeah. Yes, sir.
So what are the complications you expect from these lift procedures?
Mainly recurrence, sir. Mainly recurrence is more, sir.
Apart from recurrence, any other complications? Any abscess formation, local collection,
Local
post.
formation.
So what are the advice you have to give to the patient after your surgery?
Regular follow-up, sir. Then clean and hygiene, sir. Maintain hygiene.
So sometimes recurrence rate is more. So what's some advice you give to the patient means you avoid some recurrence. So what are the things you have to do for this lift procedure? What is the cause for the recurrence?
Unhygiene, mostly unhygiene, sir. And distal tract, proximal tract only ligated, no, sir. Distal will be
okay,
open.
some remnants. Okay, some remnants and also unhygiene. So the dressing methodology and also cleaning habit and avoid the local stasis of the contaminated things. Okay, so these are the things you have to do. Thank you,
Okay.
Satish.
Thank you, sir.
Thank you, Dr. Satish.
Yes, sir.
Next
Thank
speaker, please. Dr. Dambolam Srinidhi. Srinidhi,
Not joined.
not joined. Debasri. Dr. Debasri.
Dabasri is there. Dabasri is ready? Okay, start. Share your slide.
Yes, sir. Are you able to see my screen, sir?
No.
Now, sir?
No, no.
आप टैब से ज्वाइन हो या कंप्यूटर से?
Sorry, sir?
You join with tab or laptop?
Tab, sir. I actually have two presentations in two different stations, sir.
You need to share your screen, no?
I have shared, sir.
No.
Not at
It's-
display.
It's not coming. They were saying nothing is coming. Now your only your view came just now. Again, it also went away.
Okay, time is running.
David, it's not coming. I think you
Okay.
see your what is the problem. We can go to next speaker. You can come at the last. Devasri, can you hear
Okay.
me? Can you
Yes,
hear
sir.
me?
I can hear you.
Okay. You please see that everything is all right. We'll call you at the end. Next speaker,
Okay.
please, Dr. Shiv Kumar.
Hello, sir.
Yes, share your screen. Quick.
Yes, sir. 1 second. Is it visible, sir?
Yes. Start, please.
Shall I start, sir?
Yes.
Yeah, good morning, sir. Myself, Dr. Shivkumar. I'll be presenting a paper on effectiveness in the management of acute cholecystitis and acute cholangitis based on Tokyo Guidelines 2018.
Hello.
Tokyo Guidelines 2018 is an expert panel formulated diagnostic and severity assessment criteria guidelines and is the only guidelines which aids in diagnosis and management of acute cholecystitis and acute cholangitis. Except for some known clinical signs like Murphy's sign, Charcot-Strad, there are no well-defined criteria for the diagnosis of biliary infections. Acute biliary infection may cause a rapid deterioration in condition due to sepsis, and therefore prompt and appropriate treatment is required. Tokyo guidelines for the management of acute cholecystitis and cholangitis were first published in January 2007, which consequently were updated in 2013, and they're currently followed as Tokyo Guidelines 2018. It includes diagnostic criteria of acute cholecystitis and cholangitis to establish the diagnosis based on clinical signs, blood investigations, and radiological evidence. These guidelines also encompass a severity assessment criteria based on which patient can be divided into groups, which are then managed according as per severity criteria. These guidelines include diagnostic criteria, severity assessment, and management. In acute cholecystitis, the diagnostic criteria include 3 parameters: local signs like Murphy's sign and right upper quadrant pain or mass or tenderness, and systemic signs like fever, elevated CRP, elevated WC counts more than 12,000, and imaging findings of suggestive of acute cholecystitis. If one item in A and one item in B are present, then it's considered as a suspected diagnosis. If one item in A, one item in B, and imaging findings are present, then it's a definitive diagnosis according to this diagnostic criteria. Then coming to the severity criteria for acute cholecystitis, there are mild, moderate, severe, or grade 1, grade 2, grade 3. In grade 1 or mild cholecystitis, there is no organ dysfunction and mild inflammatory changes are present, and it does not meet the criteria of grade 3 or grade 2. In grade 2, patient is having acute cholecystitis with presence of any one of the following, like elevated WBC counts, palpable tender mass in right upper quadrant, duration of symptoms more than 72 hours, or marked local inflammation like gangrenous emphysematous cholecystitis or pericholecystatic or hepatic abscess or biliary peritonitis. Grade 3 or severe acute cholecystitis, it includes the features of acute cholecystitis with any of the following organ dysfunction. It can be serious dysfunction, neurological dysfunction, renal dysfunction, respiratory dysfunction, hepatic dysfunction, hematological dysfunction. Then coming to cholangitis, these Tokyo Guidelines diagnostic criteria for acute cholangitis include systemic inflammation, cholestasis, and imaging. Systemic inflammation like fever or chills, elevated WBC counts, cholestasis features like jaundice or abnormal liver function test, imaging imaging findings of biliary dilatation or evidence of etiology and imaging like stricture, stone, or stent. Suspected diagnosis can be given if one item in A and one item in B are present. Definitive diagnosis is given if one item in A plus one item in B and one item in C are present, according to these guidelines. Then coming to severity assessment, grade 1 or mild acute cholangitis, it does not meet the criteria of grade 2 or grade 3. Grade 2 or moderate cholangitis, it includes elevated WBC counts, high fever, age more than 75 years, hyperbilirubinemia, hypoalbuminemia. Grade 3 acute, severe acute cholangitis, it includes organ dysfunction like serious dysfunction, neurological dysfunction, renal dysfunction, respiratory dysfunction, hepatic dysfunction, or hematological dysfunction. Then coming to the management according to these guidelines, in case of acute cholecystitis, grade 1 or mild cholecystitis, early laparoscopic cholecystectomy is preferred. In grade 2 or moderate acute cholecystitis, early cholecystectomy is recommended in experienced centers. However, if patients have severe local inflammation, early gallbladder drainage is preferred because early cholecystectomy may be difficult. Medical treatment and delayed cholecystectomy can be done. Grade 3 or severe acute cholecystitis, initial management of organ dysfunction and management of severe local inflammation by gallbladder drainage should be done. Then followed by elective cholecystectomy. Then guidelines for acute cholangitis management include in grade 1, antibiotics and general supportive care should be given. Once finishing the antibiotic course, then definitely treatment can be done, endoscopic or percutaneous treatment. In case of moderate and severe cases, early biliary drainage is indicated. Then aims and objectives of my study: to study the effectiveness of Tokyo Guidelines 2018 in diagnosing, assessing severity, and management of acute cholecystitis and acute cholangitis. Materials and methods are all the patients aged 18 to 60 years who were diagnosed with acute cholecystitis and acute cholangitis using Tokyo Guidelines were included in this study. It's a prospective study carried out during for a duration of 18 months between Jan 2019 to June 2020. All cases of acute cholecystitis and cholangitis due to biliary pathology aged between 18 to 60 years are included. Exclusion criteria is case of acute cholangitis and acute cholecystitis due to extrabiliary pathology. Patients denying treatment or not giving consent are excluded. Methods of collection: patient diagnosed with a case of acute cholangitis and acute cholecystitis are followed up and assessed using Tokyo Guidelines 2018 criteria, and outcomes are analyzed. Clinical details, lab investigations, imaging findings are required using well-detailed performer. Other contributing factors, clinical patterns, presentation, treatment outcomes are analyzed in detail. There are a total of 60 cases, 30 in each group. The data is analyzed using SPSS, and p-value less than 0.05 is taken as significant. Coming to results, gender, both acute cholecystitis and cholangitis it has a higher incidence in females, accounting for about 60% in both cases. And coming to the age-wise incidence of acute cholecystitis and acute cholangitis is higher in elderly patients above 50 years of age. Pain, abdomen, fever are predominant complaints and was the first to arise in our study population. Other symptoms are vomiting, chills and rigors, jaundice, anorexia, and Murphy's. Duration of symptoms: majority of the cases, accounting 56%, they presented to the medical attention after 24 to 72 hours of onset of symptoms. More than 40% of the patients were presented after 72 hours in both the cases. Biochemical results: total leukocyte count was elevated in both acute cholecystitis and acute cholangitis patients. In acute cholecystitis, about 70%, and in acute cholangitis, 83%. CRP is elevated in both the cases. Coming to ultrasonographic findings in our study group, enlarged gallbladder and followed by thickening of the gallbladder was found in our study group. About 63% thickening of the gallbladder and 73% enlarged gallbladder. Other findings are echogenic debris, ultrasonographic Murphy's sign, gas imaging, and pericholecystatic fluid. In acute cholecystitis, there are 6 patients with single GB stones, and there are about 20 patients with multiple gallbladder stones. Coming to the grading, majority of the patient, about 53%, they were belonging to the grade 2, followed by grade 1, 43% in acute cholecystitis, and in acute cholangitis.
Your time's up. So what is your conclusion?
Hello, sir.
Yes.
Coming to conclusions, sir. Elderly patients in fifth decade. Hello, sir. Hello.
Yes. Yes.
Yes, Tokyo guidelines.
Sir, please unmute, sir. Unmute. Kota, sir.
Tokyo guidelines
Okay.
2018. It's an appropriate tool that can be used in a setup without any fallbacks. As most of the parameters in these guidelines can be analyzed and reproduced in our population group, it allows early diagnosis and easy management of patients and to determine necessity for early cholecystectomy.
Okay. Dr. Siva, you have got a good paper, but you should have presented, properly in time. Okay, you took much more time in introduction. Okay,
Yes, sir.
don't do that.
Guidelines,
We are not interested in that. Whatever those classification, because we know already all these things. We know little bit you should have told, but you spoiled a lot of time and the results, which is most important in presentation, we could not hear it or we couldn't know. Okay,
sir.
what you have achieved from your this study?
Sir, using these guidelines, it's possible to early detections in elderly, especially in elderly patients and with comorbid patients. These guidelines allow us to early diagnosis and severity grading, sir, which is very important, sir, and early treatment. Any biliary drainage.
What treatment you advise as early as possible in your study?
Sir, in mild cases, we can prefer conservative management, sir. Otherwise, if there is severe local inflammation, biliary drainage procedures can be considered, sir.
What is the ideal procedure? Whether you do surgery in acute cholecystitis or not, or acute
Yes,
cholangitis?
early presentation, sir. Within 72 hours, it's preferable, sir.
What is your study report?
Yes, sir. The patients presented within 72 hours, we did lap cholecystectomy, sir. The patients who were between like above 72 hours, we initiated lab, sir, but it was about 3 patients we converted to open, sir.
So what precautions you have to take before you go for lap cholecystectomy or whatever the surgical procedure in this acute cholecystitis or cholangitis? Directly going for surgery or pre-operative, any
Ultrasound, sir. Investigative.
ultrasound imaging, it's all okay. Good. What is the role of ERCP in the management of acute cholangitis and cholecystitis?
To look for CBD stones and if drainage required, sir. For two-root cholangitis, any mass or stones, we can make out, sir, through ERCP.
ERCP stenting. What is the use of ERCP stenting?
To facilitate the drainage and while ERCP stenting, we can remove the stones also, sir. Stone retrieval can be done.
So final result in your study, final result, one word.
Yes, sir.
Okay, Shivakumar, thank you.
Thank you.
Thank you. What the next?
Thank you, Shiva. Next speaker, please. Chaitanya sir, Ganesh,
Not joined.
not present.
No, sir.
Oh, not joined. Okay.
Not joined. Dr. Debasri, are you ready? Dr. Debasri, are you ready? Srinidhi? Dr. Srinidhi?
Webcam events, please.
Dr. Srinidhi and Dr. Chaitanya is not joined, or I think Dr. Devashri is left.
Devasri is left.
Yeah, he's
and
an attendee. I promote him. She is an attendee.
okay. So now the total presentation is the lab risk indication. That is
Devashri ma'am is come.
Devasri is coming. Okay. Devasri is ready.
Good morning, sir. Yes.
Good morning. Okay. Please
Morning,
start.
Devasri. You can share your screen.
Yes, sir.
Make it slideshow.
Yes, sir. Are you able to see it, sir?
Yeah. Please carry on.
Good morning, sirs. I'm Devashri from Ramchandra Institute of Higher Education and Research from Chennai. Today, I'll be presenting my paper on the clinical spectrum of extrapulmonary tuberculosis, a surgeon's perspective. Tuberculosis is an endemic disease in India, and extrapulmonary TB usually presents with atypical symptoms that pose a diagnostic and treatment challenge. In a surgical practice, the presentation mimics more common surgical emergencies or diseases, forcing tuberculosis to take a backseat in the differential diagnosis. Here, I'm reporting a series of atypical presentations encountered by surgeons in a tertiary care center. The aim is to highlight the variable presentations and their appropriate management regimens. Materials and methods. It's a series of 4 cases of extrapulmonary TB. First being a parotid tuberculosis, a second an oral ulcer, a third is tuberculous mastitis, and fourth are peritoneal tuberculosis. In all 4 cases, the diagnosis was confirmed after having done AFB assessment and histopathology. The patients were treated with anti-tubercular therapy based on RNTCP protocol, and patients were under follow-up until completion of therapy and showed satisfactory recovery. First case, a 19-year-old female presented with a swelling in the right preauricular region since 1 month, which was associated with pricking type of pain for the past 1 week. On examination, a hemispherical swelling of 4 by 4 centimeter, cystic in consistency, mobile and tender was noticed. A provisional diagnosis of a limb cyst was made. MRI neck done revealed a well-defined cystic lesion in the right superficial parotid gland with peripheral soft tissue components. Differential diagnosis included first branchial cleft cyst, lymphoepithelial cyst, and epithelial neoplasm. Following a surgical excision, the histopathology of the cyst revealed granulomatous inflammation. AFB stains were negative. Gene expert of the parotid cyst wall fluid revealed Mycobacterium tubercle bacilli. Post-operatively, patient was on ATT as per DOTS for 12 months. Coming to the second case, a 33-year-old female was admitted with a painful ulcer on the tongue for 3 weeks with loss of weight and generalized weakness. On examination, an ulcer of size 2 by 3 centimeter in the right lateral border of the tongue with undermined margins and base covered with pale slough was noted. The ulcer was tender to touch and had an indurated margin. Lab investigations revealed a normal total leukocyte count and an elevated erythrocyte sedimentation rate. Provisional diagnosis of malignant ulcer was made. A biopsy taken from the margin and the center of the ulcer under local anesthesia revealed granulomatous inflammation with areas of necrosis, suggestive of tuberculosis. Post-operative further investigations revealed a positive MAN2 test. The patient was thereafter started on anti-tubercular therapy, and 1 week thereafter, the ulcer was noted to regress in size and completely healed in 1.5 months, whereas the patient continued treatment for 6.5 months. Coming to the third case, a 33-year-old female who presented with a swelling in her left breast for the past 2 months, which is associated with pricking type of intermittent pain. She gave history of pus being drained from the lump in an outside hospital with no history of fever, loss of weight, or appetite. On examination, pus discharge was present at the nipple. Underlying lump of 6 by 6 centimeter noted in the central quadrant with an irregular surface, firm in consistency, and no axillary nodes were palpable. Screening ultrasound done had revealed solid components. Hence, we proceeded with a core biopsy of the left breast lump, and samples were sent, which showed histopathology revealing granulomatous mastitis. AFP stains were negative. Gram stain showed occasional gram-negative bacilli, and pus culture showed Staphylococcus aureus. A pulmonologist review was obtained, and the patient was thereafter started on ATT, and she continued for 9 months. Coming to the fourth case, a 60-year-old female who presented with abdominal distension, which was insidious in onset and progressive since 1 month, associated with abdominal pain, which was diffuse and dull aching. There was no history of, there was history of fever and loss of weight over 1 month. For abdominally, distension was present and fluid thrill was present. A provisional diagnosis of query abdominal tuberculosis was made, and hence the patient was taken up for a diagnostic laparoscopy with peritoneal biopsy. Histopathology revealed necrotizing granulomatous inflammation. However, AFB and fungal stains were negative. The ascitic fluid cytological analysis was suggestive of chronic inflammatory process. A pulmonologist opinion was obtained, and hence she was thereafter started on anti-tubercular therapy for 6 months. Coming to the discussion, India contributes to the highest burden of TB in the world, which is 40%. Of all cases, extrapulmonary TB comprises 15%. The sites include pleural, lymph nodes, spine, bone and joints, pericardium, meninges, CNS, oral cavity, breast and abdomen as well. A lack of a clear consensus on algorithms for diagnosis and hence also its non-contagious nature also are present. Diagnostic challenges include a variable sensitivity of Ziel-Nielsen staining, limited availability of fluorescence microscopy, long duration of solid culture growth, liquid culture requiring well-equipped laboratories, and limited availability of nucleic acid amplification, line probe assay, and gene expert. Conventional smear microscopy has a low sensitivity of 0 to 40%, and hence a negative result cannot exclude the presence of TB. Relatively inaccessible sites may produce paucibacillary tuberculosis. However, the sensitivity can be improved by using PCR. Although 6 months of standard ATT is generally considered adequate for most forms of extrapulmonary TB, longer treatment is suggested in case of meningeal or bone and joint TB. Coming to the role of surgery, a pericardiectomy is done for constrictive pericarditis in specific, or a placement of a ventricular peritoneal shunt for hydrocephalus secondary to meningeal TB. Other than these specific indications, the others are usually for diagnostic modalities. Coming to the conclusion, extrapulmonary TB manifestations cannot be ruled out as a differential diagnosis in endemic countries. In the absence of facilities for molecular diagnosis and mycobacterial culture, AFP demonstration with ancillary investigations are the cornerstone. Considering the very high TB prevalence in India, it should always remain a differential diagnosis. Thank you, sir. Sir, I'm unable to hear you.
Can you hear me?
Yes, sir.
Yeah, you have presented a nice series of these tuberculosis cases, but I want to ask you one thing. You said if would have kept some pre-operative photograph or operative photograph, it would have been nice. Number one. Okay. Anyway, I think you will do it in future. You are just starting your career.
Yes.
Okay. Just I want to ask you one question. A peritoneal tuberculosis, you have told all your diagnoses were not in favor of tuberculosis. You didn't get AB. Okay. And
Yes.
there's no biopsy, whatever you have taken, you didn't get anything. So how did you confirm your diagnosis that it was a tuberculosis?
Sir,
What you should have done, which you have not done?
ideally, we should have done an ESR and a MAN tool, sir.
Pardon?
Erythrocyte sedimentation.
Yes, sir. Yes, sir. Cannot give a positive diagnosis of peritoneal tuberculosis. Anyway, anything else?
We can do a gene expert.
How did you diagnose? Why you thought it was a cox only? Tuberculosis.
So based on the granulomatous inflammation and the history of loss of weight and loss of appetite and the absence of features of malignancy, with the help of the pulmonologist, we started the patient on.
No, you are a surgeon. You are a surgeon. Okay.
Yes, sir.
You are a surgeon. Why didn't you put one diagnostic lab? Why didn't you do? I would have loved to put a. If I would have suspected to be peritoneal tuberculosis, I would have put a laparoscope. I would have seen myself. I would have taken a photograph. I would have taken a biopsy.
We did, sir. It was only with the peritoneal biopsy that we got the answer as necrotizing granulomatous inflammation.
You didn't get any. Okay, fine.
From the biopsy samples, we did not identify or isolate the bacillus.
What is the commonest extra pulmonary tuberculosis?
So, tuberculous lymphadenitis.
You had got any cases in your?
We had got multiple cases, sir, but I did not include it in my series because I wanted to present rarer cases.
So, what are the ATT you gave to all these cases?
So, we gave rifampicin, isoniazid, pyrazinamide, and ethambutol.
4 drug combination
Yes,
for how many months?
for 6 months.
4 drugs.
Yes, sir.
All 4
First
drugs.
2 months, no, sir. First 2 months, 2 drugs, followed by all the drugs for 4 months.
Then why did you, tell that you are given ATT on dots basis?
Sir, some of the cases were older cases. So the
Older
oral
case.
ulcer case was an older case,
Okay.
which was under dots.
Okay. Thank you very much. And Dr.
Actually, nowadays the whole drugs are formed in the single capsule, single tablet.
Exactly.
Okay, then you give it is a daily basis also.
Yes.
And duration for extra pulmonary tuberculosis, what is the ideal duration we follow nowadays?
Now we give between 9 to 12 months.
Okay, 9 to 12 months. So, what are the stages of extrapulmonary tuberculosis? What are the 3 stages of extrapulmonary tuberculosis?
I'm not aware, sir.
But the 3 stages, no. First is there is a exposure, then there is a latent phase, then there is an active stage of tuberculosis. So there is a 3 stages. What are the common things is a lymph node and pleura and osteoarticular surfaces. This is the common area. But in your
Yes.
presentations, you are all rare presentation like a parotid abscess, like a tuberculosis, and there's a breast and also peritoneum. Okay, nice presentation and nice things. Okay, good. Congratulations. Thank you.
Thank you.
Good, Devas. Thank you very much. Any other presenter? Srinidhi,
Webcam, anything?
No, sir.
Nothing?
Two presenter is not present.
Ganesh is not there.
No.
That okay, fine.
That 2 presenter is one is evolution of TB as intestinal obstruction. The another one is the FNAC in thyroid. So that is a 3rd presenter and the 6th presenter is not there. Is correct?
Not there. Yeah.
Okay. Thank you.
We'll
Thank
stop.
you all.
We'll stop here.
Yes, sir. Yes, sir.
Thank you very much.
Functions,
That is
thank you.
second.
Thank you. Thank you, sir.
Okay.
Thank you.
Next
Thank
time.
you all presenters. Webcam. Thank you. Thank you. Thank you. Thanks.
Thank you very much.
Thank you. Thank you. Thank you. You're leaving now.
Thank you, sir.
Shiva Kumar, sir.
Yes, sir.
You're talking.
Nothing, sir. Nothing. That's it.
Okay, you can leave.
Okay. Thank you.
Good morning, sir.
Hey, good morning. Hello.
Yes, sir. Session will start, I think, 12:15.
Yes, session will start at 12:15. Huh?
Yes, sir.
Yeah, I am online through. No problem.
Okay, sir.
Hello.
Yes, sir.
Am I visible and audible?
Yes, sir. Yes, sir.
Okay, thank you. Should I rejoin at 12:15? Hello.
So, if you want to rejoin, you can do it, sir. Otherwise,
Or I can keep it in mute and
yes, sir.
stop video.
Mute.
ఇదేంటంటే 78 కొట్టమన్నారు సేమ్ ఆఫ్టర్ 1
ఇంకేం ఓపెన్ అవ్వలేదన్నా దీని అర్థం
Hello. It's 12:13. 12:15 will start. Sarangi sir.
Good afternoon. I think I'm the first speaker. I'm Dr. Shayak Chattawardhay from Sri Ramachandra Medical College.
Wait. Session not start.
Okay, fine. Should I share my screen?
Wait, sir.
Okay.
Janardhan sir. Hello, Janardhan sir.
Am I audible?
Yes, sir. Can you please introduce the first speaker, sir?
Dr. Sayak Chakrabarty. Sayak Chakrabarty.
Yes, sir. Yes, sir. I'm here, sir.
Yeah.
Good afternoon, sir. Yes, sir. I'll start, sir.
Shall we start the session?
Yeah, sure. You can start.
Okay. Good afternoon. I'm Dr. Shayak
Please
Chattawardhay
share
from.
your screen, sir. First, you
Yeah.
need to share your screen.
Yeah. Okay.
And you have only 7 minutes.
Okay. Thank you. So I'm Dr. Shayak Chattawardhay from SRMC Chennai, and my topic for today is ureteroscope-assisted laparoscopic transcystic CBD exploration, a viable alternative in choledocholitis. This was done under the guidance of my professor, Dr. C.D. Narayanan. So about 15% of people with gallstone develop stones in the common bile duct. The incidence is even higher in older ages, and 20 to 25% of patients older than 60 who have gallstone disease present with concurrent choledochal stones. It may result in complete or incomplete bile duct obstruction and manifest with cholangitis or gallstone pancreatitis. Choledocholitis is managed either by endoscopic sphincterotomy or surgical exploration. Studies have concluded that laparoscopic common bile duct exploration procedures are superior to sequential endoscopic treatment. And LCBD has been proven to be a safe, reliable, and effective single-stage procedure for the treatment for CBD stones. Successful stone clearance rates for LCBD range from 85 to 95%, with a morbidity of 4 to 16% and mortality of 0 to 2%. So the aim of my study was to explore the viability of laparoscopic cholecystectomy with laparoscopic transcystic CBD exploration as a genuine option in treatment of choledocholitis. And at the same time, it highlights the advantages of an ureteroscope-assisted LTCBD procedure. So we took a total of 3 patients with choledocholitis, 1 female and 2 males, who underwent LC plus LT-CBDE assisted with a semi-rigid ureteroscope between January 2017 to March 2017 in Department of General Surgery in Sri Ramachandra. Among these, only 1 patient had preoperative failed ERCP. The exclusion criteria for our cases was narrow or tortuous cystic duct, less than 3 millimeter, stone location proximal to cystic duct or CBD junction, and large stones greater than 10 millimeter. So patients were placed in supine position under general anesthesia, and port positions were similar to that of standard laparoscopic cholecystectomy. Ductotomy was made in the cystic duct, and semi-rigid ureteroscope was passed through the cystic duct. Multiple CBD stones were retrieved using Dormia basket, and biliary stent was placed. I'll show you a video to explain exactly how this was done. So first, callus dissection is done, as you can see here. And then a loop is tied at the neck of the gallbladder to make sure that the stones do not slip out during the exploration. The loop is being tightened right now. Then intraoperative cholangiogram is done. There's the green one is the cholangiogram catheter, which is placed over the Olsen's forceps, as you can see in the video. And the Olsen's forceps is now clamped and dye is injected. And there's the intraoperative cholangiogram done, and now the guide wire is being inserted. And now you can see that there's the Fogarty's balloon catheter, which is being inserted right now. That is used for dilatation of the cystic duct. It is usually placed at the junction of cystic and common bile duct for dilatation. It's being inflated right now. So now we remove the Fogarty's and we introduce the ureteroscope. The ureteroscope will be introduced along with the Dormia basket. There you go, the ureteroscope is going in. And in a moment, you'll see that the Dormia basket will come out with the stone in situ. There you can see that the stone is coming out with the Dormia basket. You can see the stone at the mount of the ureteroscope right now. Next, we're irrigating with warm saline. And finally, we are placing a stent. You can see the white one that's the stent pusher, which is being pushed in. This is usually done under C-arm guidance to check whether the stent is in position. And now the stent pusher is being removed. And finally, a check cholangiogram is being done on table under fluoroscopic guidance. And then we clip the cystic duct below the incision site. Usually we put 2 clips in, and then we clip the cystic artery. And finally, we proceed with a normal cholecystectomy. There you see the gallbladder being skeletonized and dissected off the bed. So now we'll just see the ureteroscopic view of how the stone is extracted. There you can see the black colored stone. And in a moment, there's the Dormia basket being, and you see the stone being extracted. So post-operative care and follow-up. In all patients, drains were kept in Morrison's pouch and were removed on 3rd post-operative day along with initiation of solid diet, and patients were discharged on the 5th post-operative day. Stents were removed after a month via endoscopy. None of the patients had any post-operative complications, and there was no mortality in our series. All patients had come for review on post-operative day 10 and after 3 weeks. In this study, the median age of participants was 60 years. The mean CVD diameter was 10 millimeter and mean cystic duct diameter was 5 millimeter. The Dormia basket extraction was done with biliary stent placement in all 3 cases. 100% stone clearance was achieved. Post-operatively, mean time to discharge was 5 days. No complications such as biliary stricture or bile leak was observed. So in conclusion, we can say that LT-CBDE plus LC negates the need for opening the CBD, decreasing biliary morbidity associated with choledochotomy. It eliminates the subsequent need for a T-tube and decreases the complications therewith and recurrence rates. Moreover, the use of a semi-rigid ureteroscope allows the use of a lithotripter to fragment large and impacted stones not possible with a regular choledocoscope. For mobile stones, a Dormia basket can be passed through the same ureteroscope to extract the calculus. The only limitation is the extreme surgical expertise and the adequate equipment required. These are my references. Thank you.
Okay, thank you, Dr. Sayak.
Thank you, sir.
Good presentation. Okay.
Thank you, sir. Thank you, sir.
But the problem is, just give me short answers. Why did you place stent when you have done a procedural cholangiogram? What is the need of putting stent?
Sir, post-procedure, if there is any development of any stricture or anything, that's why we place the stent, sir.
Because you have gone through the cystic duct and you have ligated the cystic duct beyond your incision site, and
Yes,
you have
sir.
done a post-procedure cholangiogram. You know the biliary tree of any stone.
Yes, sir.
Then why should there be any stricture, and where will be the stricture?
Because of intraoperative manipulation, sir. If there's any injury,
No, intraoperative manipulation you are doing within the CVD.
Yes, sir. Yes, sir.
Where will be the injury? And you are doing under the laparoscopy.
Yes, sir.
Okay.
Yes, sir. Yes, sir. Yes, sir.
Dr. Sayak,
Yes, sir.
CBD and biliary system.
Sir, I can't hear you, sir.
Sayak, am I audible?
Yes, sir. You're audible now, sir. Yes, sir. Tell me, sir.
Biliary system is a slow kinetic system.
Yes, sir.
Hello?
Yes, sir. Hello, sir. Yes,
biliary
sir.
system is a slow kinetic system. Kinetics are very slow in biliary system, unlike renal system.
Okay, sir.
Okay.
Okay, sir.
So you
Okay,
need
sir.
to decompress the dilated biliary system by means of a endo stent or by a T-tube drainage.
Okay, sir.
So you have to decompress it. That is the reason why you put a stent inside.
Okay, sir.
Okay, because if it's
Okay,
still
sir.
dilated, still there is stasis, and stasis is one of the common reasons for formation of stones.
Okay, sir. Okay, sir. Okay, sir. Okay, sir.
Okay,
Thank
it's
you, sir.
not because the complete going to form a structure or anything. Okay?
Okay, sir. Thank you, sir. Okay, sir.
Right, sir.
Okay, sir.
Okay, so if you have to go through the cystic duct, your prerequisite is that there will be the callots will be absolutely free, correct?
Yes, sir. Yes, sir.
What are you doing in chronic cholecystitis where there is adhesions and your cystic duct approach is little bit difficult?
Yes, sir. If it's not dilated more than 3 millimeters, it's a very difficult approach, sir. So
No,
in
it
that
can be
case,
dilated.
yeah.
It can be dilated, but there's adhesions at the callots there.
Yes, sir. Yes, sir. That will also be difficult, sir. That will
Is
be
it
difficult.
dilated?
In that case, we have to go for a choledochotomy, sir.
Okay, thank you.
Yes, sir. Yes, sir.
Dr. Madhavi, next speaker.
Yes,
Yeah,
sir.
you can move.
Good morning. Good afternoon, sir.
Hi, good afternoon.
Madhavi, please share your screen.
Yes, sir.
Hello,
So,
ma'am, share.
yes, yes. 1 minute. So, is my screen visible, sir?
Open your presentation. I think your bandwidth
You
is
have
low.
done it.
Yeah.
Okay. Is my screen visible, sir?
Yeah, go.
Good afternoon. Today, my topic is about efficacy of autologous platelet-rich fibrin in chronic non-healing ulcers in lower limb. Introduction. Chronic non-healing ulcers are defined as loss of skin and subcutaneous tissue on the leg or foot, which takes more than 6 weeks to heal. The prevalence of the leg ulcers is documented to vary between 0.18 to 1%. Venous, arterial, neuropathic, traumatic. Chronic wounds are characterized by a long inflammatory phase that hinders the regenerative wound healing. Standard treatment algorithm includes complete patient and wound assessment, history, physical examination, variety of diagnostic tests that determine the need for infection control, debridement. The treatment is often difficult in general association with higher recurrence rate. The aim of the study is to determine the efficacy of the PRF in chronic non-healing lower limb ulcers. The methods we used is the prospective study to study the efficacy of the PRF in epithelialization and wound reduction in the chronic wounds. 32 cases were compiled in the study, which was done in NRA General Hospital, Andhra Pradesh. Including inclusion criteria, age group of 18 to 80 years with long-standing non-healing ulcers, ulcers more than 6-week duration, patient HP is more than 10 gram per deciliter. Exclusion criteria, the patients with a known or suspected osteomyelitis, presence of cellulitis, peripheral vascular diseases, ischemia, gangrene, and the patient not willing for study. Preparation of materials. Under strict aseptic conditions, a 20 ml venous blood drawn and added with a red color vacutainer, which contains a clot activator. The first spin in the tube is centrifuged at 5000 RPM for 15 minutes to separate the red blood cells from the plasma. After the first spin, 3 layers are appeared. Bottom of the tube contains the red blood cells. Middle layer contains the buffy coat, which contains the platelets and leukocyte. Upper phase contains a clear solution of the platelet pool plasma. Again, it is centrifuged for 2000 RPM for 5 to 10 minutes. This is the picture showing the patient blood being drawn from the patient and centrifuged and applying it for the patient. Dressing techniques. Ulcer cleaning with a normal saline. PRF prepared from the patient's blood is injected to the edges of the ulcer and fibrin plug is placed directly over the ulcer. The dressing is kept for a period of 3 to 4 days depending is repeated every week for a period of 6 weeks. These were the wounds which we have done the PRF dressing.
Not audible.
After PRF dressing, the first wound showing after 6 PRF and the second is after the 4 PRF. Results. Out of 32 patients, 12 patients were 4 were anemic, 3 had proven osteomyelitis, 1 had waiting for the steady, and 1 had peripheral vascular disease. Age distribution and etiology of the ulcers. 18 to 35 years are 3 cases, 36 to 50 years are 11 cases, 51 to 65 are 5 cases, 66 to 80 are 1 case. On the etiology, diabetic are 7 cases, traumatic are 2, trophic is 9, and venous ulcers were 2. Sorry, the diagram of cases on the location of the ulcer, area, and the size of the ulcer after the PRF, second PRF, and third PRF. We have seen a very rapid decrease in the size. Discussion.
Voice is breaking, ma'am. Your network is down.
Cannot hear anything. Cannot ask any question to this candidate.
I request you both to look into the matter.
Sir, her network bandwidth is low.
Okay.
Actually, sir, I think she is the exit because
She-
of her bad network.
Okay.
So now,
Should we proceed with the next candidate or we'll wait?
maybe go to next, sir.
Yeah,
So,
definitely.
Sarangi sir,
Yeah.
go to the next participant.
Pardon?
Shall we go to the next patient, sir? That will be better. We'll not waste time.
I think we can go for the next candidate.
Yes, sir, correct. You are right. Dr. Ashwin.
Hello, sir. Can you
Dr.
hear me?
Ashwin, please present.
Yes, sir.
Please.
1 minute, sir. So is my presentation visible, sir?
Yeah.
Good afternoon. Today I'm going to present a paper under the guidance of Professor Naveen Alexander. My topic is laparoscopic transabdominal retromuscular hernia repair for ventral hernias, a cost-effective approach. So introduction, intraperitoneal onlay mesh repair has been popularized since 1993, and complications of IPOM and IPOM plus favors subluxation of mesh, need for a low-cost approach, a minimally invasive approach, and use of polypropylene mesh instead of biological mesh, and appropriate midline closure for anterior abdominal wall reconstruction. So laparoscopic transabdominal retromuscular hernia repair was proposed by Dr. Ashwin A. Masurkar, which conquers all these needs. Now, our objective of the study is our experience and short-term outcomes in laparoscopic transabdominal retromuscular hernia repair for ventral hernias, and it was done by a single surgeon in a single institute in South India. So the methods is, it's a single institute study in the Department of General Surgery in Sri Ramchandra Institute of Higher Education and Research. The total number of patients is 9, and the study period, it's an ongoing case series since November 2019. So here's a video of the technique. This is a case of epigastric hernia, and a 10 mm camera port is placed in the midline, and 2 5 mm camera poking ports are placed, following which the hernial sac is dissected, and as you can see, and the falciform ligament is also dissected, and the adhesions is released. Following which, a transverse incision of 8 centimeters is placed in the peritoneum posterior rectus sheath complex, 7 centimeter proximal to the upper edge of the hernial defect. Following which, the retrorectus space is clearly delineated as shown in the video, and using either monopolar cautery or ultrasound harmonic. And here the linea alba is also divided and dissected to delineate the hernial defect, as you can see. And here you can see superiorly the hernial defect, which has been delineated, and also the peritoneum posterior rectus sheath complex is dissected laterally up to the linea semilunaris, beyond which the neurovascular bundle is seen, and which should not be damaged. And the peritoneum posterior rectus sheath complex is hernial defect is closed using number 1 PDS a barbed suture, and the same is done for the superior defect using the same number 1 barbed PDS suture, polydioxanone suture. Following this gives us a good midline approximation of the defect, and also divarication of recti also can be corrected, thus giving a better abdominal wall reconstruction. Following which, appropriate sized mesh is placed in this rectorectus space, and it's fixed using transfacial sutures, and the peritoneum posterior rectus sheath complex as such is anchored to the anterior abdominal wall using tackers. So here's the port geometry for hernia defect in the epigastric. The port geometry is placed below the umbilicus, and for hernial defects in the lower midline and lateral, the ports are placed above the umbilicus as described. Now the results is the total number of patients were 9, and out of which 3 were male and 6 were female, with a mean BMI of 23 kilos per meter square, and out of which 4 were diabetic and 3 were hypertensive and 2 were habituated to smoking. And the defect size of the hernia was a mean length of 3.5 centimeters and a mean breadth of 2.8 centimeters, which was calculated, which was found using CT. And out of the 9 patients, 6 were incisional hernia, out of which the 2 of them were operated previously for LSCS, 1 for abdominal hysterectomy, 2 for open tubal ligation, and 1 was for appendectomy. And out of the 3 primary ventral hernia, 2 were of umbilical hernia and 1 was epigastric hernia. And the average operating time in minutes was 161.1 minutes, and the median length of stay was 2 days. And all the patients were started on soft solid diet on POD1, and there were no drains kept, and there were no intraoperative complications or conversion to open, and no postoperative complications also. The patients are followed up at 1 week, 1 month, and 3 month duration, and 2 patients complained of postoperative pain at 1 week follow-up, but they were conservatively managed. No clinical or ultrasound evidence of mesh infection, seroma, or recurrence. So discussion is Kaufman et al. Reported intracutaneous fistula formation following intraperitoneal polypropylene mesh placement. So this gave a rise to the era of IPOM and IPOM plus, where we use a composite mesh which was layered by a biodegradable or reabsorbable coating on one side, avoiding bowel mesh contact. But the cost of these meshes were 10 times that of the polypropylene mesh. And use of balloon trocars were also popularized in TEP and ETEP procedures, which are also expensive. So advantages of this procedure is that use of polypropylene mesh instead of biological composite mesh, which reduces the economic of the surgery, and balloon trocars can be avoided, and transfacial sutures are used instead of tackers for mesh fixation. And the release of pneumoperitoneum will obliterate the retrorectus space created for the mesh placement, and any rise in the intra-abdominal pressure will further sandwich the mesh in between the two layers. And the same port geometry can be used in cases of larger hernial defects where if the midline kosher is not possible, myofascial medialization can be done using posterior component separation for a better abdominal wall reconstruction. And the mesh is placed in the sublay which provides a great tissue ingrowth as compared to others. And laparoscopically inadequately reduces all complications related to open hernia surgeries, such as surgical site infection, bleeding, and seroma. And so the retrorectus space delineation provides a very clear anatomy and also a large working space as compared to TEP or ETEP. And it evidently conquers the same working space as dissected in the open Reeve-Stoppa procedure. Since we enter the peritoneum, we can assess the content of the hernia sac and reduce it in a controlled manner. And furthermore, the same three-port geometry can be used for midline closure and myofascial medialization, providing a better abdominal wall reconstruction. The drawbacks of the study is that it's a time-consuming procedure, but it's not inordinately so as compared to TEP or ETEP or IPOM plus. And yes, sir.
Okay, you can just conclude.
Yes, sir. So 1 minute.
Just conclude.
Yes, sir. So we are placing a polypropylene mesh in the sublay in the rectorectus space, and it's a natural barrier that is the peritoneum posterior rectus sheath in comparison to the composite mesh. So there's no the complications of IPOM and is conquered in this, and the ergonomics of the port placement is of high value in procedure, which has to be proper. And laparoscopic transabdominal retromuscular repair is a safe and a cost-effective way to repair in Indian population, sir.
Okay, thank you. Nice presentation.
Yes,
good
sir.
job. Just tell me two things. Are you assessing the hernial size preoperatively or paraoperatively?
Yes, sir. Preoperatively, we are assessing, sir, using CT, sir. CT of the abdomen, sir.
So CT abdomen is must for all patients?
Sir, it's not must. This is
What is the advantage of CT abdomen over ultrasound? Dr. Ashwin?
Hello, sir.
What is the advantage of CT abdomen over ultrasound abdomen?
So we can clearly delineate like the hernial defect size and also see the content of the hernia, if it is a bowel or and also assess the viability of the bowel. So which can also help us to see which procedure to proceed with, sir.
Basically, CT abdomen is done to assess yourself the number of defects later on the film, because ultrasound will give you just a report, and
Yes,
probably you wouldn't see the defects as such. But
Yes,
in a CT scan, if the radiologist misses one or two small defects, you can identify yourself on the film. So that film is very essential to understand more than one defect and size of
multiple
the defect.
defects. Yes, sir.
Yeah,
Multiple defects.
yeah,
and
that's
size
the advantage. Anyway, nice presentation. I think Sarangi sir will continue further. Sarangi sir?
Does the size of your hernial orifice influence the type of closure?
Influence the type of what, sir? Closure.
Yes.
So in this procedure as such, we are having we have a maximum of 8 centimeters in length and 5 centimeters in breadth, sir. So this was the cutoff which we have got from a parent article which we had previously studied, sir, by Ashwin Maruskar. So we've been following that, sir.
That is the size of the defect you have taken. That's the size of the defect.
That's the maximum size, sir. Maximum length is 8 centimeters and breadth is 5 centimeters, sir.
And what is the size of the mesh you are using?
Sir, we'll use a 30 into 30 polypropylene mesh, sir. It depends on the hernial defect size. After measuring it using after medialization and the creation of the retrorectus space, we will decide upon the mesh size, sir. And
time, sir. Time, Sarangi sir.
Thank you.
Yeah.
Okay. Thank you, sir.
Thank you, Ashwin. Sir, you can move on to the next presenter, sir. Sarangi sir, please continue, sir.
Yeah, definitely.
Yes.
Is there any other panelist?
Yes, sir. Can you see my screen, sir?
Yeah.
Yes, sir.
This is Dr. Rohit Kate from NKPCM Slagpur. My topic is predictive factors of amputation in diabetic foot ulcers and analytical observational studies. Diabetes is a global epidemic and leading cause of death by disease. According to International Diabetes Federation, the prevalence of diabetes is about 425 million people worldwide, or 8.8% of the adults. In India, an estimated 72.9 million people suffer from diabetes. This figure is predicted to increase to 134.3 million. According to World Health Organization and the International Working Group of the diabetic foot is defined as a foot of diabetic patients with ulceration, infection, and or destruction of the deep tissues associated with neurological abnormalities and various degrees of peripheral vascular disease in the lower limb. The development of foot ulcers is one of the major complications of diabetes. That is in 15 to 25% of the patients. Diabetic foot ulceration is the leading cause of non-traumatic lower limb amputations. More than half of the diabetic foot ulcers become infected, which leads to higher amputation rates in the diabetic population. Early diagnosis and management of foot infections are essential because there is increased prevalence and is related health burden among patients with diabetes. Therefore, knowledge of these factors is crucial to develop diagnostic, management, and treatment protocols for the prevention of lower extremity amputation. A number of foot ulcer classification systems, for example, the Wagner system, have been used to categorize ulcer. There is one more system, the diabetic ulcer severity score. It is one of the latest wound system for classification, which is being evaluated. The International Working Group of Diabetic Foot developed the perfusion, extent, depth, infection, and sensation, that is the PDIS classification, in which all the diabetic foot ulcers are classified according to the 5 categories. This study is going to help us to identify the predictive factors of amputation of diabetic foot ulcers and the role of the diabetic ulcer severity score, Wagner scale, and the PDIS classification in predicting the amputation in diabetic foot patients. Aims and objective of the study were to study the predictive factors of amputation in diabetic foot patients and to evaluate the 3 scores: the diabetic ulcer severity score, the Wagner scale, and the PDIS classification. The study design, it was a tertiary care-based hospital analytical observational study. All patients fitting into the inclusion criteria, which was patients from foot ulcers with age more than 18 years, symptoms of diabetes plus random blood sugars more than 200, fasting of more than 126, and 2-hour plasma glucose level more than 200. Patients excluded were venous ulcers in patients with diabetes mellitus, non-diabetic neuropathic ulcers, ulcers above the ankle. And the study factors were demographic factors, the clinical features, laboratory investigations, and imaging investigations. The outcome was out of the 95 patients, 39 patients, that is 41% of the patients had a lower extremity amputation. Among the patients who required amputation, 16 underwent below knee amputation and 23 underwent disarticulation. Results. The mean age of the patients was about 55.57 years. Majority of the patients were more than 50 years. And the youngest was 31-year-old, and the oldest was a 75-year-old patient. Gender, out of the 95 patients, 78, that is 82, were males. 82% were males. History of trauma, 61 patients out of 95, that is 64 patients had a history of trauma. Autonomic neuropathy was present in 77.8% of patients. Ankle brachial index was calculated in all the patients. The mean ankle brachial index was 0.7. The minimum being 0.2 and the maximum being 1.3. Peripheral pulsations were in 62.5% of the patients, both dorsalis pedis artery and posterior tibial artery pulsations were palpable, whereas in 24 patients, either one or both of them were not palpable. The results of the Wagner grading, the patients were arbitrarily divided into 2 groups according to the Wagner grading system. Lower grade was from 0 to 2 and a higher grade was from 3 to 5. It was observed that out of 51 patients in the higher grade, 36 patients underwent amputation, while out of the 44 patients in the lower grade, only 3 patients underwent amputation. These results were significant statistically, showing amputation rate in higher grade, that is more than Wagner grade 3 and above. This was the findings. The PDIS score was calculated in all the patients. Minimum score was of 4 and the maximum was of 12. Patients were grouped in high and low PDIS score. Low PDIS score is between 0 to 7 and high PDIS score is between 8 to 12. 42 of our patients were in high score, that is 44%, and 53 were in the low PDIS score. Out of the 42 patients who had high PDIS score, 35 required amputations, that is 83%. As you can see, patients above a score of more than 8 required the maximum number of amputations. Only 4 amputations were done in patients who had a PDIS score less than 7. the diabetic ulcer severity score, there was a significant association between the score and amputation. With an increase in the score, there was increase in the amputation rate. Out of the 32 patients with a score of 1 or 2, only 6 required amputation. While with a score of 3, 31 patients had a score of 3. Out of them, 18 underwent amputation. That is 58% of them under amputation. And with the score of 4, 17 patients, 15 out of 17 patients underwent amputation with a percentage of 88%. Conclusion: in the present study, we can conclude that PD score more than 7 and a DUS score more than 3 and a higher Wagner grade are significant risk factors for amputation in diabetic foot ulcer. Thank you.
Okay, thank you, Dr. Rohit. Nice presentation. But two things I like to share with you, that your presentation slide is full of your words and write-ups. Usually the presentation slides should not be such a full with words and write-ups. It should be less so that the audience whom you are presenting, they can read your slide as well as they can listen to you.
Yes.
Okay. Number two, have you compared your result with published series? You have not shown any.
Sir. Yes, sir. I have compared them in my. This is also my thesis topic, sir. So I have compared them with various studies, and I have found 2 studies which show similar results with regarding the PD classification system, and 1 study regarding the Wagner classification system.
Yes. See, Wagner 3 and above incidence of amputation is high. That is already well established.
Yes, sir.
Okay, so what was the purpose of your study? When the already established publications has proven, then why did you go for your study again?
Sir, diabetic ulcer severity score has not been validated till yet. So we wanted to compare its sensitivity with the other scores.
But that sensitivity and specificity of that particular score vis-a-vis the other score or comparison to the other scores you have not shown.
Sir, it is comparable. A score of more than 3 had almost every patient almost had amputation of with a score of more than 3 in diabetic ulcer severity.
That comparison or sensitivity of DUSS has not been projected in your slide.
Yes, sir.
Number 2, and when the patient has gotten a BI of 0.2.
Yes, sir.
Okay, the patient is having critical limb ischemia.
Yes, sir.
So, have you thought of doing any revascularization procedure before amputation, or you straight away went for amputation without thinking of any doing revascularization procedure?
Sir, as revascularization procedures are not available in our institute, and the patient was not ready to be transferred to another institute, and the patient had landed up in septicemia, so a decision to do an amputation was done.
Facility not available in the institute. Actually,
yes, sir, ideally the patient should have undergone a revascularization procedure. Sir.
Okay, so is there any indication of doing pre-amputation revascularization in the patient's diabetic foot with critical limb ischemia?
Yes, sir, they will show better result after the amputation about the stump. There won't be any less chances of stump necrosis or infection in the amputation site.
So you'll do revascularization before amputation or after amputation?
Before, sir.
Okay, thank you. I think your time is up. Thank you, Dr. Rohit.
Thank you, sir. Thank you.
Okay, now we can proceed to the next presenter.
Sir, Varun sir, please share your screen.
Good afternoon, sir.
Hello?
Yes, sir. Yes, I'm sharing my screen, sir.
Okay.
Sir, is my screen visible, sir?
Yeah, your screen is visible.
Sir, good afternoon, sir. This is Dr. Varun Prakash from Meenakshi Medical College from Chennai, sir, Kanchipuram. My topic for presentation is procalcitonin as a diagnostic marker for sepsis and antibiotic therapy. Under the guidance of my professor, Dr. Ganesan, we did it in Kanchipuram, sir. Septic response is a leading contributory factor for morbidity and mortality, especially in intensive care settings. Accurate identification of sepsis etiology in patients admitted to the emergency department is often unattainable, largely because the infections can have minimal or even no symptoms or signs. An accurate, readily available test for bacteremia would greatly facilitate medical decision making for septic patients. Established biomarkers of inflammation, leukocytes, C-reactive protein may often be influenced by parameters other than infection. Positive bacteriological results may be caused by contamination, and negative results do not exclude sepsis. Procalcitonin was found to be a promising biomarker of sepsis and can provide early and valuable information before culture results are available. So actual mechanism is not clear, but the mechanism which was elicited in literature was the bacterial lipopolysaccharides and sepsis release cytokines modulate the liver and peripheral blood mononuclear cells to produce procalcitonin. Microbial infection induces the elevated expression of calcitonin 1 gene, followed by the release of procalcitonin product, which is correlated with severity of disease and mortality. So procalcitonin as a biomarker proved successfully its clinical usefulness in determining the presence of sepsis. An algorithm based on serial measurements of PCT can reduce the antibiotic exposure in septic patients. According to the level of serum PCT, therapeutic decision in patients can be made. So the objectives which we wanted to do was to ascertain possible diagnostic role of procalcitonin, to compare serum procalcitonin with CRP, which is the currently the best marker for sepsis, and total count as well, to identify the most sensitive and specific indicator. To study the outcome of study population with early diagnosis using procalcitonin as a biomarker. We used it from January 2019 to May 2020. Universal sampling was done. 60 patients were taken. It was done in Meenakshi Medical College Hospital and Research Institute. Inclusion criteria: patients who are diagnosed as septicemia, severe trauma, burns, major surgery, cellulitis, and prolonged shock. Exclusion criteria: children less than 1 year and immunocompromised state and collagen vascular disorder were not taken. So we did with demographic age, sex, clinical and comorbidity profile, CRP levels were taken, PCT were taken on day 1, 7, and 28. Microbiological culture was taken, length of stay in ICU and hospital, and outcome of patients were also studied. So statistical analysis, we use statistics software, student t-test and Wilcoxon rank test was used. P less than 0.05 was considered statistically significant. Then this is the classification based on the age, gender, and comorbidities. So sepsis we differentiated into sepsis, severe sepsis, and septic shock. Sepsis was more around 52%, severe sepsis around 35%, and septic shock was 13%. So distribution was more of respiratory, and as we have a more advanced CTVS department, more respiratory tract infection and more respiratory sepsis was there. UTI next, and cellulitis was more with the diabetic department. And then culture growth, when we did more of Acinetobacter subcurrents and Staphylococcus aureus was taken. E. coli and Haemophilus influenza were following up next. So this sepsis, severe sepsis, and septic shock, total number of death and survived I have given. More total number of death is associated with severe sepsis. And then this is procalcitonin. Procalcitonin, the variation in procalcitonin with sepsis, severe sepsis, and septic shock is significant while compared to CRP, which is almost along the same line. Then death and survivors and non-survivors, the procalcitonin level, if it is more than 7 on the day of admission, the probability of death is extremely high. Whereas if the procalcitonin level on admission, if it is low, the patient is more likely to survive. So this is serum ROC curve. If you can see 0.729 area under the curve. So under this curve, this is for procalcitonin, and this is for C-reactive proteins. If you can see, C-reactive procalcitonin has more sensitivity and specificity for sepsis in comparison to C-reactive protein. So this is on the day of admission. If procalcitonin level is greater than 7 nanogram per ml, the value, the patient survival and sepsis mortality is significantly very high. So more than half of the patient had sepsis, while 13% of the patients were in septic shock. So these are the results, description, and conclusion. Serum procalcitonin done once at the time of admission was proven to be very good. Cost effectiveness for early identification for sepsis, better than CRP values and cultures and total count. serum procalcitonin can reduce the antibiotic exposure in septic patients, and it is also used as a so procalcitonin at the time greater than or equal to 7 nanogram per ml. It is used for identification of mortality risk and help improve the treatment. So finally, septic shock, severe sepsis. So normal value is from 0.1 to 0.49. If it is more than 0.49, 0.5, it leads to sepsis, and more than 2, it's severe sepsis. And above 2, around 10 nanogram per ml, it is goes for septic shock. So we planned from 0.1 to less than 0.1, we didn't give antibiotics. From 0.1 to 0.25, antibiotics was not encouraged. Above 0.25, we started the patient on antibiotics. We started him, and the results were very promising, and we were able to have a good outcome, and we could judiciously use the antibiotics. So these are the references, sir. So to conclude, procalcitonin has a greater advantage over total count and C-reactive protein. Thank you, sir.
Varun, please go to your conclusion slide.
Yes, sir. Yes, sir.
Let's see. Serum procalcitonin done once at the time of admission was proved to be very good, cost-effective biomarker. I agree. For the early identification of sepsis,
Yes,
I
sir.
do
Yes,
agree.
sir.
Better than CRP values, but
Yes, sir.
not better than culture.
No,
Culture
sir.
is the gold standard. Maybe
Sir,
early. Early
let
is
me,
okay.
sir, the thing I wanted to think was culture will take 3 days, sir, for us to get the culture result.
Early, I agree.
Yes,
Early,
sir.
I
Yes, sir.
agree.
Yes, sir. That's right, sir. At the time, so earlier treatment to start up procalcitonin has slightly little bit significance, and then
Still, procalcitonin is also a non-specific marker, whereas
yes, sir.
culture is a specific marker.
Yes, sir.
Right?
Yes, sir.
And
The
what way it was better than CRP levels?
Yes, sir. The way is CRP takes time to settle down than procalcitonin, sir.
Yes.
If there is a severe sepsis, procalcitonin level will shoot up, sir, to around 7 or 8. In the meantime, CRP levels.
Procalcitonin appears early.
Yes, and
it comes down also early.
Sir.
So it is important for monitoring of the treatment.
Yes, sir. So we
because
can.
CRP will come down later in time.
Yes, sir.
Right. So Sarangi, sir.
Yeah, exactly. I was coming back to that. It cannot replace your culture, number one.
Yes, sir.
So depending upon, irrespective of the value of your procalcitonin, in a patient with severe sepsis or septic shock, you have to start antibiotics.
Yes, sir.
Okay. Number 3, your modification of your antibiotics will depend upon the culture result.
Yes, sir.
Right. So procalcitonin cannot replace your culture.
Yes, sir.
But definitely the predictive value and for follow-up of the patients, as a marker, it has got a definite role. But okay, it can be complementary to the culture, but it cannot be supplementary to a culture.
No, sir. Hand in hand, can be used as a starting point, sir. Before culture results come, we can use this as a way to start the treatment while we are waiting for the culture results.
Yeah, exactly. You can identify early sepsis.
Identify early
and start
sepsis.
antibiotics based on your local resistant patterns.
Yes.
Right? Right.
Yes.
Thank you. Well
Thank
presented.
you. Thank you, sir. Thank you very much.
And the antibiotic as per the institutional protocol, and you assess the severity of the sepsis.
Yes, sir. Yes, sir.
Okay. Okay. Thank you. I think it's a good presentation.
Yeah, good one.
Thank you, sir.
Thank you. Thank you, Dr. Varun.
Thank you very much, sir. Thank you, sir.
The last speaker.
Not available, sir.
Not available. Shalim? Okay. The second speaker, Madhavi? Will she
Not
continue? Or shall we
available,
close?
sir.
Could you connect with her?
Sir, not picking my phone.
Okay. Shall we end the session?
I think if there is no other speaker, we can conclude now.
I think, sir, wait for 5 minutes.
Okay, fine. We can do that. We have got time.
Are you trying to contact the last speaker?
Yes, sir. Call again.
Please call again.
So last presenter is not picking my phone. I think Madhvi ma'am is joined 1 or 2 minutes.
She's joining?
Yeah, sir.
Okay. Hello. Hello.
Yes, sir.
How much time she will take?
Sir, session end time is 1:15. Now it's 1:06.
Will she be able to complete her presentation?
So she's not picking my phone again.
Then I think we can call it off.
Okay,
No,
sir.
sir. Session time is till 1:15.
Okay, okay.
So it's better we wait till 1:15.
Better wait till now.
At least till 1:10. She's the last speaker.
No problem. We can wait. Was there any other panelist or Dr. Janardhan?
Pardon, sir?
Was there any other panelist?
I don't know. So CRK sir came in between and he went away. Only both of us, I think.
Okay. No problem.
also not making my phone. I called 4 to 5 times, but not picking.
Sir, Sarangi sir, shall we close?
I think we can call it off.
Okay, sir. It's 1:10. Our time is lost.
Yeah.
Thank you, sir. Thank you so much.
Thank you. Thank you so much.
Thank you, sir.
Good afternoon, sir.
Hello,
Good
sir.
afternoon.
Hello, sir.
Yes, sir.
Shall I start, sir?
Yeah, please. Who are the others?
Dr. Sarvesha,
Can you see
sir,
my screen?
session will start 1:30. Nikhil, sir, can you
Yeah.
please stop sharing?
Okay, okay.
You need to introduce first the speaker, sir. 128 or 127.
Okay, sir.
127, huh? Okay, okay. I'll join at that time.
Yes, sir.
Okay.
You join, sir. Dr. Sarvesha, sir.
Yes.
Sir, please introduce first speaker.
Yeah, I am Dr. Sarvesh Rajaras, working in Mysore district, Hunsur. I am a life member of ASI. I am a senior specialist and administrative medical officer of my hospital.
Good afternoon, sir.
Yeah.
Shall I start, sir?
Yes, please.
Yes. Good afternoon, one and all. I would like to start my presentation with a quote. Excellence is the unlimited ability to improve the quality of what you have to offer to yourself and others. As rightly said by the famous basketballer Rick Pitino, we should strive to offer the best possible treatment to our patients. So that brings us to the question, which is better? Polypropylene versus polygalactine sutures for mesh fixation in inguinal hernia repair. This study was done under the guidance of Dr. A.S. Gopte, and I'm Dr. Nikhil, final year PG from JNMC Belgavi. Coming to the introduction, inguinal hernia is the most frequently occurring type of hernia globally. 75% of all hernias of abdominal wall. It accounts for 10 to 15% of all surgeries, and it is second only to appendectomy in terms of most frequently done surgical procedures. For ages now, long-term evaluation of the results of hernia repair focused on post-operative pain as well as recurrence rates. Chronic groin pain, that is inguinal hernia, post-hernioplasty can be defined as the pain lasting for more than 3 months post-surgery, and the incidence ranges from 0 to a whopping 62%. The basic mechanism of pain after surgery still needs research. It could be due to nerve damage, type of mesh, or even the type of suture material, and this has to be studied in depth. So we hypothesize that the use of polygalactine for mesh fixation lessens the severity and decrease of rate of chronic pain compared to polypropylene sutures. And so we compared the effectiveness in reducing the post-operative pain and also complications like seroma and hematoma. Coming to the methods, this is it's a single-blinded randomized control trial, and a period of 1 year from January 2019 to December 2019. It was done in the Department of General Surgery in Dr. Prabhakar Kore Hospital attached to the JNMC Belgaum. And the sample size was total of 60 patients, with each group having 30 patients each, and group A is the mesh is fixed with Vicryl sutures, and group B the mesh is fixed with Prolene sutures. The inclusion criteria are the unilateral or bilateral inguinal hernia, primary inguinal hernia, and uncomplicated inguinal hernia. Exclusion is irreducible hernias, bleeding disorders, patient with anticoagulant treatment, pregnancy, emergency repair, HIV, HPCH, positive patients. And the randomization is the snooze method. The outcome variables. So the pain was assessed with visual analog score ranging from 0 to 10. 0 as no pain, 10 as maximum pain, and the range between 0 and 3 was categorized as mild, 4 to 6 as moderate, and 7 onwards it was categorized as severe. And all the patients were given as the same analgesia post-operatively, and post-operative complications such as seroma, hematoma were followed on day 1, day 3, day 7, and 3rd month post-operatively. So the results, as we can see, on the post-operative days of 1 and 3, the percentage of patients having mild and moderate pain is higher in Prolene group as compared to the Vicryl group. And but on day 7 and on the 3rd month of the post-operative day, the percentage of patients experiencing pain in Vicryl was significantly lower than the Prolene group. Even the percentage of patients developing common complications such as seroma and hematoma were comparatively less in Vicryl group. So our study clearly showed that the third and fourth follow-up of the pain scores were significantly less compared to the proline group, and even the incidence of seroma and hematoma slightly less in the polygalactin group. So the polygalactin suture is a braided multifilament coated with polymer, copolymer of lactide and glycolide. Lactide slows down the loss of tensile strength, and the calcium stearate coating permits easy passage of the tissues and precise knotting placement. So the nature of the suture material, which leads to the shorter tissue reaction, in turn lesser tissue damage and hence lower incidence of complications. Surgeon is the most important prognostic factor for any surgery. So we also analyzed few surgeon factors such as operative time and ease of surgery. And we found out that the operative time was marginally less in Vicryl group, that is 86.6%. And surgeons felt that the Vicryl was easier to fix than the proline sutures. So the delayed resolution of post-operative pain as well as the presence of complications with proline suture usage, patient had to stay for a longer duration in the hospital or return to the doctor due to some complications. So I would like to conclude that by saying the polygalactin suture material to fix the mesh in Lichtenstein tension-free hernioplasty is a simple, safe, as well as effective alternate to the conventional usage of polypropylene sutures. Thank you.
So you done your presentation?
Yes, sir.
Had you done?
Hello, sir.
So had you done your presentation?
Yes, sir. I'm done with my presentation.
Dr. Sarvesha.
What was the infection rate in your this one?
Sir, in fact, we did not observe any infection in either of the groups, sir. The surgical site infection, I mean, and we have not quantified it also.
Did you observe any recurrence in your this one? It's only for 3
Sir,
months.
our follow-up duration was only for 3 months, sir. We did not observe any recurrence, sir, in the 3 months.
Okay.
Yes, sir. Thank you, sir.
So please announce next speaker. Sir, please announce the next presenter. You are muted, sir. Dr. Akhila.
Yeah.
Dr. Akhila Krishnamurthy.
Yes, sir. I'm present here.
Please share your screen.
Yes, sir. So there's some getting some video glitching, so I'm not able to start my video. Can I go ahead, sir?
Done.
Okay. Good afternoon, everybody. I'm Dr. Akhila from Bangalore MEJ MCRH. I'll be presenting a paper topic today on analysis of factors influencing early hypocalcemia development following thyroid surgery in a single center in a rural setup. Introduction. The term thyroid is derived from the Greek description of a shield-shaped gland in the anterior neck, also known as thyroides. Goiters, from the Latin word gutter, is also defined as an enlargement of the thyroid, have been recognized since 2700 BC, even though the thyroid gland was not documented as such until the Renaissance period. Early surgical approaches to thyroid masses had extremely high complication and mortality rates. In the late 19th century, two people revolutionized understanding and treatment of thyroid diseases. Billroth and Cocker established large clinics in Europe and applied skilled surgical technique combined with newer anesthetic and antiseptic principles. Their surgery results proved the safety and efficacy of thyroid surgery for benign and malignant diseases. Calcium is the most abundant cation in human beings and has several crucial functions. Extracellular calcium levels are 10,000 times fold higher than intracellular levels, and both are tightly controlled. Parathyroid hormone secretion is also stimulated by low levels of 1,25-dihydroxyvitamin D, catecholamines, and hypomagnesemia. Parathyroid hormone functions to regulate calcium levels via its actions on three target organs: the bone, kidney, and the gut. Calcitonin is produced by thyroid C cells and functions as an antihypercalcemic hormone by inhibiting osteoclast-mediated bone resorption. Calcitonin plays a minimal, if any, role in the regulation of calcium levels in the humans. However, it is very useful as a marker of medullary thyroid cancer and in treating acute hypercalcemic crisis. Thyroid surgery, total or near total thyroidectomy, can lead to serious complications, including transient or permanent caudal palsy or severe bleeding. However, hypocalcemia is the most frequent complication after thyroid surgery. Transient hypocalcemia frequently complicates post-operative care of patients who have undergone thyroid surgery. Post-thyroidectomy hypocalcemia arises because of parathyroid removal, devascularization, and damage, which induce a state of transient or it may lead to permanent hypoparathyroidism. Additional mechanisms such as vitamin E deficiency and acute increase in calcitonin serum levels because of gland handling during surgery or an hungry bone syndrome are also believed to contribute to this. A sound knowledge of the anatomy of the thyroid and parathyroid glands is nearly effective in decrease in incidence of postoperative hypocalcemia. With increasing parathyroid preservation technique, the incident rates have come down. Yet, the transient hypocalcemia ranges between 6.9% to 49% of patients who have undergone thyroid surgeries. The ability of the surgeon to predict the onset of post-thyroidectomy hypocalcemia is vital for post-op management. Early detection of any risk of developing hypocalcemia will reduce the duration of hospital stay. When hypocalcemia is predicted, prophylactic calcium and vitamin D supplements can help in prevention of hypocalcemia symptoms. Various studies have been done to identify the risk factors for early hypocalcemia development after thyroid surgery with varied results. Postoperative hypocalcemia remains a clinical challenge for thyroid surgeons because of its frequency and limited preoperative predictive factors. Coming to methods, retrospectively, we have analyzed the data of 50 patients undergoing thyroid surgery at the Department of General Surgery at MVJMC Medical College and Research Hospital between the July 2019 and June 2020. All surgeries were performed by the same surgical team experienced in endocrine surgery. We have included all the patients undergoing thyroid surgeries regardless of the surgical indication for malignant or benign pathology. We have considered the presence of early hypocalcemia for serum calcium levels lower than 8 mg per deciliter measured 24 hours after surgery. We have excluded patients undergoing thyroid surgery during considered period whose postoperative calcium data were incomplete, patients with concomitant primary hyperparathyroidism, and patients undergoing a thyroidectomy associated with neck dissection. The following variables were analyzed: preoperative variables, gender, further dividing the female population in pre and postmenopausal groups, considering age of 50 years as a limit between the two, and age was divided into 4 groups: age less than 40, 40 to 50, 50 to 60, and more than 60. Glandular hyperfunction, preoperative diagnosis as benign and malignant or suspected malignancy, preoperative serum calcium levels, preoperative serum parathyroid hormone levels, and comorbidities such as diabetes and hypertension. Surgical procedures, type of surgery performed, total or versus lobectomy, surgical approach to benign pathology versus malignant pathology, and number of parathyroid glands visualized by the surgeon during the surgery. Postoperative variables, postoperative serum calcium levels 24 hours after surgery, variations in perioperative calcium levels, difference between the preoperative and postoperative calcium levels, and definitive histological examination report and presence of thyroiditis based on histopathology reports. Depending on the early hypocalcemia evidence, patients are divided into 2 groups and were compared considering analyzed variables, attempting to highlight any statistically significant correlation between individual variables and early hypocalcemia development. Statistical data analysis were performed using SPSS version 20.0 to compare parametric variables of Pearson chi-square test or Fisher's exact test, and to compare non-parametric variables student t-test or man-Whitney U test. Level of statistical significance was determined at p-value less than 0.05. We analyzed the data of about 50 patients that underwent thyroid surgery. There were 40 women and 10 men with the mean age of 54.65 years. Patients' demographic operative details and are reported in table. Explaining the table, by analyzing patients' the mean age group, the patient developed early hypocalcemia, shows a mean age of 55 years, and with the mean age group of being 13 years. There was no statistically significant difference between the two groups. Patients of both the groups were further subdivided into 4 age groups with 40 years, patients under 40 years, and N being 7 people, 3 out of 7 cases developed early hypocalcemia. Patients between 40 to 50 years developed early hypocalcemia in 43.3%. This suggests that there is no any statistically significant difference between the different age groups, confirming the absence of correlation between age and development of early hypocalcemia. By analyzing the male and female population, there was no statistical significant difference between these two groups because the p-value is less than 0.0001. Among the men included in the study, 2 out of 10 developed early hypocalcemia, while women with was N40, 17 out of 40 developed early hypocalcemia, therefore showing female gender appears to be predisposing factor for early hypocalcemia development. However, there is no any statistical significance in the subset of pre and post menopausal women among the female population. Coming to a correlation between the perioperative early hypocalcemia development, the mean decrease in serum calcium was 1.67.
The time is up.
Okay. So finally, I just want to conclude saying that there is the early hypocalcemia development factors associated are usually female gender and the risk of prior the surgery, what was the serum calcium level and how many glands, parathyroid glands were handled and how it is going to affect during the surgery.
Sir, please start the question.
Yeah, first of all, you should have finished in time. Conclusion also should have been there. See, male is to female.
Yes, sir.
What was the main cause in this one? Hypocalcemia.
So, main cause. We had only 10 meals out of out of 50 patients. There were only 10 meals, sir.
Yeah.
So that it's were comparatively less when compared to the total number of females we have studied.
Yeah, you didn't specify in which surgery you had the hypocalcemia because you had mentioned that one total thyroidectomy.
Yes, sir. Total thyroidectomy versus lobectomy. In that, total thyroidectomy showed signs of development of early hypocalcemia more than lobectomy.
Yeah, how many of them had the parathyroid also along with the thyroid?
So, we had almost 17 of them, sir.
17 had parathyroidectomy also.
Yes, sir.
Okay, ma'am.
Okay, sir. Thank you, sir.
So Dr. Rajkumar Singh is not joined. Move to Dr. Harish.
Hello. Hello.
Hello, who is the next one?
Sir, I am audible. Dr. Harish.
Yeah, you are. Yeah.
Yeah, sir.
Can you give me 2 minutes time?
Yeah, okay, sir.
Yeah. ಏನಿಲ್ಲ ಈಗ ಭಾಸ್ಕರ ಬಂದಿದ್ದ ಜೊತೆ ಬಂದಿದ್ದೆ ನಮ್ ಯಾರ್ ನಗರ ಭಾಸ್ಕರ ಅಲ್ಲ ಬಂದಿದ್ದೆ ಆಮೇಲೆ ನೋಡಿದ್ರೆ ಇದಕ್ಕೆ ನಿಮಗೆ ಚೇರ್ ಪರ್ಸನ್ ಹಾಕ್ಬಿಟ್ಟಿದ್ರು ಪೇಪರ್ ಪ್ರೆಸೆಂಟೇಷನ್ ಹಂಗೆ ಇಟ್ಕೊಂಡು ಸಡನ್ ಆಗಿ ಹೇಳಿದ್ರಿ ಇವಾಗ ನಾನು ಇದು ನೋಡಿರ್ಲಿಲ್ಲ ಅದಕ್ಕೆ 2 ನಿಮಿಷ ಟೈಮ್ ಕೊಡಪ್ಪ ಅಂತಂದೆ ಮನೆಗೆ ಹೋಗ್ಬಿಟ್ಟು ಸ್ವಲ್ಪ ಮೀಟಿಂಗ್ ಇದೆ ಈಗ ಒಂದಕ್ಕೆ.
Dr. Harish, is it possible?
Yes, sir. Sir, I am here, sir.
Can
Sir,
you please switch on your video?
Yes. Sir, I am trying to first my post paper on the screen. I will start my video, sir.
You're not open your presentation, only desktop.
Yeah, yes, sir. Sir, I am trying, but it was not shown on my desktop. Sir, I am trying.
Okay, first you need to open your presentation, then share.
Sir, on my screen, the window on which I am open Zoom is showing in small screen. Hello.
Sir, क्या problem है? एक बार बताएं.
Sir, on my screen there is a no option for sharing.
Sir, you log in Zoom ना?
Yes, sir. I am
Zoom
logging from
minimize
Zoom.
किया था. आपने Zoom minimize किया था.
Yes, sir.
उसमें एक एरो आ रहा होगा सर. जूम की विंडो पे जाओ, आप क्लिक करते एक एरो आ रहा होगा वहाँ पे.
हाँ सर.
एरो को क्लिक करेंगे तो बड़ा हो जाएगा.
यस सर.
स्क्रीन बड़ा होने के बाद ग्रीन साइन मिलेगा आपको. शेयर तो आपने कर रखा है ऑलरेडी.
सर, इसमें शेयर का कोई ऑप्शन नहीं दिखा रहा है इसलिए.
सर आपने शेयर तो कर रखा है अपना डेस्कटॉप. मैं स्टॉप कर रहा हूँ, फिर आप करिए.
हाँ सर.
अभी आप पहले प्रेजेंटेशन ओपन करके फिर शेयर करें.
यस सर, होगा. सर अब दिख रहा है प्रेजेंटेशन?
नहीं, अभी शेयर करें उसे. आपने पीपीटी ऑन कर लिया ना, आप जूम पे जाकर उसको शेयर करें.
हाँ सर.
जूम पे नीचे ग्रीन कलर का साइन आ रहा होगा, शेयर स्क्रीन.
यस सर.
सर शेयर करें आप. शेयर नहीं हुआ अभी. हाँ, अभी शेयरिंग हो रहा है कुछ. हाँ जी, इसको फुल स्क्रीन करके फुल स्क्रीन कर दीजिए.
यस सर. यस सर.
स्लाइड शो.
हाँ.
प्लीज स्टार्ट योर टॉक.
हेलो
डॉक्टर हरीश, प्लीज स्टार्ट योर टॉक.
सर अभी कैमरा ओपन होने में डिफिकल्टी हो रही है.
कोई बात नहीं, आप स्टार्ट.
हेलो, गुड आफ्टरनून एवरीवन. आई एम डॉक्टर हरीश मेमरिया, second year resident doctor in BJ Medical College, Ahmedabad. Sir, I am presenting the paper of a comparative study of percutaneous needle aspiration and catheter drainage in management of liver abscess. Aim of the study: to compare the effectiveness of percutaneous catheter drainage and percutaneous needle aspiration in management of the liver abscess. Introduction. Liver abscess is an intra-abdominal or visceral abscess cavity containing pus present in the liver. With the advent of the newer imaging and technique availability of broad-spectrum antibiotic, the management of the liver abscess is now imaging-based percutaneous needle aspiration or catheter drainage. Some consider percutaneous catheter drainage along with intravenous broad-spectrum antibiotic as a really accepted and safe effective treatment for a liver abscess. Some consider needle aspiration as a better procedure as it is less aggressive and risky and complicated. But this requires follow-up and repeated monitoring by investigation. Material and method. The study was carried out on a 50 patients who were having liver abscess of 5 cm in any diameter by ultrasonography after taking detailed history and general examination. The study was conducted from August 2019 to August 2020 in Civil Hospital, Ahmedabad. Patients were randomized in a two group, 25 patients in a A group, which was managed by catheter drainage, and second group in a 25 patients managed by needle aspiration. Procedure. In procedure, a disposable trocar needle of 16 gauge will be inserted and the abscess from the cavity is aspirated, and it is repeated if there is no reduction in the size of abscess cavity or clinical improvement in a clinical feature.
aspiration is done maximum up to 3 times. For a catheter insertion, pictal catheter of 12 to 20 French with a guiding stylet will be inserted. The whole of the abscess cavity was evacuated by the manual syringe suction. Then the catheter will be sutured to the skin and connected to the collection bag. From this day, USG is being done every third day till abscess cavity is fully evacuated and removed if the collection was nil for the last 24 hours. Analysis. Table showing the distribution of patient based on a gender. In my study, total in a catheter drainage, total 5 female and 20 males. And in a needle aspiration, total 6 female and 19 male. Average table showing average day of hospital stay and IV antibiotic. In a catheter drainage, average day of hospital stay is 9 days, and for a needle aspiration, average days in a hospital stay is 11 days, and average day of antibiotic in a catheter drainage 8 days, and in a needle aspiration 9.5 days. Association between different age group and outcome. In a catheter drainage, out of 25 patients, one patient is having a failure by failure in case of catheter drainage to aspirate the liver abscess, while in a 24 patient it is successful. While in a needle aspiration, out of 25 patients, 4 patients was having difficulty in aspiration, while 21 patients having successful aspiration. Table showing association between different group and recurrence after out of percent of catheter, 23% of catheter, while 2 patients having recurrence. And in a needle aspiration, out of 25% was 20% was successful, and 5% having table showing association between different age group and recurrence after 3 months. In a catheter drainage, out of 25%, 24% is 24% having no recurrence, while only 1 patient having recurrence. Or in a needle aspiration, out of 25%, 23% have no recurrence, while 2 patient having recurrence. This table showing association with after 6 months. In a both catheter drainage and aspiration, 23 patients showing no recurrence, while only 2 patients showing recurrence. Complication in a catheter insertion, only 3 patients showing complication, mostly spontaneous bile leak, which was healed by which was stopped spontaneously, while in a needle aspiration, 4 patients showing a complication of hemorrhage, which stops spontaneously. Discussion. 50% of liver abscess were randomly distributed into catheter drainage and needle aspiration group. It was found that 30 cases belong to amoebic liver abscess, while 20 cases belong to pyogenic. Total average duration of IV intravenous antibiotic administration needed for patient in catheter drainage group was 8 days, while for a needle aspiration group were 9.5 days. The average duration of hospital stay for patient in the catheter drainage group was 9 days. For a needle aspiration group were 11 days. Regarding clinical efficacy of the 2 percutaneous method, it was found that both of them were effective against treatment of the liver abscess, which were recorded in terms of post-intervention improvement in a various clinical parameters as relief in a pain, jaundice, fever, decrease in hepatomegaly. Out of 25 patients in the catheter drainage group, 2 patients saw recurrence after 1 month, and out of 25 patients in the needle aspiration group, 5 patients saw recurrence after 1 month. The success rate in a catheter drainage group was 92%, and that in a needle aspiration group was 80%. And the complication related to needle aspiration was hemorrhage in a 4 case, which stopped spontaneously without hemodynamic compromise. Complication related to catheter drainage group was bile leak in a 3 cases, which spontaneously. Conclusion: from our prospective study, we can conclude that the percutaneous catheter drainage is a better modality as compared to percutaneous intermittent needle aspiration in medium to large size liver abscess in a several aspects. The duration of hospital stay. Hello.
Yeah.
Time over.
Hello.
Sir, please start the questions.
Harish, can you hear me?
Yes, sir. Yes, sir.
Yeah. The size of the abscess, you're not
Yes, sir.
mentioned in all the things.
Sir, I mentioned in my study, size of the liver abscess more than 5 centimeter in any diameter. Sir.
Of your cases, how you decided to go for needle aspiration or the catheter aspiration?
Sir, I take randomly 50 cases, and out of 15, 25 are divided into needle aspiration and 25 are divided into percutaneous drainage.
No, of the same size or different sizes?
Sir, of different size, more than 5 centimeter in any direction.
Why I'm putting the question is the small, medium, and large abscess you have taken.
Yes,
the
sir.
medium and large abscesses.
Sir, only medium to large.
Medium to large. See, the hospital stay was more in the catheter drainage, no?
Yes, sir.
Yeah. How you
Sir,
conclude then?
Sir, but in a needle aspiration, we have to try multiple time. So for a post of after complication of needle aspiration, hospital stay was more in the needle aspiration as compared to catheter drainage.
Yeah. The what was the recurrence rate?
Sir, in a recurrence rate after 6 months, there both are effectively in success or in 92%. But in a early month, like in 1 month and 3 months, catheter drainage drainage shows less recurrence than needle aspiration.
How many days the catheter was left there in the this one?
Sir, sir, 7 days, 7 to 8 days, on most of patient.
In the needle aspiration, how many times the needle aspiration was done?
3 times, sir.
Okay. Okay.
Dr. Sarvish, Dr. Rajkumar is joined.
Yeah, please. Yes, sir. He can also put the questions, no?
Hello.
Hello.
Good afternoon, sir.
Welcome, Dr. Rajkumar.
Sir, can you please speak louder, sir? Your voice is not audible. Rajkumar, sir.
Hello.
Your voice is low.
Hello, sir. Hello.
Yes, yes. Sir, can you please full screen?
Full screen.
Slideshow.
Hello.
Done, sir.
Good afternoon, sir.
Yeah, good afternoon.
So, myself, Dr. Rajkumar Singh Jat. Hello.
Start, sir. Start.
Good afternoon, sir. Myself, Dr. Rajkumar Singh Jat from Mahatma Gandhi Medical College, Indore. My topic is to describe a technique, subcutaneous onlay laparoscopic approach, SCOLA, for the correction of ventral hernias combined with the DMRA application and to report the initial result of the case series. So objective is I present case series of 30% with outcome and follow-up. Introduction: ventral hernias are one of the common condition presenting the surgical OPD prior to the early 90s. Open method was practiced either anatomical repair alone or anatomical repair along with a mesh placement with the advent of prosthesis placement for hernia repair. The recurrence rate of the hernia has dramatically come down. In 1993, pioneers including Levenank, Booth, Hanniford, Park, Ramsey, and Waller subsequently introduced the laparoscopic approach to ventral hernia. Involves various methods like intraperitoneal placement of the mass, polypropylene mass. LBHR has excellent result, but it has its own complication like omental adhesion leading to adhesive colic, adhesive obstruction, intercutaneous fistula. The study provides the details of surgical technique, post-operative complications, advantage of the procedure, and early result. Diastasis of the rectus abdominis muscles (DMRA) is a frequent and may be associated with abdominal wall hernias. For patients with reductant skin, dermolipectomy and plication of diastasis is the most commonly used procedure. However, there is a significant group of the patients who do not require skin resection or do not want large incision. Diastasis of the rectus abdominis muscle (DMRA), defined as a distancing from the muscular border in the midline greater than 2.2 centimeter, is not a rare condition. Treatment of DMRA associated or not with abdominal wall hernia in a patient with excess skin is usually performed by a large transverse incision in a lower abdomen associated with a dermolipectomy. The aim of the present study is to describe a technique, SCOLA, for the correction of ventral hernia combined with the plication of diastasis of the rectus abdominis muscle and present the initial result of the prospective study. These photographs shows mass covering DMRA plication in the pre-apneurotic position only, and these diagrams explain the port assessment. This method is this study was conducted during the period between Jan 2019 and Feb 2020 at MGM Medical College and Amba Hospital Indore. Out of 47 patients who presented with the ventral hernia to the surgical OPD, 30% who met the inclusion criteria were taken into the study. Of the 30% with ventral hernia, 4 is epigastric hernia, 13 were umbilical hernia, 11 is incisional hernia, and SCOLA technique was performed in these 30% and followed up post-operatively for 3 months. Discussion: DMR is a frequent condition, especially during pregnancy, and regress spontaneously after delivery in most women. DMR is characterized with thinning and widening of the alba linea, generally combined with a sagging abdomen wall muscles. DMR is defined according to Weir's classification. The main complaint in the patient with DMR is alternation of the shape of the abdomen. Surgical repair is generally considered an aesthetic procedure and is addressed to plastic surgeons. The ARROW-ETL in randomized study demonstrated a significant reduction in the risk of the recurrence without an increase in the rate of complication when polypropylene mesh was used. A prospective cohort Danish ventral hernia database also shows a reduction in the risk of relapse from 5.6% to 2.2%. P-value 0.001 when mesh was used for repair. The rate of complication was similar to repair based on suture alone. In this study, although the size of the defect was small, 2.3 centimeter between 1.5 and 4 centimeter. If the use of mesh is more accepted, it seems that surgeons have neglected the importance of taking into account the concomitant presence of DMRA. Kohler et al. Reported a 31.1% relapse in the patient with epigastric or umbilical hernia smaller than 2 cm with DMRA versus epigastric or umbilical hernias 2 cm with DMRA versus 8.3 without DMRA after 24 months of follow-up. Recently, this procedure was described by exclusive endoscopic techniques, that is through small suprapubic incision for the portals and CO2 insufflant to maintain the operative field. However, this article presents some technical modification in relation to original study published by Argentine surgeons. The technique is antibiotic prophylaxis was routinely used, consists of administration of 1 gram intravenous cefazolin in anesthetic induction. The patient is placed in dorsal decubitus under general anesthesia with a slight extension of the hip and leg decubited and abducted. The surgeon is placed between the patient's leg and assisted laterally. A small 2 cm transverse incision is just over the pubis performed. The subcutaneous dissected. It reaches the anterior aponeurosis of the rectus abdominis muscle with the aid of the parafube type retractor, with the subcutaneous tissue separated from the anterior aponeurosis with a monopolar cautery. Both are superior and laterally to create sufficient space in placement of the portal of 11 cm for uptake by the previous incision of 2 axillary fibrils laterally. A persisting suture is performed in the suprapubic incision, both to fix the portal of the optic and prevent CO2 leakage. So my operative result is the mean operative time was 100 minutes, 70 to 150. There were no conversion to open procedure. There were no intraoperative complication, and bleeding was about mean 90 ml in all cases. Post-operative complication 10%, 31% had complications. Seroma was the most frequent. Seroma was reabsorbed without intervention. In 5, while in 3, puncture was necessary for drainage. Of these, 2% needed only 1 puncture, while 1 needed multiple. After mean follow-up of 6 months. The case series are this graph is showing that the recurrence and outcomes and complication of that 30 patients. The conclusion that SCOLA is a technique is a safe, reproducible, effective alternative for the patient with abdominal wall hernia associated with DMRA. Review of literature, Claus, CMP et al. Done that study on 48 cases in 2018. Result is following. The mean operative time was 93.5 minutes. There were no intraoperative complication and no conversation. Seroma was the most frequent complication. Only one had a surgical wound infection after median follow-up of 8 months. Only one patient presented recurrence of DMRA and one subcutaneous tissue retraction fibrosis. Dong CT et al. Done that study on 16%. 14 was female. The mean age was 45. The mean BMI was 29. The mean operative time is 146 minutes. The mean follow-up time was approximately 2 months. 3 patients developed seroma, and patient developed an infected seroma, and 2 patients developed hernia recurrence. Thank you. Hello. Hello.
Hello.
हाँ जी sir. Hello.
Yeah, Dr. Rajkumar.
जी sir.
So mainly you wanted to go for the size of the incision you are commenting, or the whole of the procedure is better you are telling?
जी sir. Yes sir. What's the mean, sir? The mean is 2.3 for the defect size. Sir.
So you mean to say it's cosmetically helpful?
Ji sir. This is a very cosmetically helpful in the diastasis of rectus abdominis muscle cases.
Your voice is not audible properly.
Hello.
Okay, Dr. Rajkumar. Okay. Go for the next, please.
Dr. Anupama.
Sir. Hello, sir. Hello, sir.
Please start, ma'am, sharing.
Okay, sir. Sir, can I start, sir?
Yeah.
Good afternoon, respected faculty. Yes, sir. Good afternoon, respected faculties. Myself, Dr. Anupama, pursuing post-graduation in SPMC Tirupati. So I'm going to present a paper regarding the low molecular weight heparin role in the management of acute pancreatitis, a prospective study. Acute pancreatitis is a common disease. Hello, sir. Sir, is it audible, sir?
Ma'am, please go.
Okay, sir. Acute pancreatitis is a common disease with varying severity, and mild acute pancreatitis usually has an uneventful course with spontaneous recovery in less than 1 week. Moderately severe and severe acute pancreatitis can be complicated with various local and systemic complications. Severe acute pancreatitis is severe and frequently a lethal disorder with a mortality rate up to 25 to 40%. The exact pathogens of pancreatitis still remains debatable, but this can be closely related to the dysfunction of balance between the pro-inflammatory and anti-inflammatory responses. There will be premature activation of the pancreatic proteases and extravasation of these activated digestive enzymes into the pancreas and peripancreatic tissues. Cytokines and other inflammatory mediators will be produced and released with excessive leukocyte activations. These in turn stimulate the inflammatory cascade, leading to systemic inflammatory response syndrome. Infected necrosis and persistent organ failure usually carry a poor prognosis for the patients. Pathogens of necrosis affects not only the pancreas but also the kidneys, lungs, liver, intestine in the course of severe acute pancreatitis. And low molecular weight heparin is known to possess a special antithrombin activity, which is stronger and safer than attenuated heparin. And low molecular weight heparin also inhibits the inflammatory cascade in and reduces the release of cytokines and inflammatory mediators. Moreover, heparin administration also has the following activities like it downregulates TNF-alpha-induced leukocyte rolling. It blocks the adhesion of leukocytes to the endothelium by inhibiting the interactions between the expressed adhesion molecules and endothelial cells. It reduces the activation of platelets and reduces the formation of microthrombi and improves the microcirculation, thereby preventing the further damage. And therefore, low molecular heparin by its antithrombus effect and by blocking the initiation of an inflammatory storm leads to improvement in the microcirculation system and reduces the formation of microthrombus in pancreas, leading to better outcome of the patient suffering with acute pancreatitis. In this scenario, the aim of our study was to determine the efficacy of low molecular heparin in the prevention of progression of acute pancreatitis into more severe forms of moderately severe and pancreatic necrosis. Coming to materials and methods, and this is a hospital-based study conducted in Department of General Surgery over a period of 1 year in our hospital, and the eligible 100 subjects fulfilling the inclusion and exclusion criteria were randomly divided into two groups, those receiving standard care alone and standard care plus low molecular heparin, and were studied. Inclusion criteria: patients diagnosed with acute pancreatitis based on the following criteria, like abdominal pain, which is characteristic of acute pancreatitis with a duration of less than 72 hours, serum amylase or lipase, which is elevated more than 3 times the upper limit of normal, and radiological findings suggestive of acute pancreatitis. Those who are excluded from the study are those patients who are suffering with chronic pancreatitis and patients having hypersensitivity to low molecular heparin or radio contrast agents. CT findings suggestive of complicated pancreatitis, pregnant or breastfeeding patients, patients who are having coagulation diseases, and patients with severe comorbidities. Procedure methodology. After obtaining written informed consent from patients, all patients underwent general routine examination and clinical examination, routine hematological, biological, and radiological investigations done for each patient, and the diagnosis was based on the American College of Gastroenterology guidelines with the presence of at least 2 of the following 3. Characteristic epigastric pain, serum amylase value of more than 3 times the upper limit of normal, and characteristic findings of acute pancreatitis in imaging. Moderately severe and severe acute pancreatitis were defined according to the revised Atlanta criteria. Moderately severe acute pancreatitis is characterized by local complications such as peripancreatic fluid collections and pancreatic and peripancreatic necrosis without transient organ failure. Severe acute pancreatitis is characterized by persistent organ failure that is lasting for a period of more than 48 hours, and harmless acute pancreatitis score was calculated, and CT results were classified according to Balthazar and modified CT severity index. Following parameters were monitored on admission and during the follow-up of 7 days, and hematocrit, WBC count, serum amylase and lipase, calcium levels, creatinine, albumin, transaminase, C-reactive protein, blood glucose levels, and INR. Abdominal CT scan of all patients were performed at the time of hospital admission in the first 12 hours and on day 7, and acute pancreatitis severity was assessed using the modified CT severity index. According to the modified CT severity index, scores that range between 0 and 2 indicated mild pancreatitis, 4 and 6 indicate moderate forms, and 8 and 10 indicate severe acute pancreatitis. Patients with moderately severe and severe pancreatitis according to the modified CT severity index in the initial CT were excluded from our study. Coming to the results, in our study, the most common age group affected is around 30 to 45 years. And the mean age of patients treated with standard care is alone 40, and those treated with standard care and low molecular heparin is 40.4, and that shows there is no significant difference between the mean age groups of the ages of the two groups. Most of the patients were male patients with a percentage of 94%. In our study, among the 100-patient study, 97 were recorded and 3 were dead, sir. In our study, it was found that among the 100-patient study, the outcome is better in patients received low molecular heparin in addition to the standard care with a recovery rate of 100% with low molecular heparin. The recovery percentage is 94% and mortality percentage is 6% in patients received only standard care. And there is no significant difference between the two groups with a p-value of 0.04 calculated by using chi-square test. Coming to the discussion, acute pancreatitis turns a severe course in a minority of patients. However, this subset is responsible for the burden of the disease. Therefore, decreasing the burden of acute pancreatitis can only be achieved with successful management strategies towards the disease. Previous clinical and experimental data revealed that the fate of acute pancreatitis is dictated in the early hours of pancreatitis, and impairment of microcirculation is the rearrangement leading to necrosis. The presence of hematocrit value more than 44% and failing to decrease it with IV fluid boluses is considered to predict severe prognosis. And hemoconcentration may be a cause for the impairment of microcirculation. This may play an important role in the transition of radiomatous to necrotizing pancreatitis. Abundance of several inflammatory cytokines in the microenvironment of the pancreas in the setting of acute pancreatitis is also a precipitating event. Pro-inflammatory cytokines such as interleukin-1 beta, interleukin-6, and TNF-alpha increase during the course of acute pancreatitis.
And time is up. Sir, please answer the question.
Yes, sir.
Hello. Can you hear me, Anupama?
Yes, sir. Yes, sir. Yes, sir. You're audible, sir.
No, what was the main theme of your this one study?
Sir, actually, the study was aimed to prevent the progression of acute pancreatitis into more severe forms, sir, like by administering the factors that prevent the trophic formation, sir, so that we can improve the prognosis in the early stages itself, sir.
Okay, ma. Okay. Hello.
Yes, yes, sir.
Yeah, it's okay.
Dr. M. Saim, please share your screen.
Okay, sir.
I didn't hear the name properly.
Anugnya, sir.
No, Anupama is finished. Okay.
Sir, is it visible, sir? My PPT?
Please make it full screen, ma'am.
Okay, sir. Is it visible, sir?
Is this possible? Can you please switch on your video?
Okay, sir. Sir, I am visible, sir.
Yeah.
Yes.
Good afternoon, sir. I am Sai Anugnya. I am final year postgraduate in SVMC Tirupati. My paper presentation is on a clinical study of wound infection in emergency abdominal surgeries in a tertiary care hospital. Abdominal surgeries, they are one of the most common surgeries performed as an emergency procedure. After these surgeries, in the post-operative period, surgical site infection is one of the most common complications leading to superficial wound disruption or burst abdomen, which may result in an incisional hernia at a later date. Post-operative wound infection is considered a surgeon's nightmare. It is the third most common cause of nosocomial infection and is highly associated with morbidity and mortality. Surgical site infection meant infection occurring within 30 days after surgery. My aim of study is to study the factors leading to the wound infection after emergency abdominal surgeries. Objectives: to know the incidence of wound infection based on different types of emergency abdominal surgeries, duration of illness, associated comorbidities. This is a prospective study conducted in our hospital. Patients of greater than 18 years age presenting with acute abdomen in need of emergency abdominal surgery in Department of General Surgery are taken into the study. 100 cases that satisfy the inclusion criteria are taken. Inclusion criteria: patients of age more than 18 years presenting with acute abdomen in need of emergency surgery. Exclusion criteria: patients who died within 24 hours of the post-operative period, patients who are in septic shock, and patients with malignancy and immunocompromised conditions. Methods of data collection: detailed history of the cases, clinical examination, and laboratory investigations includes hemoglobin, total count, differential counts, RFT, RBS, BT, CT, and urine examination. Radiological studies: special investigations include culture swab from the wound for sensitivity. My results of the study: in the age group of 18 to 28 years, 6.25% wound incidence undertaken. In 29 to 30 years age group, 12% incidence of SSI present. In 39 to 48 years age group, 26.08% incidence of wound infection present. In 49 to 58 years, 23.07% of wound infection present. In 59 to 68 years age group, 50% of wound infection present. And 68 to 78 years age group, 25% of wound infection present. This showing in the mean age group of for 59 to 68 years, the incidence of SSI is more. Incidence in relation to the BMI, in less than 20 BMI, 23.5% incidence present. In 20.1 to 25, 15% incidence present. In greater than 30 BMI, 38.46% present. This shows that BMI greater than 30, patients have the higher incidence of SSI. Incidence in relation to the anemia, hypoproteinemia, diabetes, and infections. In anemia patients, the incidence of wound infection is 22.5%. In hypoproteinemia patients, 53.3% incidence present. And in patients with diabetes mellitus, wound infection is about 40%. This shows a higher incidence in patients with hypoproteinemia. Incidence in relation to the diagnosis. In duodenal perforation present, about 32% cases are infected. In ileal perforation cases, 50% are infected. In acute appendicitis patient, 8.88% are infected. In appendicular perforation cases, 50% of cases have wound infection. In gallbladder perforation cases, 33.3% has wound infection. In obstruction cases, about 42.8%. And in obstructive hernia cases, 33.3%. In blunt injury abdomen and penetrating abdomen, there were no cases of wound infection. And in gastric perforation, about 33.3% cases are infected. Incidence in relation to the type of surgery. In clean and contaminated wounds, the incidence is about 12.5%. In contaminated wounds, 20.5% present. And in dirty wounds, the incidence of wound infection is about 60%. Incidence in relation to the duration of surgery. If the surgery duration is less than 2 hours, the incidence of wound infection is 13.8%. And if the duration of surgery last is greater than 2 hours, the incidence is about 31.4%, showing high incidence related to the duration of surgery. Incidence in relation to the postoperative day. In the second postoperative day, the incidence is about 6.6%. In third day, 40%. Fourth day, 35%. In fifth postoperative, 20%. And in sixth day, 6.6%, showing higher incidence in third postoperative day. Incidence in relation to the organism. In this, Escherichia coli has 40%, and Staphylococcus aureus is 30%, Klebsiella 20%, and Pseudomonas is 10%, showing the organism most commonly isolated is Escherichia coli. The conclusion of my study is, out of 100 cases taken for study, incidence of wound infection in emergency abdominal surgeries is about 20%. Majority of patients belonging to the age group of 59 to 68 years, accounting for incidence of 50%. And patients with BMI ranging greater than 30, it means the obese patients have incidence of 38.46%. Incidence in patients with hypoproteinemia is 53.3, which is more, followed by anemia and diabetes patients. Incidence of SSI is more in dirty wounds with 40%. Longer the duration of surgery, more was the incidence of infection. Most of cases had wound infection on the third postoperative day, and Escherichia coli was the most common organism isolated in these studies. Yeah.
Ma'am, you done?
Yes, sir.
Hello.
Yes, sir.
Yeah, first of all, I want to know your name, ma'am.
Anugna, sir.
Huh? Anugna.
Yes, sir. Sai Anugna, sir.
Yeah. So the thing is, with the clean contaminated wound. Okay.
Yes, sir.
Can you hear me?
Yes, sir. Yes, sir.
What is the incidence of wound infection? SSI.
Yes, sir. In contaminated wounds, it is about 12.5%, sir.
In clean wound?
Sir, I didn't clean wound, no, sir. Only
In see, why I'm asking is, you have operated on hernia also.
Yes, sir.
Hernia was it obstructed or regular hernia?
Obstructed hernias.
Reducible part. In that one, what was the incident?
Sir? Incident. In obstructed hernias, it about 30%.
Hernia.
30.
Infection.
In obstructed hernias, it was about 30%.
Okay. Next is, what was the cause for infection in long duration?
Sir, more handling of the tissues. Sir.
Handling of tissue, would have put it in the handling of the tissue only. More of handling of the tissues rather than the duration. What is the relation between the duration and handling? See, contaminated wound.
Yes, sir. Sir? Hello, sir? Sir, you are not audible, sir.
Sir, done.
Hello, sir.
Hello, Sarvesh sir.
Hello, sir.
Sarvesh sir. Sir, done all Q&A. Ashik sir, can you please check the share screen? Can you please check your sharing, Ashik sir, for the first presenter? Hello, Dr. BS.
Hello.
Yes, sir. Session will start 2:45. Already 2:44. Can you please introduce first speaker?
We are there for judgment of the papers.
Yes, sir. You are the chairperson judge.
Okay. So, video. I'm not seeing any video here. Any presentation.
Sir, first presenter. Can you please introduce the first presenter, Asit Ranjan?
Asit Jha, I think, is the first presenter.
Yes, sir. Can you please switch on your video, sir? Is it possible?
Start my video. Shall I press
Yes.
start my video?
Camera, your camera. Yes, sir. Done.
Okay. Done. Okay.
Please call the first presenter, Dr. Asit Ranjan.
Is it Asit Ranjan Jha or what?
Yes, sir. Good afternoon, sir.
Okay. Introduce your name and.
Sir, myself, Dr. Asit Ranjan. I am doing MS General Surgery second year from Narana Medical College and Hospital, Jamhar, Sasaram, sir.
Hello.
Narana Medical College and Hospital, Jamhar, Sasaram, Bihar.
Okay. So can we start your presentation?
Start sharing, sir, and you have 7 minutes.
Okay, sir.
Please start sharing.
Yes, sir. Good afternoon, sir.
Good afternoon.
I have the subject from my side, sir, the evaluation of pulp score, peptic ulcer perforation score.
So make it full screen.
Pardon, sir?
Full
Slide
screen,
show.
sir.
Make it a slide show.
Yes, slide.
Slide show.
Yes, sir. I'm doing slides. Now it is. Sir, dikh raha hai, sir?
Okay.
Yes, sir. Yes, sir.
Okay. The evaluation of pulp score, peptic ulcer perforation score, as a predictor of mortality following peptic ulcer perforation. Next. Introduction. Peptic ulcer disease included both gastric and duodenal ulcer, which poses a major threat to the whole population, world populations over the past 2 centuries with a high morbidity and mortality. The evolution of knowledge regarding etiopathogenesis of peptic ulcer disease from acid-driven disease to an infectious disease has led to various studies to find out the best possible option for management of this disease. Barry J. Marshall and Robin Warren led to groundwork for a revolution in the medical and surgical arena by discovery of Helicobacter pylori. In addition, NSAID, low-dose aspirin, smoking, excess alcohol use, emotional stress, and psychosocial factors are increasingly important cause of ulcer and their complication. Mortality and morbidity following the perforated peptic ulcer is substantial, and mortality proportion of the 25 to 30% has been reported in population-based studies. Large number of prognostic factors for morbidity and mortality following perforated peptic ulcer has been reported, and a number of clinical prediction rules have been proposed for prognostic prediction, likely the Boyer score and the American Society of Anesthesiologists score, Apache score 2, and the sepsis score. The peptic ulcer perforation score was put forward by M.H. Muller in 2011 based on prospectively collected data from 35 hospitals in Denmark. The aim of this study was to study 5 patients who undergo surgical treatment for perforated peptic ulcer into low risk to high risk group according to pulp score, and to predict the mortality within 30 days post-operatively in both these patient and methods. A prospective study was conducted on patient presenting to Narayan Medical College Hospital, Sasaram from September 2019 to September 2020. 52 patients with feature of hollow viscous perforation and perforative findings suggestive of perforatic peptic ulcer were taken for the study. Inclusion criteria: all patients more than 18 years age presenting with feature of hollow viscous perforation with peroperative findings suggestive of perforated peptic ulcer. Exclusion criteria is taken like histopathologically suggestive of malignant ulcer. Hollow viscous perforation can cause perforation cases which were not operated. Patient with hollow viscous perforation who died before surgery, patient who were not ready to give informed written consent for the study, and patient undergoing procedure other than primary closure with omentoplasty. Patient was resuscitated with IV fluids, oxygen, Polish catheter for urine output. Culture were changed and the patient was started on broad spectrum antibiotics. After stabilization of the patient, details history was taken regarding age, onset of symptom, previous use of steroid or NSAID, smoking, alcohol intake, any active malignant disease, and other associated illness. Patient of peptic ulcer perforation were operated as simple closure with Graham's omental patch. Gastric biopsy was done to rule out the perforation due to malignancy of the stomach. And this is the peptic ulcer variables: age more than 65 years, comorbid condition, AIDS, comorbid liver diseases, concomitant use of steroids, shock on admission like BP less than 100, systolic and heart rate more than 100. Time from perforation and admission more than 24 hours or less than. These are the points for the pulp scoring system: ASI score 2, 3, 4, and serum creatinine. Patient who underwent surgical treatment for perforated peptic ulcer were allotted points according to the pulp scoring system. Other patients who underwent surgery for other hollow viscous perforation were not included in the study. Individual patient was classified into high risk and low risk category, and continuous bedside monitoring was done. All the patients were followed up after 1 month, either directly in person or through the telephonic conversation, and again after 6 months of the interval. A statistical analysis age differences were considered significant if p-value is less than 0.05 using the chi-square test. IBM SS statistics for Windows version 24 of software program are used for this calculation. Observation and results: the highest incidence of perforated peptic ulcer was seen in 30 to 50 years of ages in the present study. There were 50 males and 2 females. The association of variables with mortality is depicted in following tables, like ages more than 65 years are more vulnerable, like shock on admission, if taken for 46%, one is died not in shock. Shock is also important factors. As we serum creatinine is also given in table. Again, ASI scores are high ASI score, high mortality. There is stratification patient done in low risk, high risk criteria. Significance of pulp score in predicting mortality. P-value is very low, 0.001 less than this, and sensitivity 83.33% sensitive, and the specificity of this score is 97.83% is a specific. This discussion: perforation is the most common complication of peptic ulcer disease. In spite of modern prognosis process in management, it is still a life-threatening catastrophe. Perforated gastric ulcer are potentially complicated surgical emergency, and appropriately early management is essential in order to avoid subsequent problems, including unnecessary gastrectomy. Complications rates continue to remain the same despite overall reduction in incidence of peptic ulcer disease in recent decades. Mean age is 47 years in the present study, which is similar to that of another study. Sex ratio was 25:1, which is similar to studies conducted in India by Sharma et al. And Misra et al. 4 variables are found to be most important. In the present study, treatment delay more than 24 hours, shock on admission, high ASI score, age more than 65 years. The mortality rate in case of the delayed surgery was 9.9%. This is similar to the study done by others. The mortality in the patient presenting with shock at admission was 18.2%. This matches with the study done by Dakubo and others. The present study, there were 5 deaths and they belong to ASA grade 3 and 4. Hence, ASA grade is highly important predictor of the post-operative mortality. The results are similar to the study done by the Focus, where higher mortality was seen in ASA 3 and 4 and 5. The age above 65 years was found to be a significant influence on the mortality. Out of 5 decades, patients, 4 were above 65 years of age. This result is also similar as done by the Focus and Lohis Rivat. All the 5 patients who died in serum had serum creatinine level more than 1.47.
The time is up.
Okay, sir. Thank you, sir.
Please start the question, Chairperson.
Can you conclude from what are your conclusions from your paper?
Sir, conclusion is that this pulp score is very much important score to diagnosis about the seriousness of the peptic ulcer perforation and to send the patient from periphery to the well-equipped center, higher center, as and time is in less time. The criteria, the pulp scoring system is very simple tests, creatinine levels, age, and these are the easily predictable, and we can send the patient to higher center for less mortalities from periphery.
The patient, for example, who comes in shock, a patient, for example, who comes in shock, having peritonitis and in shock, do you think that patient should be referred to the higher centers without resuscitation?
No, sir. We have to resuscitate first, and during resuscitation, IV fluids, oxygen, and creatinine level to see, and Foley's catheterization is should be done, and time is during this time we have to arrange the system to send to higher system.
What are the causes of shock in a patient who has got peritonitis? Why patient develops shock in peritonitis?
Because in peritonitis, peritonitis can extend beyond peritoneum, and sepsis is rapidly progressing, which is cause of the dehydration and shock.
Initially, is it the loss of fluid? Later on, can it be the septicemia? What are the factors which give rise to shock in case of perforation period? Yes.
Septicemia, sepsis is the cause for shock in peritonitis.
Okay. So you think that in every patient it is better to have this scoring system, and is it only for the prognostic point of view?
Yes, sir, it is prognostic part only. All patient is not following because specificity is 97% and it is sensitive for about 90% cases. 100% is not specific, sir. But more or less it is better score, sir, and very cheap.
Okay. You said the incidence has gone down, but the mortality has not gone down. Incidence of perforation has gone down. Why? How can you say that?
Pardon, sir?
Incidence of perforation has gone down. However, the mortality of perforation remains almost the same. That is what you said.
I can't understand.
Would you get me?
Sir, getting, sir, but can't understand what you are. Pardon,
is it because of the use of proton pump inhibitors, the incidence has gone down?
Yes, sir.
So that is what I'm asking.
Yeah.
Incidence has gone down, but once there is perforation,
so time's up.
Now, in spite of the perforation, in spite of the proton pump inhibitors, why ulcer perforate? What is the reason for perforation? What do you think?
It may be Helicobacter H. pylori infection. It may be overactivity. PPI is not of in such 100% is not effective because of its limitations. Proton pump inhibitors.
Okay, thank you. I think your time is up. I think your time is up. Thank you.
Thank you, sir.
Okay.
Next, Dr. Venkat is not available. Move to Dr. Divya.
हो गया ना जबरदस्ती क्या पूछा तो सिंपल सवाल था लेकिन
Good afternoon, sir. This is Divya. Can I start, sir?
Oh, yes, you can.
Yes, sir. So my paper is on the effect versus conventional dressing on split skin graft. It is a randomized control trial. It was done in Mahatma Gandhi Medical College and Research Center in Pondicherry. So skin grafts are most common procedure in general surgery and plastic surgery, used extensively for extensive wound areas and wounds that cannot be healed by primary intention or that healed by secondary intention, causing extensive scarring. So this originated about 2,500 to 3,000 years ago, which was first documented in Sanskrit in the 18th century. So skin graft, the process involves creation of another wound, which is similar to that of a second degree burn. So there is significant morbidity, which can lead to delay in wound healing, as well as cause a lot of pain to the patient because of the exposure of the sensory nerve endings, and it is more painful than that of the recipient site. So it has to be managed adequately and promote wound healing. Even though there are various advancements in the techniques of grafting, the management of donor site is more or less standard. Perfenadone is a pyridine derivative. It has anti-fibrotic and anti-inflammatory properties, and it acts as a modulator for inflammatory cytokines. So selective inflammatory cytokines regulator. It is commonly used in idiopathic pulmonary fibrosis. So TGF-beta is TGF-beta participates in the onset of the development of wound healing, but overexpression leads to delay in the keratinocyte migration, which leads to delay in the wound healing. This anti-TGF-beta activity of perfenadone has shown to increase epithelialization and cause wound contraction much faster. So the aim of this study is to study the effect of topical perfenadone compared to that of the conventional study, and we have compared the reepithelialization rate, duration of complete repigmentation, the pain score, and duration of dressing. So it is a randomized controlled double-blinded study, and we had two groups, the perfenadone dressing groups where 24 patients were there, and the conventional group with 21 patients. Patients older than 18 years and who were willing to participate were included in the study. Exclusion were patients with significant medical condition that caused impaired wound healing, like renal impairment and hepatic impairment. And patients who received corticosteroids, immunosuppressive therapy, radiation, or chemotherapy 1 month before the entry of the study. So patient who underwent skin grafting, patients graft of intermediate thickness was taken and were allocated into two groups, the topical perfenadone dressing group and the conventional dressing group, and they were follow up and analyzation was done. So here we included the size of the wound, and there was no significance difference between the two groups. And reepithelialization, the duration of dressing, the days for complete thing, and the pain showed significant difference. So reepithelialization on day 7, the perfenadone group had 93.68%, whereas on day 10, the conventional group had 93.7% and the perfenadone group had 97.8%, which was significantly different. And pain score, we found that there was mild to moderate pain up to day 3 in the perfenadone group, and the conventional group had moderate to severe pain up to day 6. In the which was also significantly different, and the duration of dressing was about 8 days in the perfenadone group and 10 days in the conventional group, which was also significantly different. So here we can see on day 7 there was almost complete healing of the donor site. So here we have exhibited that the faster epithelialization in perfenadone group than that of control group. The conventional group was evaluated only on day 10 because various studies shows that wound healing with paraffin gauze takes up to 12 to 15 days. And McCord Rivera, in a study where they compared the difference between conventional dressing, they found something similar to that of our study, which was 99% on day 10 was found in perfenadone and 83%, whereas ours was 97 and 93%. And perfenadone group had significantly less pain even in theirs, which was 3 to 7%. These studies, most of these studies evaluated by thickness of the epithelium, which was different, which was avoided in our groups because of the invasive technique. There was a study by Gabriel McCord which showed second degree burns, which was also thickness was increased in pirfenidone group, and it also showed all layers of epidermis. And there was other evidence for pirfenidone in wound healing is where they were involved in chronic diabetic foot ulcers, where these studies showed that there was significant reduction in ulcer volume compared to that of the normal dressing group. And another study where they saw pathological skin scarring in burns patient, the scarring was significantly reduced in topical pirfenidone group compared to that of pressure dressing. And so I would like to conclude that topical pirfenidone improves the epithelialization in split skin graft donor site, and there is significant reduction in pain and reduction in the duration of dressing. It would be ideal to compare this dressing with other available dressings, and also long-term follow-up to find out about the graft complications, hyperpigmentation, scarring would be appropriate. Thank you.
How much is this drug costing to the patient?
Sir, this drug is only 200 rupees cost.
But how many times you have to apply? It is only once?
Sir, we have to apply once, yes, per day.
Okay, not much cost difference to the patient.
Yes, sir. So sorry, sir, you're muted. Can't hear you, sir.
What is the mechanism for whatever advantage you have said? If you go to your last slide and whatever say advantages you have mentioned.
Yes, sir.
What is the mechanism for the significant improvement in the recovery of this patient?
Pirfenidone says there is reduction in the inflammatory phase, sir. So the keratinocyte migration causing the epithelialization occurs faster because the inflammation is reduced, and early migration of keratinocyte leads to early epithelialization.
So do you think that the whatever is routinely used now should be replaced by this type of modality of
So yes, so because it causes a lot of pain, as well as an extensive burns patient where we can regraft can be done earlier, because if it heals faster, we can take a graft again from the same place in case of extensive burns where multiple grafting might be necessary. So it can be replaced and it causes less pain, where patient sometimes constantly complains about pain in the donor site more than the recipient site also.
Okay. Okay, thank you, Divya. If there are no questions, are there any questions from the other judges? Okay, if there are no questions, okay, thank you.
Thank you, sir.
So next presenter is Dr. Purnima.
Okay.
Good afternoon, sir.
Ma'am, please share your screen and speak louder.
Yeah, can you just, I think I've shared the screen. Is it visible, sir?
Yes, yes, it is visible.
Good afternoon, sir. Dr. Purnima Parashuraman. I'm presenting a paper on role of diagnostic laparoscopy in chronic abdominal pain. I'm a third year general surgery resident from MBJ Medical College. So in our surgical practice, we often encounter patients with undiagnosed abdominal pain who, even after careful evaluation with sophisticated investigations, remain undiagnosed. These patients with undiagnosed abdominal pain are difficult to treat, and they tend to have a chronic phase of suffering from the unremitting nature of the pain. Diagnostic laparoscopy, as we have seen, is a valuable tool that can be used in these group of patients to overcome this problem. It is used in these patients when the modern imaging techniques fall short in identifying the causes of undiagnosed abdominal pain. There are numerous differential diagnoses for the patients with undiagnosed chronic abdominal pain. Since diagnostic laparoscopy has a high yield in diagnosing and treating these patients, it has become a major diagnostic modality in surgeons' armory. Coming to the aims and the objectives, here we want to assess the benefit of using laparoscopy as a diagnostic tool in patients with undiagnosed chronic abdominal pain, to find the various causes leading to chronic abdominal pain and treat it accordingly using laparoscopy. Coming to the materials and methodology, we have done a prospective study on 100 patients admitted in MVJ Medical College, the Department of General Surgery, with undiagnosed chronic abdominal pain from September 2018 to September 2019. The inclusion criteria, we included patients with undiagnosed chronic abdominal pain. It is greater than 3 months duration. Patients with or without previous abdominal surgeries, patients of both sexes, and patients of age group from 18 to 65 years. Coming to the exclusion criteria, patients with established diagnosis after laboratory and radiological investigations, patients with comorbid conditions, patients with acute abdomen and peritonitis, patients with functional diagnostic diseases. All patients were subjected to a thorough history and abdominal examination along with gynecological examination. Radiological imaging such as X-ray, USG abdomen, pelvis, and CECT abdomen and pelvis were done. Blood investigations such as complete blood count, renal function test, liver function test, coagulation profile, urine routine, and urine culture were also performed. Additional investigations such as upper GI endoscopy and colonoscopy were done according to the patient's symptoms. Only those patients who remained undiagnosed, even after all these above mentioned investigations, were included in the study, and the same were explained to the patient. Informed written consent was obtained from the patients. Coming to the operative technique, so under general anesthesia, Veress needle was passed through the infraumbilical region and the pneumoperitoneum was created. So we used a standard 3 trocar technique where one 10 trocar was placed in the umbilical port. The other two 5 mm trocars were used in the ports. Then a fourth trocar of 5 mm was inserted as needed during the procedure. Now, all the quadrants were in the abdomen were visualized in a sequential manner. Solid organs, small bowel and large bowel, appendix, ovarian, fallopian tube, and uterus are examined for any female for pathologies in all female patients. And also we looked into the peritoneal surfaces. Here we can see a photo of the Veress method. Based on the patient's conditions, the required procedures were performed. So here the first table shows an age distribution where the maximum number of patients were found in the age group of 26 to 35, which included 46% of the patients. Second being 36 to 45 years, which included 24% of the patients. Coming to the distribution in the male and the female distribution, 55 are males and 45 are females. In the 26 to 35 years age group, we found 34 males and 12 females. Now coming to the associated symptoms, the most patients presented with nausea, which included 24 of the total patients. Second, we had fever, and third being vomiting. We also compared, there were other associated symptoms such as burning micturition, loss of appetite, loss of weight, dysmenorrhea, abdominal distension, constipation, etc. So coming to the diagnostic laparoscopy findings, in the appendicitis was found to be seen in maximum number of patients, that is 43%. Adhesions were seen in 25% of the patients. Next being peritoneal tubercles, which is 8%. Ileocecal TB was seen in 4%. Hydrosalpinx was seen in 4%. Adnexitis was seen in 4%. Mesenteric panencylitis in 2%. Mesenteric lymphadenopathy in 2%. Endometriosis in 2%. And ovarian cyst in 2%. Normal study was seen in 4% of the patient. So basically in this study, 100 patients were enrolled, in which 26 to 35 years of age group accounted for 46 patients. Out of these 5,500 patients, 55 were males and 45 were females. 34 out of the 55 male patients and 12 out of the 45 female patients belong to the 26 to 35-year age group. Out of the 100 patients, 60 presented with lower abdominal pain. Nausea being the most commonly associated symptom, which was present in 24% of the patients. Appendicitis is the most common finding, which accounted for 46% of the total findings, in which 30 were males and 13 were females. And for these patients, appendicectomy was done in the same setting. Adhesions is the second most common finding, which was observed in 24% of the patients. And for these patients, laparoscopic adhesionolysis was done. 82% of the female patients had non-gynecological problems, and 12% of the females were found to have gynecological problems. 4% of the patients had normal findings on diagnostic laparoscopy. Remaining 96% of the patients had their definitive diagnosis at the end of the procedure. 82% of the patients had either therapeutic procedure or ancillary procedure performed. Most commonly performed procedures were laparoscopic appendicectomy, then laparoscopic adhesionolysis, and biopsies were done. Now, coming to the comparison. Yes, sir. Sir, I can't hear you, sir.
Did you conclude have you concluded your I could not see your last slide.
Sir, this is one slide left, sir.
So you can mention that. You can show that slide.
Kindly.
1 minute, sir. I'm not able to show it, sir.
Okay, so what is your conclusion then?
Conclusion, in this study, we have seen that 96% of the patients with chronic undiagnosed abdominal pain had a definitive diagnosis at the end of the procedure, and in 82% of the patients, this laparoscopic procedure had a therapeutic role in the same sitting itself. So hence we see that diagnostic laparoscopy is very useful in diagnosing as well as treating the patient with undiagnosed chronic abdominal pain, sir.
Okay, the commonest condition you revealed in these patients was appendicitis.
Yes, sir.
Right. You have mentioned in your selection criteria that the patient who had abdominal pain for more than 3 months were included in the study.
Yes, sir.
So 3 months, for example, acute appendicitis, how on laparoscopy you could see that it is appendicitis on laparoscopy after 3 months?
Basically recurrent appendicitis, sir. Patient was having pain on and off, sir. So it was more of a chronic appendicitis what we diagnosed on laparoscopy, sir.
So what were the signs by which on laparoscopy, what signs you could see that to make a diagnosis of appendicitis?
So there was congestion of the appendix, inflammation was seen, sir.
Now, why this patient should have recurrent appendicitis? And if there is recurrent appendicitis, I think it should be diagnosed and it should be treated. So why it should remain as an undiagnosed condition?
Sir, previously, actually, the patients who came to us, they said that they had not undergone any USG abdomen. They were showing in a small clinics close by, sir. So when they presented to us after 3 months, we even on the USG, we didn't find any signs of appendicitis. Even CECT was done for these patients. It didn't show any signs of appendicitis. And when they presented, sir, already patients had more than 6-7 days of pain, sir.
The specificity and sensitivity of the CT scan is quite high, almost 95 or more than 95%. So it is difficult to understand how this appendicitis was missed on even CT scan also.
Very true,
sir. So what actually it looked more like chronic appendicitis, subacute and chronic appendicitis, sir, not acute.
Chronic appendicitis will not show the signs of inflammation on laparoscopy.
Sir, mild inflammation was there on laparoscopy, sir.
Okay.
Say acute and chronic?
The cases.
Dr. Purnima, you mean to say acute and chronic? That is what sir
Yes,
wants
sir,
to
acute
take.
and chronic, sir. Acute and chronic.
But if it is acute and chronic, then also it will show some signs on the CT scan at least. Am I right, sir?
Yes, it should. It should show the signs of.
Yes.
Yes,
Anyways,
sir.
let's go with the next presentation, sir. We are also short of time, sir.
Dr. Bharat.
Okay. Thank you.
Yes,
Thank
sir.
you.
Please share your screen, Dr. Bharat.
Yes, sir. Yes. Sir, is it visible, sir?
Yes, it is.
Yes.
Yeah, yes. 1 minute.
You are Shashikala, is it?
Yeah, yes, sir. No, sir, good afternoon, sir. Myself, Dr. Bharat. My paper is a study to evaluate
Mentioned here is
scoring system.
the
Sir?
paper in name mentioned here is a Shashikala.
Yes, sir. It's my guide, sir. Yeah.
So you are presenting the paper.
Yeah, yes, sir. My name is Bharat, sir. I'm postgraduate.
Okay, Bharat Kumar.
Yes, sir.
Bharat Kumar.
Yes, sir.
Okay.
My guide is Dr. Shashikala. This paper is about a study to evaluate preoperative scoring system for difficult laparoscopic cholecystectomy. Laparoscopic cholecystectomy is one of the most common laparoscopic procedures being performed surgeons all over the world. Laparoscopic cholecystectomy, though safe and effective, it can be difficult at times. So, preoperative prediction for the risk of conversion or any difficulty in the operation can be predicted, and this is an important aspect of planning for surgery. Various problems which is faced in laparoscopy is difficulty in creating pneumoperitoneum, anatomical variation of the cystic duct or the cystic artery, dissection of Calot's triangle, assessing peritoneal cavity and releasing adhesions, and avoiding injury to common bile duct and extraction of gallbladder. Our study is based on the assumption that the difficulty can be predicted, and its design is directed towards the identification of these predictors and to decrease the post-operative complication and conversion rate. The aims of the study were to evaluate the preoperative scoring system for prediction of difficult laparoscopic cholecystectomy and to study the outcome of this scoring in the patients. The materials and methods, the data was collected from the admitted patients in Department of General Surgery in the hospitals attached to Bangalore Medical College, Bangalore. The study design was a prospective study which was conducted from November 2018 to May 2020. The place of study was Bangalore and sample size was 60. The inclusion criteria was patients above 18 years of age and who are giving written informed consent for the surgery, and exclusion criteria was not giving consent or not fit for general anesthesia. The scoring system was taken based on history, age, sex, and previous admissions were asked on the history stage. And on clinical examination, we check the BMI of the patient and any abdominal scar, which is upper abdominal or lower abdominal, and any palpable gallbladder. And ultrasound, in ultrasound, we see impacted stone in the neck, the thickness of the gallbladder wall, and any pericholecystic collection. And this scoring system was graded up to 15. Maximum score was 15, and easy was taken from 0 to 5. Difficult was 6 to 10. Very difficult was 11 to 15. And this was compared in intra-op, comparing the parameters were time taken less than 60 minutes with no bile spillage and no injury to duct was considered as easy in the intraoperative outcome, and difficult is taken as time taken more than 60 minutes or either bile or stone spillage was happened or injury to duct. Very difficult was time taken more than 120 minutes, or is there a possible conversion from laparoscopic to open cholecystectomy? In our study, the results were age is a parameter where more than 50 years of age, the patient number were 14 patients, in out of which 10 were difficult surgery, which was observed in intra-op. And comparing this with the scoring, the age more than 50 years is statistically significant with p-value of 0.02. Coming to gender, male, in our study, 20 cases out of 60 were males and 40 were females, but male gender was found to be difficult laparoscopy up to in 20 males out of 15 males were found difficult laparoscopy. In BMI, BMI more than 27.5 was seen in 16 patients, out of which 7 were difficult surgeries. Normal BMI 36 patient, in out of it only 11 difficult surgeries was happened. And coming to diabetes mellitus, out of 60 patients, 14 of our patients had diabetes mellitus, in which 11 had difficult surgery, which was observed in intraoperative. WBC counts, patients had more than 18,000 counts, were 10 in number, in which out of them 8 had difficult surgeries, and less than 18,000 counts were out of 50 were only 17. And this has a p-value of 0.01. Gallbladder wall thickness, 35 patients had normal wall thickness, in that only 7 had difficult surgeries, whereas 18 out of 25 patients who had increased wall thickness had difficult surgery. And previous admissions for acute cholecystitis, in our study, 15 patients had previous attacks and they were admitted in hospital for the treatment of acute cholecystitis. Out of them, 12 were having difficult surgery. In intraoperative findings were increased adhesions and were seen. Coming to conclusion of my study, around the 60 patients we observed as a prospective study over 19 months. All the patients had stones in gallbladder. Upon that, 44 patients had gallbladder disease symptoms like dyspepsia, bloating of abdomen, and 15 were admitted for acute cholecystitis, and 5 had impacted calculi in neck of gallbladder in ultrasonography. Among the 60 patients, intraoperative outcome was 25 patients had difficult surgery and other 35 had easy surgery. In our study, the significant parameters we found that was male patients and patients aged more than 50 years and patient who had a history of acute cholecystitis and were admitted for the same, and patient who had history of diabetes mellitus and total counts who had more than 18,000 and gallbladder wall thickness more than 4 mm, and patients who had BMI more than 27.5 were found statistically significant both in intraoperative outcome and also the predictive scoring. Concluding the studies, USG was helpful for us to predict the scoring and history of the patient, and that our scoring system is reliable and it will be a useful tool to predict the cases. As prediction of the difficulty surgery is more important for surgeon to plan, it will help the anesthesia and all the OT team members to plan for open surgeries. However, our study was a small sample size. I suggest a large scale multicentric study could be useful to validate and establish the efficiency of scoring methodology. So the references. Hello, sir.
Please
Can you
unmute.
hear?
Sir, I can hear, sir.
Okay. Now, what is the reason that in male patients the cholecystomy is difficult? Is there any rationale? What is the reason for?
Rational one, sir. The insertion of the port may be difficult in male patients.
So that should not make the removal of the gallbladder difficult, because many surgeries are done in male patients also.
Yes, sir. Yes, sir.
So unless there are local changes which are related, for example, to the gender, insertion of port should not be the criteria for difficult cholecystectomy.
Yes, sir. Overhanging liver edge may be also a reason, sir.
Okay. Why diabetes mellitus should be the factor, for example, for difficult cholecystectomy?
Which one, sir?
Why diabetes mellitus should be a factor for difficult cholecystectomy?
Any patient with chronic diabetes mellitus have higher chance of any acute symptoms, sir. And they will be on regular medications and any other.
No, medication should not decide the local changes in the gallbladder.
Yes.
So unless there are local adhesions, so anything which can make, for example, where the adhesions are relatively more common there, that should make the cholecystectomy difficult.
Yes, sir.
So why diabetes should, for example, should be a factor?
Yes, sir. For adhesions.
For adhesions. Now the patients who had wall thickness more than 4 millimeter there was significant problem in the
Yes, sir. We found more than
yes,
sir, more than 4 mm thickness of gallbladder wall found in ultrasonogram. We had difficulty in grasping the gallbladder, and
okay,
we had problems in intraoperative, sir.
Now, did you find in such patient the incidence of carcinoma of gallbladder where the wall thickness is more than 4 millimeter? Did you get any patient on histology after cholecystectomy you could find the carcinoma of gallbladder?
Sir, carcinoma, sir, you're asking?
When the wall thickness is more than 4 millimeter, you said.
Yes, sir.
My question is that incidentally, did you find the carcinoma of gallbladder in those patients who had got a increased wall thickness?
No, sir. In 60 patients, we didn't get any. 2 cases of gallbladder polyp we found, sir. That's
okay.
no
So
cases.
No case of carcinoma of gallbladder was.
No, sir. In 60 patients, we didn't get any.
Okay. Are there any other questions from anybody?
No, sir. I think the time is also short, and he's presented quite fine.
Okay. Okay. Thank you.
Thank you, sir.
Dr. Pankaj, please
Thank you,
share
sir.
the screen.
Am I audible, sir?
Yes.
Hello.
Yes, yes.
Yes, you are.
Hello.
Sir, please present.
I am Sir Dr. Pankaj, second year resident in General Surgery, Department Department of General Surgery in BJ Medical College, Civil Hospital, Ahmedabad. Sir, my topic is laparoscopic management of the hereditary cyst of the liver with the Palani value hereditary system over the period of the 1 year, a case series of the 8 patients. Sir, hereditary disease is caused by the Echinococcus granulosus. The human are the accidental intermediate host. The liver is the organ most commonly affected by the parasites. One loss in the liver, the hereditary cysts grow steadily at the rate depending on the resistance offered by the surrounding tissue. Initially asymptomatic, the clinical complaint arises as a result of the compression of the adjacent organ due to the growing cyst or the complication like the rupture, infection, and fistulization. Though the hereditary cysts are known to regress continuously in overwhelming majority, the therapeutic intervention is necessary. The conservative management in form of the medical therapy or the percutaneous aspiration of the cyst have been described. The mainstay of the treatment remains the surgical. The variety of the surgical procedures have been described, including the pericystectomy, de-roofing of the cyst with the omentoplasty, marsupialization, and the liver resection. The technique of the minimal invasive surgery have also been adopted. One of the chief concerns during the surgical treatment of the hereditary cyst remains the possibility of the cyst rupture and the spillage and its containment. There is an increased risk of the anaphylactic reaction as a result of the hereditary cyst is highly energetic and the delayed risk of the dissemination of the disease in the peritoneal cavity. The difficulty in containing spillage during the laparoscopic management is much greater in the open conventional surgery. This factor has always the deterrent to surgeon from widely adopting the laparoscopic surgery as the mode to treat this disease. We describe the correct technique to utilize a specialized hydrated trocar system designed to allow the spillage-free evacuation of the hydrated cyst and enable the intracystic inspection of the residual daughter cyst and the cystobiliary communication. Material and the methods. This is a retrospective study. The all cases of the hereditary cyst present to us from February 2019 to February 2020. The laparoscopic management offered to all patients diagnosed with the hereditary cyst except in the segment 7 and segment 8 and totally intrahepatic cyst and the patient unfit for the surgery under general anesthesia. The patient were evaluated clinically and routine investigation done. Patient undergo USG and the CT scan. This is the photograph of CT of the one of the patient showing the hereditary cyst involving the almost whole the liver. The patient was started on the albendazole in the dose of 10 mg per kg 2 weeks pre-operatively and then 6 weeks post-operatively. The patient will operated under general anesthesia in the supine position, operating surgeon on the right side of the patient and the assisting surgeon on the left side of the patient. Monitored at the head end of the patient. This is the hydrated trocar system, the Palani value hydrated system. The upper photograph is of the cannula 286 centimeter long, 12 mm diameter. This is for the A is for the suction apparatus, B for the gas insufflation. This is the cannula trocar of the Palani value system. With E suggests of the fenestration, D is there is a two opposite fenestration, and C is for the suction. This is the port side. One major supraumbilical port and other two ports on the right and left hypochondrium, and the one extra port can be added for detection of the gallbladder depending on the surgeon. This is the technique in which we introduce the hydrated trocar cannula into the abdominal cavity, and after entering the abdominal cavity, we remove the trocar and cannula touches the cyst. After touching the cyst, the suction apparatus is attached creating the vacuum seal, which prevents the spillage of the hydrated content. Then trocar is introduced with the suction apparatus, and trocar is introduced inside the cavity, and then the suction of the content done. Lastly, the cyst is filled, when the content are evacuated, the cyst is filled with the 0.5% cetrimide solution and remain for the 10 minutes and suction off. Then cannula is removed and cyst will open up and excised and placed in specimen bag and removed. The cavity is checked for bile leak and cystobiliary communication. If any such communication are identified, they are over and with the interpreted suture of the 30 polygalactin 910. The cavity is packed with the omentum. Whiteboard drain is kept, saline was given, and the facial ports is closed greater than 5 mm. The patient has started liquid orally after 12 hours, and the discharge after once patient get afebrile and with nil discharge. Patient will call for the follow-up of the 7 days, 30 days, and 6 months. The ultrasonography performed 6 months after the surgery. The results: there are total 8 patients eligible to included in this analysis. There are 5 males, 3 females. The average age of the patient including 37 years, ranging from 23 to 58 years. All of the 8 patients, the 7 patients were rural agricultural background, and 1 patient was from the urban setting. The commonest present complaint include the abdominal pain and the heaviness exacerbated by the meals. Symptom reported by the 6 of the patient, nausea and dyspepsia by the 5 patients, and the mass was noticed by only 2 patients. The patient had a single cyst. The right top of the liver was involved in the 7 patient and left lobe in the 1 patient. All patients were started on the albendazole orally and were scheduled for surgery 2 weeks later. A duration of the surgery ran from 55 minutes to 120 minutes. There is no intraoperative complications. The range of hospital was 3 days to 15 days. And out of 8 patients, no recurrence is found in the 6-month follow-up period. The discussion. The hydatid disease is the endemic entity in several parts of the Indian subcontinent. The life cycle of parasite is such that the human infestation is likely in the area where they are living the proximity to the intermediate host, sheep and goat, and the definitive host dogs. Patient belongs to the rural agriculture background where livestock are maintained. In an area where there is a population of the stray dogs, the adult as well as the children coming in contact with the infected strays can get infested with the parasite. This explains the reason for the disease in the 1 patient who belongs to the urban background. In our study, no history of the contact with the livestock, but contact with the stray dogs were present in this case. In our study, more males are involved than the females, but a few other studies also suggest that there is an equal predilection in both the sex. The disease is known to progress asymptomatically for the several years due to the slow growth rate of the cyst before manifestation with the symptom related to the pressure effects to surrounding organ and infection in the rupture. The rupture of the cyst into the biliary tree releases the daughter cyst into the biliary system, causing the obstruction, jaundice, and the infestation. Both USG CT are reported to highly effective in diagnosing the liver, and the predilection for the right top of the liver was seen in our study. The main concern in the laparoscopic drainage of the hepatic cyst is regarding the spillage of the hydrated fluid. The reduce this possibility, surgeons in different parts of the world have developed a specialized device. The device was we utilize the Palani value hydrated system, allow the maintaining a seal while draining a cyst, preventing any leakage of the cyst fluid. It allows the complete evacuation of the cyst and its content and facilitates the intracystic inspection of the cyst. The effectivity of the device can be gauged from the fact that we didn't encounter a single case of the anaphylaxis and the delay abdominal recurrence in our series. We perform a omental packing of the cyst to reduce the dead space and the problem associated with it. Among the agents used in medical treatment, the albendazole is the far most popular due to the greater absorption and penetration, but Rhodes' standalone role is doubtful. It is a well-defined role as an adjunct to the therapy, adjunct to the surgery to reduce the post-operative recurrence in the disseminated disease and the inoperable cases. While surgery has established itself as a definitive therapeutic modality for the disease, the laparoscopic surgery is own limitation. The minimal invasive surgery is not suitable for the cyst located intraparenchymally in the liver, located in the posterior segment of the right lobe of the liver, and the recurrent disease due to the extensive adhesion involved. The large case of cyst will not. Yes.
Hello.
Hello.
Can you
Yes,
just
sir, you
conclude?
Yes, sir. Sir,
Can
my
you
conclusion is
mention?
yes, sir. My conclusion is that we can operate the patient of the hydatid cyst located superficially, not intraparenchymally, and the larger cyst by the pulmonary valve hydatid system without any recurrence, without any spillage of the spillage-free evacuation of the cyst content, and decrease incidence of the anaphylactic reaction, sir.
Which cyst, what do you think about what should be the management in calcified hydatid cyst?
It is a pericystotomy, sir.
In calcified?
Yes, sir. We remove the cyst with the wall, sir, but there is a chance of the bleeding and the cystobiliary communication, cystobiliary leak.
Calcified cyst, it is said that the calcified cyst, whatever is the, say, the parasite is not viable when the cyst gets calcified. The protoscolaces may not be viable.
Yes, sir.
So why calcified cyst requires surgery?
Because of the patient having the symptoms, sir.
No. Now here there is no spillage when you use the Panadiveru, this cannula trocar system.
Yes, sir. Yes, sir.
There is no spillage. Do you think that these patients require postoperative albendazole? And if yes, why?
Yes, sir. Yes, sir. Yes, sir. Postoperative albendazole.
Why do they require? Because you are using the scolicidal agent also. And if there is no spillage of fluid, what is the rationale of using albendazole in the postoperative period? When there is a spillage, one can understand that yes, you have to use the albendazole. Here you say if there is no spillage, then why albendazole should be used?
No, sir. No, sir. Oh, yes.
No idea. Now, did you get, for example, any bile leak in these patients? Whatever 8 patients you have selected,
Yes, sir.
was there any postoperative bile leak?
No, sir. No patient having the postoperative bile leaks.
How do you diagnose the, for example, biliary communications intraoperatively?
By, sir, the intraoperatively, sir. Sir, while draining the bile will come in the cystic cavity during the intraoperative, sir. We can use
Because if there is biliary communications, you cannot put this scolicidal agent inside.
Yes, sir. Yes, sir.
So intraoperatively, how do you diagnose the biliary communications with the cyst?
Intraop, sir, cholangiogram, sir.
Intraoperative cholangiogram. Do you do it routinely?
No, sir. No, sir.
So,
Endoscopy.
tell me, how do you diagnose?
ERCP, sorry, sir. ERCP, sir.
No, that becomes an additional invasive procedure. Whatever fluid you aspirate, if it is bile stained.
Yes, sir.
And when you, for example, put the scope inside the, say, residual cavity, you can see some bile leaking there.
Yes.
That may tell you that there is a biliary communication.
Yes, sir. Yes.
And in the presence of biliary communication, it is better to avoid the scolicidal agent because that may
Yes,
cause
sir.
the cholangitis.
Yes, sir. Yes.
Okay.
Thank you, sir. Thank you, sir.
Are there any more questions from anybody? If not, okay, thank you.
Thank you, sir.
Do we have any other presenter?
No, sir, all over.
They are all over.
Only one presenter is not joined, Venkata Satish.
Okay, okay.
Okay, sir.
So, how should I send this, whatever are the marks? Should I send it by mail?
Sir, I don't know this.
You have to just inform me how am I supposed to send the marks if they require marking.
Wait,
So,
wait, sir, I need to confirm.
I think these are the free papers, therefore marking is not necessary. Is that right? Is that okay? Hello? Hello? Should I close?
Sir, you need to send the mail organizer.
Okay, the mail has to be sent to the organizers.
Yes, sir.
Okay. Okay, thank you.
You're welcome, sir.
Thank you very much.
Hello, job events. Ma'am, please start the session.
Yes, yes. Hello,
Yes, ma'am.
can you hear me?
Yes, ma'am.
Huh. Okay.
Ma'am, please start the session. Call
Huh.
first speaker.
Huh. Good evening, everybody. Welcome you all. Now I would invite the first speaker. Uh, can you hear me?
Yes, ma'am, I can hear you.
Okay. So I invite the first speaker to start with his deliberation. Thank you very much.
Dr. Giridharan, please start.
Yes.
Dr. Giridharan, please.
Good morning, sir.
I think I'm audible, no? Yeah.
Yes, ma'am, you are
Yes, ma'am.
audible.
Thank you.
Good morning, everyone. Today, my presentation is about prevalence of type of gallstones in South Indian populations, which is a cross-sectional observational study, ma'am. So, introduction. We all know that gallstones are most common symptom and clinical syndrome affecting humans, which has been found since a long time. They affect around 10 to 15% of the adult population in Western societies. The overall incidence of gallstone is thought to be about 1.39 per 100 years. In developed countries, more than 85% of gallstones are cholesterol stones, whereas in third world countries, the most common stone is the pigment variety. So people with asymptomatic gallstones eventually may develop symptoms which require treatment, but the risk is quite low, averaging to 2 to 3% per year and about 10% by 5 years, ma'am. Since 1950, the number of surgical procedures for cholelithiasis has markedly increased in developed countries. And from 1999 to 2000, the number of cholecystectomies done has increased by more than 28%, especially after the introduction of laparoscopic cholecystectomy, ma'am. So, in review of literature, we have seen that one study by Priyash Halgoenkar and all, they did a prospective cohort study among 100 gallstone patients over a period of 18 months. Ma'am. They found that 76% of the participants had cholesterol stones, 19 had mixed stones, and 5% had pigment stones. Whereas a similar study done in India by Hemalata Sharma and all, which also conducted among 100 patients, showed that for 24 had cholesterol stones, 46 had mixed stones, and 30 had pigment stones. There has been no credible or large study which shows the exact prevalence of the type of gallstone present in the Indian population, ma'am, especially in South Indian population, ma'am. So this study aims to find the exact prevalence and the distribution of the type of gallstones among the South Indian population. So methodology, all the patients who are admitted in the general surgical and surgical gastroenterology departments of Government Stanley Medical College from September 2019 to September 2020 were included in the study, ma'am. Patients who underwent both emergency and elective open and laparoscopic cholecystectomy were included in the study, ma'am. It was a cross-sectional observation studies. The gallstone which was obtained from the specimen was then analyzed by colorimetry method, which was available in our own laboratory, ma'am. So the results we see that out of the total number of 97 patients who underwent cholecystectomy in the 1 year period, ma'am, 42 patients had cholesterol stones. Another equally amount of 42 patients had mixed stone, and whereas only 13 patients had pigment stones, ma'am. So the overall percentage was equally divided among cholesterol and mixed stones, with less prevalence of pigment stones in the total population, ma'am. So here, according to age group wise difference, we see that pigment mixed stones are more common in younger age group of 21 to 30, where we see 83% of the stones were pigment stones in the younger age group in 21 to 30, and similarly, 55% of the stones were pigment stones in the age group of 31 to 40. But as we increase the age in the middle age group, we see that cholesterol stones become more prevalent at 54.5%, followed by pigment stones at 33, followed by mixed stones at 33% now. And as we progress in the elder age group, 93% of stones up in 51 to 60 years were cholesterol stones, and 100% above 60 years was cholesterol stones in our study, ma'am. Similarly, gender-wise variation, we see that among male patients, both male patients and female patients. In male patients, we see that pigment stones are more common than cholesterol stone and mixed stone, whereas in female patients, mixed stones and cholesterol stones are more prevalent than pigment stones, ma'am. So this shows the variance among the gender between the type of stone produced in the gallbladder, ma'am. So the discussion, The most common type of gallstone, which was shared by both cholesterol and mixed stone, with pigment stone being the least frequently formed, ma'am. The mean age of persons with cholesterol stone was higher with 51.5%, as we see in the graph for age-wise distribution. Whereas for pigment and mixed stones, it is only 35.6%, which is the mean age, and 34 years, which was the mean age, ma'am, showing a significantly lower population, lower age group having producing pigment and mixed stones, whereas older age group producing cholesterol stones, ma'am. So the blood group of the patient was no way related to type of gallstones formed. It was equally distributed among all types of blood groups, ma'am. There was also no correlation between the diet of the participants or the blood group of the gallstone formed, ma'am. So the conclusion of my study is that the older population has been identified as having greater propensity to produce cholesterol stones. This may be hypothesized due to the decrease in activity of the enzyme cholesterol 7-alpha hydroxylase, which converts cholesterol into bile acids in the older population, thereby increasing the level of cholesterol in the bile, leading to cholesterol stone formation, ma'am. Similarly, we found that younger population has more of mixed stones and men have more of pigment stones, ma'am. This I hypothesize is due to the alcoholic intake among the men and younger population, which I studied, which found to produce more pigment stones because of the higher bilirubin levels associated with liver cell injury and pancreatic injury, leading to bile stasis in the younger population. And that is in the alcoholics and the men, leading to formation of pigment stones rather than cholesterol stones, ma'am. So these are my references, ma'am. So thank you, ma'am.
So, Doctor, I would like to ask you one question.
Yes,
and that is, like you said, that the younger age group has more of pigmented stones. No,
yes.
Was there any associated disease also present with the younger generation who showed up with pigmented stones?
Yes, ma'am. We analyzed patients with having, if they had any other diseases, like we did peripheral smear for them, ma'am. We checked the GGT levels. We did their alkaline phosphatase levels, ma'am. But we found no other associated diseases for the younger population, ma'am. The only thing we could find out was that the most of the younger males which we studied were alcoholics, ma'am. Other than that, we did not find any other abnormalities like hemolytic anemias or any bile duct abnormalities or strictures or pancreatic.
Sickle cell anemia and all, you didn't find in any of the
No,
cases?
ma'am, we didn't find, ma'am. We did peripheral smear. We evaluated completely and only found included those patients who had no other extra causes of bile duct abnormalities or pancreatitis or hemolytic anemias, ma'am.
Okay. So on the other hand, when you said that in the elder age group, cholesterol was more this thing, cholesterol stones were present.
Yes.
So did these patients had the feature of metabolic syndrome or hyperlipidemia?
Yes, ma'am. We also evaluated their serum cholesterol levels and fasting triglyceride levels, ma'am. We found that the female age, more than the males, and the more than 50 years age group, the females had higher levels of serum triglyceride and serum cholesterol levels, ma'am. But among them, the diabetics were only 32, ma'am. About of the total 197 patients, only 32 are diabetics, ma'am. And even in those diabetics, the sugar was under control, but the serum cholesterol and triglyceride levels were elevated, ma'am.
Okay. Anyone else wants to ask anything?
No other one chairperson, ma'am. Only you and you.
Okay, okay. It's okay. Thank you so much,
Thank
Dr.
you.
Giridhar.
Thank you.
Next is Dr. Karthik.
Doctor?
Karthik.
Yes, ma'am.
So now I invite Dr. Karthik to present. Yeah. Just give a brief intro, Dr. Karthik, and
Yes.
then start with the study.
Yes, ma'am. Are my slides visible, ma'am?
Yes, yes.
Yes, ma'am. Ma'am, good evening, ma'am. I'm Dr. Karthik from PG third year in UCMS and GTB Hospital from Delhi. So, ma'am, shall I start, ma'am?
Yes, yes.
Yeah. Good evening. I would like to present my study or prospective study to compare the outcome of amoebic liver abscess in a patient with and without alcoholic liver disease. Introduction. Alcohol plays an important role in the etiology of amoebic liver abscess. Amoebic liver abscess in the background of alcoholic liver disease has been reported to be a more fulminant course as the patient are prone to develop acute and chronic liver failure. However, no specific management protocol have been defined for this group of patients. Hence, the first step in this direction would be to study how the clinical course and outcome of the treatment of amoebic liver abscess in an alcoholic liver disease differ from the patient without alcoholic liver disease. Our aim was to compare the outcome of amoebic liver abscess in patients with and without alcoholic liver disease.
Objectives were first to study the severity of infection and rate of complication in a patient with amoebic liver abscess with alcoholic liver disease as compared to those without it. Second was to compare the response of medical treatment and indication of surgical intervention. Third and final was to compare the length of hospital stay and mortality rate between the two groups. In our study, we took a convenient sample of 120 patients that were divided into two groups of 60 each. Group 1 was amoebic liver abscess without alcoholic liver disease, and Group 2 was amoebic liver abscess with alcoholic liver disease. We included patients with more than 18 years of age admitted with diagnosis of amoebic liver abscess. We excluded patients with pyogenic liver abscess, any comorbidities as CAD, COPD, medication like steroids, or any chronic liver disease due to etiology other than alcoholic liver disease. In our study, we defined amoebic liver abscess based on the clinical criteria, a laboratory investigation, ultrasonography, aspiration wherever indicated of Anchovy sauce pus, and culture showing no bacterial growth. The diagnosis of alcoholic liver disease was made based on the history of significant alcohol intake or any abnormality in liver profile like deranged liver enzymes, INR more than 1.5, albumin less than 3, or radiological evidence of cirrhosis. In our study, we also defined acute and chronic liver failure as an acute hepatic insult manifesting as jaundice, serum bilirubin more than 5, coagulopathy, INR more than 1.5, complicated within 4 weeks either by ascites or encephalopathy in a patient previously diagnosed or undiagnosed chronic liver disease or cirrhosis. Those patients who showed the sign of acute hepatic injury leading to decompensation, manifested as coagulopathy or development of pedal edema or ascites, but not meeting the criteria of acute and chronic liver failure, were designated as patients with impending liver failure. For management, we use 4 modalities. Abscess less than 200 ml, we treated them conservatively. Those between 200 to 400 ml were treated with percutaneous aspiration. Above 400 ml, a pictal catheter was used. Ruptured liver abscess causing peritonitis, open surgery was done. And any patient showing signs for liver failure like jaundice, ascites, pedal edema, encephalopathy, deranged angina were treated with pictal catheterization, even when the abscess size was smaller. In our study, we used ciprofloxacin, metronidazole, first line of antibiotics. Higher antibiotics like tazobactam or linezolid, along with metronidazole, was started in any patient that showed decompensation, like again jaundice, ascites, pedal edema, or those who failed to respond within 48 to 72 hours after primary first line antibiotics, as noted by fever, increased leukocyte count, or increased abscess size. And the patient also who developed acute and chronic liver failure was started on albumin infusion for 3 to 5 days, depending on the resolution of symptoms. Patients were discharged when they were asymptomatic for at least 48 hours. Following observations were made. In Group 1, 32 patients gave a positive history of alcohol intake. In Group 2, 60 patients gave a positive history of alcohol intake. And we can see the both in terms of frequency of alcohol intake and duration of alcohol intake was significantly higher in Group 2 patients. Coming to symptoms and signs, pain and fever were most common symptoms in both the groups, but only significant difference was seen in nausea and vomiting and fatigue, which was significantly higher in Group 2 patients. Signs like jaundice, splenomegaly, ascites, and pedal edema were also seen significantly higher in Group 2 patients. We noted that the investigation of the patient at the time of admission and discharge, apart from total leukocyte count, all other investigation like liver enzymes, total bilirubin, INR, albumin was significantly more deranged in the Group 2, that is with alcoholic liver disease. Size of abscess, mean volume of the abscess was significantly higher in Group 2 as compared to Group 1, and more number of patients has, as you can see, had more larger abscess, that is more than 500 MCC. On treatment part, we were able to treat most of our patient of Group 1 with first line antibiotics only, but more number of patients in Group 2 needed higher antibiotics, that was tazobactam, linezolid. Same was the case with albumin infusion and plasma infusion. And the mode of intervention, we were able to treat most of our patients of Group 1 by conservative treatment, but this was not the case in Group 2, where most of the patient underwent either a needle aspiration or a catheter insertion. Coming on to the complication, pleural effusion was most common complication in both the groups, but it was significantly seen more frequently in Group 2 patients. And complication like jaundice, acute and chronic liver failure, and impending failure was seen significantly in larger number in Group 2, that is the patient with alcoholic liver disease.
Finally, comparing the mean hospital stay, the group 2 patient had a longer hospital stay around 8 to 9 days as compared to group 1 that showed 4 to 5 days. And during our study, there was one mortality of a patient that was again the group 2 patient. So I would like to conclude by saying that in view of more aggressive course of amoebic liver abscess in a patient of alcoholic liver disease, it is recommended that a patient with alcoholic liver disease should be started on higher antibiotics. The threshold of abscess drainage should be lower. There should be an active management for reversal of impending failure, either by replacement of albumin or clotting factors. And finally, a detailed assessment of alcoholic liver disease should be an important part of work of a patient with alcoholic amoebic liver abscess. Thank you, ma'am.
Okay. Can you go back to the slide before the complication one? Can
Yeah,
you
ma'am.
go
Sure.
back?
I think they've stopped sharing my slides. Just a moment,
Okay.
ma'am. Before this
Here.
one. Yeah, ma'am.
This one, no, you have said that here the treatment part, no, the first group had more conservative. And
Yes, ma'am.
like,
Yes, ma'am. Yes, ma'am.
so in the first group, the alcoholic one were very few. How
Yes,
did
ma'am. Yes,
you
ma'am.
how did you judge that they were very few? Were they not responding to the treatment?
Ma'am, in group, ma'am, first of all, we took a history of positive alcohol, whether alcohol intake was there or not. And that's what
That
you're
is
asking.
okay. You have already put them in the second group,
Yes,
no,
ma'am. Yes,
because
ma'am.
they were
Yes, ma'am.
alcoholic.
Yes,
So
ma'am.
conservative treatment, no, you have
Yes, ma'am.
directly
Yes, ma'am. Yes,
taken
ma'am.
them to the
That is
second
we
group of
reassess the. Yes,
treatment.
ma'am. Sorry, ma'am. We reassess the patient within after 48 to 72 after keeping on a conservative management only. If there
Okay.
was signs of fever, increased abscess size on repeat scanning, or the not patient was not looking toxemic, then we shifted them into a. If not, we kept on treatment with the first line antibiotic. If patient did not respond, we shifted them on higher antibiotics.
Okay. So it seems from your study that the second group hardly responded to the conservative treatment.
Yes, ma'am.
So they had to be shifted to the second line of treatment.
Second line of treatment. Yes, ma'am.
The next slide, no, the complication one.
Ma'am, they keep on.
No, okay.
Doing my
I'll just
slide.
ask you. No
Okay,
problem.
ma'am.
No
Sure.
problem.
Yes, sure.
See, in the second, you have referred to pleural effusion.
Yes,
No?
ma'am.
So pleural effusion, like so many patients had pleural effusion in the
Yes,
alcoholic
ma'am.
group. Because your graph
Yes, ma'am.
shows quite a taller this thing, no?
Yes, ma'am. Yes, ma'am.
So
Ma'am,
all these
we could explain mainly we explain because in the patient when they had higher larger amount of size, larger size of abscesses, maybe that would have been a reason, and they're more hypoalbuminic also. Maybe that would be a reason because the
but
nutrition.
if you see the graph, no, it looks that majority of the patients in the alcoholic group had pleural
Ma'am,
effusion.
maybe I'll
Was
just.
it really true?
Yes, ma'am.
Okay. Okay.
Yes, ma'am.
Thank you
40 to
so much.
70%.
Thank you so much. Thank you so much.
Thank you, ma'am.
Ma'am, next is Dr. Reena.
Dr. Reena,
Yes, good afternoon, ma'am.
good afternoon. You can start with your presentation.
Yes, ma'am. Good afternoon, ma'am. I'm Dr. Reena Prasad from IMS BHU Varanasi, third year resident from Department of General Surgery. My topic is effect of bacteriophage on infected traumatic wound, a prospective study.
Okay.
Trauma. The word trauma means a sudden, unexpected, sustained, not only physical but also a psychic injury. 18 million deaths worldwide occur mainly due to trauma, and the most common age affected is 15 to 45 years. Infection is the second cause of death in the trauma. The first being the head injury. The challenges that surgeon faces in the traumatic injury is not the abrasion but the large lacerated avulsed wound with polymicrobial infection, as you can see on the top of the slide. Now the solution to this is the bacteriophages. What are these? These are obligate, highly specific intracellular viruses that infect bacteria and kill them. How it is a process? The viruses attaches to the bacteria, inject its DNA into the bacteria, take over the machinery of the bacteria, synthesize its protein, and then finally, after assemblance, release from the bacteria after lysing it. Now, if the same physiology occur on the wound surface area, the infection will get cleared off. Aims and objective: potential alternative of topical antimicrobial therapy for the treatment of acute infected traumatic wound, and a solution to multi-drug resistant, extensive, and pan-drug resistant bacteria where the implication of antibiotic is limited in pan-drug method. After getting approval from CTRI with registration number CTRI 2019 .902147, the study was carried from September 2018 to July 2020. 54 patients were recruited from age 12 to more than age more than 12 year to less than 65 year. 27 were included in case group and 27 were included in control group. Wound swab and tissue biopsy was taken for bacterial isolation. Cases specific phage were isolated against the bacteria that were present on the wound, and it was applied locally on alternate day till the wound becomes sterile. In control, we underwent debridement and dressing with normal saline and iodine, and along with systemic antibiotic according to sensitivity report. My patient selection inclusion criteria were all traumatic wound, big lacerated avulsion and degloving injury, wound of any size and depth, written and informed consent. Exclusion criteria: patient who denied consent, burn patient, malignant ulcer, ulcer due to systemic disease, vascular disease, and due to skin disorder. My results were: in cases at the time of admission, 63% patient had polybacterial infection and 37 patient had monobacterial infection. After the application of non-specific bacteriophage, that is a non-specific cocktail phages that is most commonly encountered during the wound was Pseudomonas, Klebsiella, and E. coli. These were applied on the wound for initial 4 to 5 days. This is the day that is required for specific isolation of the phages. After specific non-specific application, the polybacterial count was decreased to 18.5%, and by the end of the study, or after the application of specific phage therapy, the 76% patient developed sterile wound, while in control, at the time of admission, 81.5% had monobacterial infection, and 18.5 had 18.5 has polybacterial, which after 1 week of conventional therapy increased to 37, and at the end of the study, which is 6 weeks, only 18.5% patient developed sterile wound. Looking to the outcome that patient had underwent, 74.5%, 74.1 patient underwent SSG because patient developed granulation tissue very early, while 18.5% developed wound closure by secondary intervention in cases. In control, 62.9 patient had a wound closure by secondary and tertiary intervention. Why? It is because the patient wound took longer time to become sterile for took longer time to attain sterility or to attain granulation tissue, such that during that duration, the wound underwent closure by secondary intervention by scar formation or wound contracture, and only 33.3% patient underwent SSG in case of control. Now, full granulation was attained with 0% slough in cases only in 15 days, average 15 days, while in control it was 23 days. Final intervention like SSG or closure by tertiary intervention, it was only 25 days, while in control it was 43 days. Average expenditure in treatment in both the group, taking a rough estimation, antibiotic was applied in the was taken by in control group as long as patient had the wound, so it cost very much. Expenditure in dressing, it was very much because it was a daily dressing, but in case of cases it was a alternate day dressing. wages loss, more than patient stay in hospital, more the patient will lose its wages along with their attendant and daily expenditure as per. This is the outcome of my study. The patient with degloving injury of the foot on day 1 and see on day 7 fully flushed after only 3 application of bacteriophages of bacteriophages, and by day 11 it is fully granulated to undergo skin split thickness skin grafting only in the matter of 10 days. In case 2, a large degloving of the leg in a matter of 20 days in single hospital stay of the patient had underwent the skin split thickness skin grafting. Case 3, in a matter that the stump underwent half of this reduction in a matter of only 6 days. From
Time is up.
Okay, sorry. My summary is that complete granulation in case was only in 15 days, while in control it was 25 days, sterility 25 and 45 days. Cost effectiveness, yes, cases is yes. Number of dressing is half the number of days in hospital stay, while in control it is number of days in the hospital. Antibiotic in control is as long, while in cases it was initially only 2 to 4 days. Please, I cannot control my PPT. Hello?
So, Dr. Deena?
Yes, ma'am.
So that means you think that if we apply this bacteriophage, so
Yes,
the healing will be better. So did you support these patients with antibiotics? Did you give them a this thing coverage for all this thing?
No,
Gram negative, gram positive. Did you give them a
yes,
coverage?
ma'am. In case of cases when we first encounter the patient during the tenure of cocktail application, we give the antibiotic, while during the application of specific phages we don't give antibiotic. While in control it went as long as the patient won't heal completely.
Okay. Okay. So then, do you think these patients are also subject to grafting also?
Yes, ma'am. Ma'am, in case of cases, 74.1% underwent SSG during their hospital stay, which ma'am, sterility attainment was 25 days. Means within a period of 15 to 20 days of admission, or patient underwent 74.1% underwent SSG.
Okay. So the results were good with the skin grafting?
Ma'am, it is actually extremely good. In my experience, once the phages is applied, the further necrosis of the wound is further stopped. The muscle don't degenerate, and it doesn't degrade. Once you apply the phages, the wound will have to be, means it is 110% assurance that people will get healed.
No, but grafting doesn't depend on the condition of the muscle. No, it depends on the granulation on the
Ma'am,
bed.
granulation is attained, and a patient who under the sterility means, ma'am, the patient had a perseus result of the wound is sterile, ma'am. Bacteriophages doesn't survive as long as if bacteria is not there on the wound, and bacteriophages are prokaryotic specific. They don't affect eukaryotic cells, ma'am.
Okay, thank you very much.
Thank you, ma'am.
Thank you.
Dr. Prajakta.
Good evening, ma'am.
Good evening. Who is the next candidate? Prajakta.
Ma'am, I am the next. Yes, ma'am.
Dr. Prajakta, you can start with your presentation.
Ma'am, is my screen visible?
Yes, yes.
Good evening, ma'am. I'll be presenting a paper on a study of traumatic brain injury in pillion-guided adult females, which was carried out on a tertiary center. I am Dr. Prajakta Vedak, junior resident third year in Department of General Surgery, MGMIHS, Navi Mumbai. I have done this study under the guidance of Dr. Neeraj Patni, who is the head of the neurosurgery department in our hospital. The majority of the road traffic accidents are the main factors who cause the traumatic brain injury in our country, which contributes to the 6th overall factor causing death in India. The more incidence is found in male population, usually due to alcohol influence, but there is a literature study which also says that the females are equally affected with traumatic brain injuries, and the pillion riders are the most common people who get traumatic brain injuries very easily because of non-wearing of the helmet and the collisions that occur on daily basis on the road. By 2020, it is estimated by WHO that the motor vehicle injury will become the third leading cause of global burden of disease in the world, and about 20% of the death are said to occur due to motorcycle accidents in the road traffic accidents. So purpose of my study was that since road traffic accident is a leading cause in our country, which accounts to total 59% of the cases, and pillions getting affected due to road traffic accident accounts to 12%. The females getting affected due to traumatic brain injury is rare but is not uncommon, and annually it is estimated that around 1,40,000 Indians are injured and killed due to motor two-wheeler road traffic accidents. So the aim of my study was to analyze the various factors which were related to the traumatic brain injury in the females, and the objective of my study was to study the various modes of injury, head injury that were occurring in the female, and to study the management and the outcome of the head injury in the female pillion riders. So all the adult females who visited our emergency with the history of traumatic brain injury were considered for our study with the proper ethical committee approval. A total of sample size of 75 was considered. After a proper primary and secondary survey as per the ATLS protocol and resuscitative measures, the patient was investigated and managed as per the findings on the investigation of CT scan. The outcome was tabulated and the observations were as follows. The most commonly involved group in the road traffic accidents was from 30 to 40 years, and the mean age was 25 years. Total of 25 patients out of 75 required an emergency decompression craniotomy due to different due to presence of extradural or subdural hematoma. And as we can see in this picture, this is the collected hematoma which has been after the decompression craniotomy. When a correlation was plotted between the GCS at the presentation and the traumatic brain injury, it was found that the lower GCS, the patients who presented with the lower GCS had a very severe type of traumatic brain injury, having either extradural hematoma or a subdural hematoma, and the count was significant with a significance level of 0.01. When we correlated the mode of injury and the relation of the severity of the traumatic brain injury, it was found that mode of the head-on collision that occurred during the road traffic accidents was related to a severe damage to the brain causing severe traumatic brain injury, accounting to 21 total of 21 patients having severe traumatic brain injury. The majority of the patients who attended our hospital had a head-on collision, which is also one of the most common type of collisions occurring on the road. The other being side collision, rollover of the vehicle, and rear-end collision. This is a bar chart which shows that the severity of the traumatic brain injury and the association of death in the patients along with the type of collisions. Here we can see that the head-on collision has a high rate of showing severe traumatic brain injury, whereas head-on collision and side collisions both have impact on the brain and lead to severe traumatic brain injury and can result in death of the patient. Therefore, it is considered as a major cause of mortality in road traffic accidents. So discussion, traumatic brain injury is the major cause of mortality and morbidity in road traffic accidents, and pillions are more affected due to not wearing the helmet. Impact of collision makes the pillion rider more vulnerable for major injuries. In our study, subdural hematoma was seen more commonly present, and it's also consistent with the literature studies. Basal skull fractures were present in 15% of the patients, and having associated facial trauma of maxilla in 11.9% patients. Total of 9 patients had succumbed to death due to severe traumatic brain injury post intervention, post surgical intervention, as well as when not intervened surgically. There was a study carried out by Kray Prasannan in fatal motor two-wheeler accidents, which shows consistent results as that of our study. The conclusion drawn from my study is that female pillion riders do suffer traumatic brain injury and have a major cause of mortality. Our study estimates that the impact and outcome of the traumatic brain injury is very severe in cases of road traffic accidents in the pillion riders, and a long-term follow-up is needed for such patients to maintain to know the condition of the patient and monitoring of the patient. And severe traumatic brain injury always results into disability and mortality. Thank you.
Dr. Prajakta,
Yes,
interesting presentation, but I just want to know that you said that the pillion riders were more affected in your study, no? So what was the result of the one who was in the driving seat?
Ma'am,
Were they not affected?
Ma'am, one major cause is not wearing of the helmet, and since our hospital falls on a very it's on highway, so where like accident zone is more prone, and the two-wheeler.
You didn't get my question. I just wanted to say that you said that your study showed that that there was the pillion rider was affected more.
Yes, ma'am.
So that means equally rider did no?
Ma'am, usually
Or
males are affected.
is it that only the pillion was and they didn't get any injury?
No, ma'am, both are affected, but since pillions.
It can never happen, no, that if the
Ma'am,
pillions can be affected more because they are not wearing the helmet.
yes, ma'am.
Okay, this is what you mean to say, no? The
Yes,
second
ma'am.
thing is you did a CT scan on all of them, no? So your decision was on the GCS or on the CT scan findings?
Both, ma'am.
Both. So according
Yes,
to the GCS, you decided to operate on those patients, no?
Yes, ma'am.
But then
Yes,
you
ma'am.
correlated the CT also.
Yes, ma'am.
Thank you very much.
Thank you, ma'am.
Interesting topic.
Thank you, ma'am.
Okay. So,
Next, Dr. Samuel.
Benjelina Samuel. Yes. Come on, Dr. Samuel, start with your topic.
Yes, ma'am. Good afternoon.
Good afternoon.
Is my screen visible, ma'am?
No, ma'am. Start sharing.
You are audible to me, but I can't see your screen.
Yeah, make it
Yeah,
full
now,
screen. Full screen.
Now it is visible.
Good afternoon, ma'am. I'm Dr. Evangeline Samuel, a second-year postgraduate student from the Department of Surgery in Jipmar, Puducherry, and I would like to present my paper titled Role of Nutritional Biomarkers in Predicting Postoperative Complications among Patients Who Undergo Elective Abdominal Surgery. Introduction to the topic, malnutrition has been defined as an insufficiency of proteins, energy, vitamins, and trace elements due to unsatisfactory and unbalanced nutrition. That is a BMI less than 18.5 or a weight loss of 10% in 6 months or more than 5% over 3 months, as has been defined as ESPN in 2015. Up to 50% of surgical patients have been found to be malnourished due to greater metabolic demands, due to the surgical intervention itself, insufficient nutrient intake and nutrient loss, but however, the burden of the disease has been chronically underreported. Malnutrition in a surgical patient leads to impaired wound healing and immunocompetency, as well as decreased cardiac and respiratory muscle function. It leads to a higher risk of mortality, morbidity, as well as a longer hospital stay. Malnutrition is a modifiable risk factor. It becomes vitally important for the surgeon to define the nutritional status of their patients operatively. Two methods exist for the determination of nutritional status: is dietary and biochemical. Dietary methods are subjective and tedious, which spur the clinician to choose a biochemical method, which tend to be faster, more objective, as well as a more convenient means in order to determine the nutritional status of patients. Coming to the aims and objectives, the primary objective is to determine the association between nutritional biomarkers and the occurrence of postoperative complications, while the secondary objective was to determine the association of demographic, anthropometric measures, and surgical characteristics with the incidence of postoperative complications in these patients. These were the definitions that were used in this study. Postoperative complications were graded according to Clavin-Dindo classification as major and minor. Anthropometric evaluation of malnutrition was done according to BMI as well as mid-upper arm circumference. Serum markers that were taken into account were serum albumin, protein, urea, and creatinine. And surgeries were classified into major and minor surgeries. The study was designed as a prospective observational study after the approval of the Institute Ethics Committee, and the sample size was calculated according to the normogram developed by Malhotra et al. With a sensitivity of 89% and absolute precision of 10% and expected prevalence of 20%. Got our sample sizes 175. We included all patients aged equal to or more than 18 years who underwent electro-abdominal surgery in our hospital, and we excluded patients who did not give consent. Data was collected using a structured proforma where anthropometric measurements were recorded twice, where the average was taken of weight, height, and mid-upper arm circumference. And the primary outcome of our study was measured as the incidence of postoperative complications until discharge. Statistical analysis in our study was continuous variables were recorded as median and interquartile range, while categorical variables were recorded as frequencies and percentages, which a chi-square test was applied. All variables underwent a univariate analysis where a relative risk and a 95% confidence interval was calculated, and all variables that showed a significant number were then multivariate analysis, and an ROC curve was plotted for such variables. Sensitivity and specificity was calculated for all significant variables where the area under the curve was greater than 50%. All statistical analysis was done using Stata for Windows version 14. Coming to the results, a total of 175 patients were enrolled in our study, where 105 underwent major surgeries and 70 underwent minor surgeries, where, as we can see according to this graph, majority of patients that have undergone major surgeries have had complications, where the most common type of complication was grade 2. This table shows the correlation of demographic and nutritional parameters with postoperative complications, where gender, BMI, as well, both gender and BMI showed a statistical significance with postoperative complication rate, where male patients and undernourished patients, both according to BMI and mid-upper arm circumference, had a great. This table shows the correlation of type of surgeries with postoperative complications, where the pathology for which the surgery was done, the type of surgery, the extent of surgery, as well as the surgical site, all showed a statistical significance, where surgery done for malignant causes, conventional open surgeries, major surgeries, and surgeries involving the upper gastrointestinal tract had a higher incidence of postoperative complications. This table shows the correlation of nutritional biomarkers and postoperative complications as per univariate analysis, where patients with hypoalbuminemia, hypoproteinemia, and an analysis where both albumins and proteins were taken showed a statistical significance, where 94% of patients with hypoalbuminemia, all patients, that is 100% of patients with hypoproteinemia, and 100% of patients with both hypoalbuminemia and hypoproteinemia were shown to have postoperative complications, while patients that had both a normal albumin as well as a normal protein had only 32% incidence of postoperative complications. Serum urea and serum creatinine did not show a statistical significance with postoperative complication incidence. Taking all the significant variables into multivariate analysis, the demographic details as well as BMI, mid-upper arm circumference, and surgical characteristics such as pathology, type, extent, and site of surgery did not not show any statistical significance, but however, patients who had hypoalbuminemia and both hypoalbuminemia and hypoproteinemia showed a statistical significance with the incidence of postoperative complications as seen in this table. The ROC curves were then plotted for serum albumin and serum protein, where a serum albumin level of 3.45 grams per liter showed an area under the curve of 83.2%, the sensitivity of 84%, and specificity of 83.8%, while the ROC curve for total protein showed that a protein level of 6.15 milligram per deciliter showed an area under the curve of 81.9% and a sensitivity of 100% and a specificity of 70%. So the conclusion of my study would be that the routine nutritional biomarkers such as albumin, total proteins, and a combination of both albumin and total proteins can be used as a measure to predict postoperative complication in patients who undergo elective abdominal surgeries. Male gender, BMI, mid-upper arm circumference, pathology type, extent, and site of surgery all showed a significant association, but on extending the statistical analysis for albumin and total proteins to distinguish between whether a complication would be major and minor, they did not show any statistical significance, and hence these routine biomarkers are only able to predict whether a complication would occur, but not whether the complication would be a major or a minor one. Thank you, ma'am.
So, doctor, one thing I just wanted to know was that they were all elective cases.
Yes, ma'am. All of them were elective abdominal surgeries.
They were all elective abdominal surgeries. Then, if they were elective cases, all, then why was the biomarkers so low? Why was the nutritional status very low? No. Because in all electives, normally you don't get this much of low biomarkers and the nutritional status. No.
Yes, ma'am. There can be two reasons for such a presentation, ma'am. One is that our hospital itself caters to a lower socioeconomic strata of patients who have a generally low nutritional status. And the second is a lot of these patients, due to the gastrointestinal nature of the disease itself, would have either a poor nutritional intake or a high catabolic nature due to the disease itself, leading to a malnourished state in these patients, ma'am. That is what
so that means that your patients, they must have faced a lot of complications also because of
yes,
the low this thing, no? So did you build them up first? Did you improve their nutritional status before you subjected them for surgery, elective surgery? Because when you are taking the patient for elective surgery, the intention is that the result should be good, and to get good results, the general stature of the patient is maintained. Yes, and you take it. So did you correct the hypoalbuminemia and the hypoproteinemia?
Our existing protocol in our hospital is to try to nutritionally optimize the patient before taking up an elective surgery. So the results of my study can be extrapolated to the fact that that elective surgeries can be postponed to an extent while it takes time to build up the patient nutritionally in order to achieve a better postoperative outcome in such patients.
So what I think was your presentation was good, topic was good, idea was good, but I think the segregation of the patients was not done properly, no? Because see, so many patients with elective surgery and so many patients with hypoproteinemia, it is a little difficult to digest. Okay, let's see. Thank you very much.
Thank you,
ma'am. Next, is there another candidate?
Dr. Ayush.
Yes, ma'am. Yes, sir.
Ayush Mittal.
Yes, ma'am.
Okay. Start your presentation, Dr. Ayush.
Yes, ma'am. My study is a randomized prospective comparative study of spinal versus anesthesia total extraperitoneal hernia, inguinal hernia repair. I'm the presenting person, Ayush Mittal, and my co-authors are Dr. Prabha, United Surgery Department, SMS, Unit 5, and Dr. R.G. Kandilwal. The cases, the inguinal hernia cases are increasing every year, and nowadays the patient want a minimal invasive technique for the surgery. The TEP is one of the preferred choices for minimal invasive technique because we need not to enter the peritoneum. And most of the
laparoscopic hernia surgeries are done under general anesthesia, there are very few studies which compare the general anesthesia and the regional anesthesia for laparoscopic hernia surgery. And there are several benefits of regional anesthesia for laparoscopic surgery. One of them is there is shorter post-operative stay, no airway manipulation, cost effectiveness, and post-operative reduced nausea, vomiting. And with the regional anesthesia, the minimal invasive laparoscopic surgeries could also be done in the comorbid patients, like old age patients, the patients with COPD, asthmatic, and several other causes. The aim of our study is to compare the spinal versus anesthesia in total extraperitoneal inguinal hernia repair. The secondary objectives are the comparison of post-operative pain, the comparison of post-operative complications, and the surgeon ease based on anatomical delineation and dissection of extraperitoneal space. The inclusion criteria is the clinical and radiological diagnosed patients with inguinal hernia. There are exclusion criteria: the patient with single or multiple lower abdominal surgeries, complicated inguinal hernia, irreducible obstructed or strangulated, recurrent hernias, coagulopathies, and uncorrected hypovolemia, absolute contraindications, allergy, increased intracranial pressure. The relative contraindications were coagulopathy, sepsis, fixed cardiac output states. This is a randomized prospective comparative interventional study done under the guidance of Dr. Prabham Mam under in a SMS surgery department this, from March to September. So all the patients diagnosed with the inguinal hernia were evaluated on the basis of inclusion exclusion criteria. Patients falling under the criteria were randomly given spinal and general anesthesia based on random table method. In GA, we gave propofol, fentanyl, rocuronium, sulfurine for tracheal intubation, and for spinal, we gave the hyperbaric bupivacaine and fentanyl. Comparison of surgeon ease during surgery based on anatomical delineation and dissection of extraperitoneal space was done. Post-operative pain comparison were done based on visual analog scale. There were also the comparison of adverse effects, complications, and rest analgesia. A prior written informed consent was taken, and TEP-MS hernioplasty, standard TEP-MS hernioplasty was done under the allocated anesthesia. So there were 80 patients included for the study. There were 10 dropouts. The 4 were complicated hernia. 1 has previous multiple abdominal surgeries, and 5 rejected for participation in the study. So there were 35 allocated patients in GA, and there were 30 allocated patients in spinal anesthesia. This is a male dominant study in which 97% were male in general anesthesia and the 100% male in spinal anesthesia group. And the mean age of our cases was 48 years. Majority of patients were in the age group of 46 to 60 years. Only 5 to 6% patients were greater than 75 years of age. So the bilateral and unilateral hernias were equal in both the groups in general anesthesia and spinal anesthesia. 8 were bilateral and 27 were unilateral. Also, the direct and indirect hernias were kept similar. There were 21 in a spinal anesthesia group, and indirect hernias was 14 in both the groups. So during the comparison, during the intra-op comparison of extraperitoneal space, dissection of extraperitoneal space, and anatomical delineation, 100% patients in GA group, there was easy extraperitoneal space dissection and there was easy anatomical delineation. And in the 97% cases in spinal group, it was easy. Only in 1 patient in spinal group, it was difficult due to large indirect sac and excessive extraperitoneal fat. And these results were insignificant because the p-value was coming greater than 0.05. And the mean time interval in the on the basis of hospital stay were also insignificant. The p-value was coming 0.396, so the results were insignificant. Distribution according to the VOS score, visual analog scale. During the first hour of post-op, during post-op first hour, the pain was very less and was almost nil in the patients with spinal anesthesia group, and the patients with the general anesthesia, there was excessive pain. So during the first fourth, there was a very high significant difference in the p-value, which was less than 0.001, and at the first and fourth, there was a significant statistical difference. difference. And at the 12th, 18th, and 24th hour post-op, there was not a significant difference in pain. So you can see at the first post-op hour, the pain in the patients with the general anesthesia group was much higher, and it was almost nil in the patients with spinal anesthesia group. The rescue analgesia was needed for almost every patient at the first hour, at the post-op hour first for the general anesthesia group, and for the spinal anesthesia group, the rescue analgesia was not needed at first hour and 8th hour. And at 12th hour post-op and 24th hour post-op, there was not a significant statistical difference between the two groups. The post-operative adverse effect, the most common adverse effect was vomiting. And the vomiting was more common in the patients with GA group, and hypotension and headache was more common in spinal anesthesia group. But these results were also non-significant because p-value was greater than 0.05. The post-operative complications in TAP, the seroma formation was the most common complication in both the groups, and rest of the complications were very few, like wound infection and all. So these differences are also non-significant. The conclusion is the total extraperitoneal surgery performed under spinal anesthesia provides adequate muscle relaxation and a suitable work environment as seen under the GA. It also protects the patient from possible risk of GA, that is airway manipulation, and the patients with comorbidities like COPD, asthma. TAP, total extraperitoneal inguinal hernia repair, can be safely performed under spinal anesthesia, and spinal anesthesia was associated with less post-operative pain, better recovery, and better patient satisfaction than GA. Spinal anesthesia is feasible, and in our experience, the preferable method of anesthesia for total extraperitoneal laparoscopic hernia repair. Less number of patients with the disadvantages of the present study. However, through this study, I'm unable to share my screen.
Your screen is not visible.
Time is over, sir.
Okay.
Yes, ma'am.
So Ayush, it's all right. Like there's not much of significance found in your study, and the only thing is that what I would like to say is that still I think spinal anesthesia is the best, unless and until indicated. No, you don't go in for GA because spinal the stay is less, the patient is comfortable, and the pain is less post-operatively. Hardly he needs a supplement of the painkiller.
Basically,
So,
ma'am, yes, ma'am.
yeah, I think your study goes more in favor on the spinal, no?
Yes, ma'am. With the spinal anesthesia, we basically could do the laparoscopic TP in the patients with comorbidities like COPD, asthmatic patients,
Yes,
and
yes,
and
yes.
there is very less post-operative pain, and the patient satisfaction was much higher in spinal group than the patients with general
Yeah,
anesthesia
yeah.
group. And also
I
there
think
were,
only if it is indicated or the patient asks for it, then only we should go.
ma'am, you are not audible.
That way, I think spinal is good enough anesthesia,
Yes,
and
ma'am.
it's okay. Your study shows the results are quite relevant. Thank you
Yes,
very
ma'am.
much.
Okay, ma'am. Thank you.
All the best. So next, do we have any more speaker?
No, ma'am.
Finished. So what we have to give some results or something
Mail to organizers.
to the organizers. Okay, okay. So with this, we finish the session, no?
Yes, ma'am. On time.
Okay. Thank you so much.
Thank you, ma'am.
Thank you.
Hello. Hello.
Yes, Dr. Avinash Supe.
Yeah. How are you, Professor Kale?
Yeah, fine. The next session, 5:15 is supposed to be ours.
Yeah, so we'll wait till that time so that others can join. I
Join
think 10
in,
minutes is okay.
Yeah.
Prathamesh? Dr. Prathamesh?
Yes,
Dr.
sir.
Prathamesh, have you checked your presentation?
Yes, sir.
Okay. And you are the first speaker, right? 5:15 we will start. We still have 15 minutes.
Hello, good evening, sir.
Hello.
Session will start 5:15.
Yes, we'll start at 5:15. No issues.
Yes, sir.
Okay. I'll just finish some other work and I'll join at 5:15.
Sir.
Dr. Kale, you will be also there tomorrow?
Yeah, I'll be also there tomorrow, yes.
Okay.
Same time.
Same time, right?
Yes, yes.
Because the session continues tomorrow also, no, that way.
Yeah. There are only 3 participants I see in that out of
Yes,
the 6.
they have come. Others have not come yet, I think so.
Yes, they haven't come in. Probably they
Yeah,
won't.
let's see.
Yeah.
Prathamesh, are you able to share your presentation?
Other presenters are not picking my phone.
Huh?
Not pick the phone. Other presenter.
Can you share your video, Prathamesh?
Yes, sir. I'll start sharing, sir.
You can start sharing.
So please introduce first speaker.
Okay.
Dr. Supe, I think we can start now.
Yeah, I think so. We can start.
Yeah, you can.
So, Dr. Prathamesh.
Yes, sir.
Hello. Along with me is Professor Kale and me. We are going to be here as a chairman and judge for this session.
Yes,
and
sir.
I think there are other 3 participants are there. You are there, Dr. Rahul Kushwaha is there, and Dr. Ankit Kumar is there, right?
Yes, sir.
Hello.
Yes, sir. Hello.
So I
Yes,
think
sir.
so. We
Sir,
should
am
be
I
start the
audible?
press.
Yeah,
Yes, you are audible to us.
Yes, sir. Thank you, sir.
So you can present your paper and then we'll have a discussion. Okay.
Sir. I'll start, sir.
7-minute presentation, 3-minute discussion.
Okay. Go ahead.
Good evening, my respected teachers. I am Dr. Prathamesh Mishra, third year PG trainee from KIMS, Bhubaneswar. Here to present my thesis paper topic on comparison of transabdominal preperitoneal versus Lichtenstein mesh repair in inguinal hernia, a prospective study. In cricket, when the batsman has to score runs, he has 2 options. When he is new to the crease, he is using the cheeky runs, which are easier shots, taking less risk, but it is very useful in facing the difficult deliveries. As he gains the experience of the pitch and the knowledge of the field, he is playing the more risky shots, the bigger shots, but the disadvantage, he cannot play this shot for all the deliveries. So which technique is the better? Answer is none, because he has to play both the techniques in order to win the match. Coming to the hernia, in inguinal hernia, it is the 75% of all the abdominal hernia with the lifetime risk of 27% in men and 3% in women. Similar line, the scientific understanding of hernia is also very vast, starting from the innumerable procedures with the Bacchini, Sholdy's, Macway, Hamilton Bailey, and the Defabda, also with the several classifications, the anatomical, Gilbert, Nihas, and the Benda-Witt. All this information had made the inguinal hernia surgery very complicated. The mesh has introduced even more complications with the plug and patch, onlay, preperitoneal, and the dual mesh technique. However, there has been standardization in the recent years, with recommended classification being the European hernia system, the recommended tissue repair being the Sholdy's and the Defabda repair, and the recommended mesh repair being the Lichtenstein, and in the endoscopy being the totally extraperitoneal and totally trans would not be placed. Now, LIHS has come a long way from the time of Dr. Ralph Jur, with the TAPP and TEP being the established procedures and one of the first line approach for inguinal hernia, with the advantage of placing in the mesh in the preperitoneal space. It has the several advantages over the open repair. However, despite all these benefits, it has not demonstrated any benefit over the Lichtenstein repair, which is the low cost and simple technique and easily reproduced by the budding surgeon without rigorous training.
Liechtenstein also is very good, can be done under the local anesthesia with in peripheral hospitals with a simple instrument. Also, the LIHS has disadvantage of the laparoscopy and general anesthesia. The large groin hernias, irreducible, incarcerated, strangulated hernias are relative contraindications to LIHS. Hence, the global acceptability is questionable and it is looked upon as a subordinate approach. The aim of the study was to compare TAVP and Liechtenstein in inguinal hernia patients with the primary objectives of recurrence and cost of procedure and the secondary outcomes. All the patients diagnosed and underwent surgery for inguinal hernia were enrolled with the applying of the inclusion-exclusion criteria. Sample size of 160 was selected by the statistical formulae and 80 patients were enrolled in each TAVP and Liechtenstein group. Study was done from September 2018 to September 2020 with data regarding the age, symptom, comorbidities and examination findings, and the intraoperative finding and post of recovery was noted. Follow-up was done for 1 year for the late complication and all the data was compiled in the master chart and analyzed with the statistical test. Patients undergoing TAPP and Liechtenstein with 18 years and above were included in the study, and patients having irreducible, strangulated, complicated hernias with cardiopulmonary compromise and liver and renal failure were excluded. In our study, the youngest patient was 18 years and the oldest was 80 years. Out of 160 patients, 143 were the primary inguinal hernias. 17 patients had undergone previous inguinal hernia surgery, out of which the 2 were ipsilateral side, 13 were the contralateral side, and 2 were the bilateral hernias. Data of the patient for hypertension, diabetes, and hypertension with diabetes was studied, and there was no significant impact in the course of recovery. Both groups were equally matched for the age, comorbidities, previous inguinal surgery, and the type of hernia. Where the European hernia system was used for classification, 150 were the unilateral hernias, 10 were the bilateral hernias, and 15 were the double or pantaloon hernias. In our study, the double pantaloon hernias were diagnosed more in the TAPP group than the Liechtenstein. Bilateral hernias were operated by the TAPP, and unilateral were distributed equally in both the groups. There was no incidence of intraoperative injury or early post-wound complications, namely the seroma, hematoma, or wound dehiscence. Also, there was no incidence of recurrent or chronic groin pain in the patients during the follow-up period. The mean duration of surgery for Liechtenstein was 73.94 minutes and TAPP was 101.81 minutes, and we conclude that the Liechtenstein was significantly faster than TAP. The estimated intraoperative blood loss was similar in both the groups. Immediate post-op pain was monitored by the number of doses of IV analgesic. Injection paracetamol 1 gram was given 8-hourly IV until the patient complained of no pain, and both the groups were similar in the number of doses. The mean duration of hospital stay in Liechtenstein was 6.06, which was significantly more than the 5.05 days of the TAPP, and it was noted that TAP has early discharge. In our study, the cost of Liechtenstein and TAP procedure were fixed throughout the study, and of course, the cost of TAP was more than 3 times the Liechtenstein. In our study, the laparoscopic repair were mostly done by the senior faculty in assistance with the junior surgeon, and most of the Liechtenstein were done by the junior surgeon under supervision. Hence, concluding, both the procedures are safe in skilled and experienced hands. Liechtenstein and TAPP are similar in inguinal hernia repair in the most of the aspects. However, Liechtenstein is far better in terms of duration of surgery and cost of procedure. Where the TAPP requires advanced laparoscopic skill and the expertise, it is also having the extensive cost and duration of surgery without any added benefit. We conclude that the case selection is very important in LIHS depending on the patient financial status and the surgeon expertise, and a larger randomized multi-center study can be done for evaluating future possibilities. Thank you.
Nice study. Why did you choose to do these two procedures? To compare these two procedures?
Sir, because the Liechtenstein is the most common gold standard surgery done, and any new surgery that is done in hernia is compared with the Liechtenstein. And also, the TAPP is the first stepping stone in LIHS. By learning the laparoscopic inguinal hernia surgery, one has to learn first the TAPP, then the TE.
And what kind of mesh did you use?
Sir, for the Liechtenstein, we use the polypropylene mesh 10 by 15 size, and for the TAPP group, we use the 15 by 15 polypropylene mesh.
Okay. Why do your patients had to stay for 6 days in a hospital? I think if I'm right, 6 and 5 days you made them stay, no?
Yes, sir.
Why? Hernia patient, why should he wait for 6 days today?
Sir, some of the patients were admitted for some investigations pre-operatively, and most of the patients were willing to go after the stitch removal.
So that's actually one of the thing which I was not very feel. And you have used stratified sampling, right? That means you have put indirect and direct patients equally in the both the groups.
Yes, sir.
Okay, and this is a short study, right? So you don't know what is the incidence of recurrence at a later date, right? Did you find any recurrences over 2 years?
Sir, during the period of follow-up, there was no recurrence. No recurrence and no chronic crisis.
Okay. Okay. And then secondly, what I wanted to ask you was, that same Dr. Professor Kale asked the question, why only these two methods? I mean, Liechtenstein versus TAP. Why not the other methods you choose?
In elective hernia surgery, it is advisable to put a prosthesis. That is why we were going for the mesh hernioplasty. And out of these, the recommended for the elective is for the Liechtenstein by the open method and the TAPP by the laparoscopic method in the initial phase.
Okay. And see, the second point about your study was that the senior surgeons did TAP and the junior surgeons did the Liechtenstein. So does it really then your findings can be compared? So that was another question. So anyway, it's a good study. I mean, you tried it to do a controlled trial. I really appreciate that effort. But I mean, you will have to really look for the long term also, how much it is recurrence rates. And there are some fineness of your stratification in the next studies if you really do. Otherwise, I feel at your level, you have done a controlled study is a good thing, but you could refine it in your future in your next cases. Any other comment from the other people you want to ask at this stage? Professor Kale, you want to ask another question?
No, that's up, and he's said the study quite well. We can go to the next person.
Okay, okay, definitely. Okay.
I think Dr. Rahul Kushwaha from
Yes, sir.
Silchar Medical College. A study on the role of FAST in assessment in blunt abdominal trauma and its correlation with clinical findings and outcome.
Okay, sir.
Open your presentation there.
Yes, sir. Very good evening, respected judges. I am Dr. Rahul Kushwaha, presenting a paper on a study on a role of FAST in assessment in blunt abdominal trauma and its correlation with clinical finding and outcomes. Introduction: blunt abdominal trauma is frequent diagnosis problem in the patient with multiple injuries. Any delay in a diagnosis substantially increase the morbidity and mortality in trauma patient due to the bleeding from the solid organ, vascular injury, or infection from the perforation of hollow viscous. Physical examination is often unreliable in unconscious patient. Rapid diagnosis of abdominal injury is an important step in the treatment process to prevent morbidity or mortality in blunt abdominal trauma cases. Rapid determination of the case in need of the emergency laparotomy is crucial, saving life, especially for those with unstable hemodynamics. The avoidance of the unnecessary surgery with its invasiveness and complications should be considered. In the study, to evaluate the ability of FAST in detecting the hemoperineum and solid organ injury in blunt abdominal trauma. And second is to evaluate the etiology and various mode of presentation. The third is to evaluate the role of FAST in assessment of organ injury and its correlation with laparotomy finding and outcomes. Methodology of study. This is a prospective observational study was performed which includes 60 patients with History of blunt abdominal trauma in a period of 1 year in the Silchar Medical College and Hospital. Inclusion criteria is patient presenting with history of recent assault by the blunt and heavy object over abdomen, road traffic accident with suspected blunt abdominal injury, and history of fall from height, patient with clinical suspicion of blunt trauma to abdomen. Exclusion criteria of this study, patient with penetrating stab and gunshot injury, and patient dead on arrival. All patients included in the study were subjected to fast using 3.5 to 12 megahertz transducer. All the cases are clinically evaluated and correlated with fast finding and operative finding wherever possible. Observation and result. In this study, we include the 8 to 69 years of age group, and this graph showing the maximum patient is 20 to 29 age group, and second is 8 to 19 age group. This is 22 and 10 in number respectively, and this graph showing the this study consists of 87% male and 13% female. Most common mode of injury in this study is a road traffic accident and followed by the physical assault. And coming to the fast data, the fast data showing the maximum number of maximum hemoprotein. That is the number of 47 number of patient, and followed by splenic injury, that is 12 in number, and followed by liver injury, that is 4 in number. Coming to the laparotomy finding, we found the bowel injury, which is 26 in number, and followed by mesenteric tear, which is 17 in number, followed by splenic injury 7, and liver injury and retroperitoneal hematoma in 5. And we this graph showing the solid organ injury, which is a splenic injury, which is detected by fast, is 12 in number, and in laparotomy we found the 7 patient has a splenic injury, and 4 patient was managed by conservatively, and in liver injury the fast detected the 4 patient, and we found the 6 patient had a liver injury, and 2 patient was managed by conservatively. Outcome of this study, 43 patient male which is survived, and 8 patients in female is survived, and 9 patient of male is expired. Calculation of the study, total fast positive is value is 40, and which has 39 patient have positive patent fluids, which is 39 in number, and 1 patient has no finding, and this is false positive, and false negative is 12 in number, and patient found the false negative is 8, and 4 in true negative. Sensitivity of the study is the 82.98%, and specificity is the 80% on fast, and the positive predictive value is 97.5%, and negative predictive value is 33.3%. On discussion, in our study, out of 60 patients, there was 52 were male and 8 were female, and this is due to the patient has a male involve the more outdoor activities, and peak incidence of the 35% was found in the 3rd decade of life, and second peak of 23% was found in the 2nd decade of life. Out of 60 cases, in 55 cases, that is 97.1%, vehicle accident was responsible for trauma, and followed by injury caused by due to the assault, that is 5%. Free fluid was detected in 47 cases. Out of 47 cases with free fluid, only 40 underwent the laparotomy and had a significant organ injury along with fluid in the peritoneal cavity on the laparotomy. 7 cases were managed conservatively. The sensitivity of the ultrasound in detecting the free fluid was 83% in our study. Humura et al. In their study noted the ultrasound finding of hemoperitoneum should be integral part of evaluating the laparotomy indication in the blunt abdominal trauma. Rothre et al. In their study 312 patients found the sensitivity of the ultrasound for the detection of the free fluid close to the 98%. There are 12 patients, that is 20% cases.
Rahul, we are not able to hear you.
Yeah, we can't hear you.
Rahul?
I think he's got
false positive case, which is so hepatic injury were noted on the laparotomy in 6 patients. Out of these, 2 cases were detected on fast, that is 33.3%. Mesenteric injury was seen in the 17 patient on the laparotomy. 1 patient had mesenteric injury on fast, but no mesenteric injury was seen in the laparotomy despite poor detection of mesenteric injury on fast, and detected free fluid in the abdomen, which is confirmed by the exploratory laparotomy. The ability of the fast to accurately detect the presence of the free fluid in pinpoint to the injured organ helps the surgeon in contemplating the planning the appropriate therapeutic approach to the patient with suspected blunt abdominal trauma. On conclusion, FAST can be considered as the best screening tool for the blunt abdominal trauma patient. It plays a key role in not only clinching the diagnosis but also in the planning and executing the best therapeutic available approach for the patient. Thank you. This is references.
Rahul, how did you calculate your sample size?
Sir, this is a conventional sampling, sir.
You
Convenient sampling, sir.
randomly took 60, the first 60
Yes, sir.
patients who came.
Yes, sir. Yes, sir. This is convenient sampling, sir.
You had 8 false negative. What was the finding in those 8 false negative?
Sir, one patient, 2 patients has a liver laceration, and one patient has a bladder injury, and other has mesenteric tear, sir.
The other thing is,
looking back, do you think they were missed because of the early cases, or what was the reason why they were missed?
Sir, I think, sir, this is early cases because patient in the shock, there's a late coming out of the blood in the pattern cavity, sir, because due to the shock, sir.
Do you think a surgeon should do a fast, or a sonologist should do fast?
Sir, surgeons do the fast, sir.
That's great. No, it's a nice study, as I said, but it's a convenient sampling, and
Yes,
you have taken it as it is. So, I mean, the conclusions are always limited, but it's a useful study to really take decisions. And we need to explore it further, definitely.
And what about any chest injuries in any of these? Since
Sir,
EFAST does look at that.
So we only include, sir, blunt abdominal trauma, sir. We exclude the chest injury, sir.
Okay. Though fast, those your false negatives, they are the patients who died actually?
Yes, someone died, sir.
Okay, okay. Anything else you want to ask? Any other participant want to ask another question? Ankit, you want to ask a question?
No, sir.
No? Okay, okay, Rahul. Sir, you want to ask anything?
No, that's good enough. Good.
Okay.
Thank you, sir.
Sure.
Thank you, sir.
So next is Dr. Ankit.
Okay. That Dr. Sahu is absent, no?
Yes, sir.
Okay. So Dr. Ankit, start.
Sir, is my slide visible?
Well, not yet.
No.
Not yet. Maybe it will take few minutes. Yes, it is visible now.
Now it is visible.
Yes, sir. Good evening, sir. Myself, Dr. Ankit. I am second year general surgery resident at JLNMCH Bhagalpur. And what I have done is I have to show that how do we do hydrocoelectomy at JLNMC Bhagalpur. Now, hydrocele is an abnormal collection of serous fluid in between the layers of tunica vaginalis. It can be classified into primary and secondary. The common causes include the or epidermoorchitis, some tumors, etc. And the treatment include hernioctomy in case of congenital hydrocele, the plication, which is the Lord's plication, and then the eversion of sac, that is the Jaboulet's eversion, and the excision, sometimes the excision. Now, what is the aim of my study is that what I have done is we have tried to not to use the catgut or any absorbable suture in Jaboulet's procedure. Now, my method is prospective observational study, and the sample size is of 172 patients, which was operated in my unit. The place of study is LMC Bhagalpur. Duration is of 1 year from May 2019 to April 2020. And the inclusion criteria is patient who gave the consent for this study, and the age groups between the 15 to 75 years. The patient with normal coagulation profile were included. The exclusion criteria was the patient with abnormal coagulation profile and those who have not given any consent for the study. Now, in my study, the age was stratified as in 20. We have got 44 patients in the age group of 20 to 40 year, and from 41 to 60 year we have got 72 patients, which means that most of the cases that we have operated is from 41 to 60 year. Now the method: under local anesthesia after proper antiseptic painting and wrapping through transverse scrotal skin incision. We have incised the skin, taking care of any of the vessel. The dissection is done to clearly visualize a bluish tunica vaginalis. Then a stab is made in the tunica vaginalis to drain the hydrocele fluid. Now the key point here is that tunica here is further incised in an avascular area, so that only the testis comes out with difficulty. We don't recommend making very large incision at this stage. We have just incised tunica very small, so that the testis comes out, and then we pull the other things through which the testis is suspended. We pull that out. So we don't recommend making large incision at this stage and suturing it again behind the testis as done in Jaboulet's procedure. The testis is delivered out and the sac is everted. Now the key point here is that sac should be totally out of the tunica. The tunica should totally be everted. It should be checked thoroughly for any bleeding at this stage. A facial space is then made to accommodate the testis. The testis is placed into that space, taking care not to re-invert the tunica at this stage. As we have seen, we have seen at our center, that that any recurrence if that has occurred, it should clearly be seen on the operation table at that time only, as this may lead to recurrence of hydrocele. The skin is closed further with nylon. And in our study, only 29 of the patient we have used catgut or any absorbable suture for and it is used for securing the hemostasis. And if you use cautery, we don't even need that. Catgut was used only in one recurrence was noted in our study, which is similar to what we have observed with Jaboulet's procedure at our center. Testis should be checked for reversion. This is the key point. Testis should be checked for reversion on the operation table itself. And the other point is that the tunica is inside so small that only testis comes out with difficulty, and we should not make a very large incision. Now, we conclude that hydrocele can be operated without using catgut or absorbable suture. The technique is cost effective. Thank you, sir.
Well, this is like reinventing the wheel. How did you choose your sample size?
Sir, it is a randomized. All the patients that have been operated in our unit, I took all of them.
And what is the normal prevalence of hydrocele in Bhagalpur and the size that you normally see?
Sir, it is in 1 year I have got 172 patients. About normal prevalence, I don't have idea that in how much population we have hydrocele. That I don't.
What is the size of each hydrocele?
What is the size of each hydrocele that you see?
And have you treated these patients with thick sac, other very big hydrocele with the same method?
Yes, sir. We have done all of them with the same method.
So if you have a thick sac, then after aspiration, the size will stay the same?
Sir, if we have thick sac, then we have excised the sac also. Not in, we have, in some of the cases, we have not done that.
And what did you do for secondary hydrocele? They were all primary or secondary also?
No, sir. There were hydrocele with epidermoorchitis or after epidermoorchitis or other things. We have done that.
That also you've operated.
Yes,
They are
sir.
very small ones.
With the same method.
What about making a subdartus pouch? Have you thought
Yes,
of
sir.
that?
Yes, sir. It is a part of that. We have made it after after the eversion of testis. After the eversion of the sac, we have done that. We have made a pouch in the facial plane.
Right. Anything else, Dr. Sube?
No, it's okay. I think it's
understood.
very, I mean, I'm not very sure whether the thick sac, calcified sac, large sac should be treated by the same method. That is the question actually.
No, sir.
Rest all is okay. Small hydroceles, thin sacs. I think we can try all that.
Yes, sir. Actually, no, sir. We have for the thick sac, we have excised the sac. We have not used the same method for that. For the thick sac hydroceles, we have excised the sac.
Okay. So that conclusion, what you drawn, has to be modified and has to be specified into that particular way.
Yes, sir. Yes, sir.
Okay. Thank you, Dr. Ankit.
Thank you, sir.
Is there anyone else who's there? Has anyone else joined?
Yeah. There are two people. Dr. Tasmia is there and Arun Mozi is there. So I think we'll listen to Dr. Tasmia now.
Yeah. Dr. Tasmia, you can share your screen.
So my topic is on a retrospective analysis of doing a ETEP versus STEP procedure in our hospital in Savita, Chennai.
Yes, go ahead.
The need for research is that the classical TEP technique is considered the closest to ideal for lap hernia repair, but it does have its difficulties and drawbacks. So the ETEP technique has been modified to overcome these drawbacks. The purpose of my study is to compare both these techniques intraoperatively and postoperatively for detailed analysis of the outcomes and its feasibility in practicing this technique in a teaching hospital. My period of data collection was around 13 months, and we analyzed the data for 1 month. The study design is an observational prospective cohort study with a sample size of 50 patients, and sampling technique is a simple random sampling. We use a statistical analysis of chi-square and descriptive analysis. Any p-value of 0.011 to 0.050 will be considered statistically significant. My inclusion criteria are basically all uncomplicated hernias and of age more than 18 years and patients who are medically fit for GA. The lifetime risk of a groin hernia for men is 27% and for women is 3%. The ETEP is a novel technique first introduced by George Days in 2012. And the lap technique currently available for repairing inguinal hernia are the TEP repair, the extended view extraperitoneal repair, transabdominal preperitoneal, and reduction of sac with or without closure of the ring. A little bit about the anatomy. All hernias originate through this single weak area in the groin called the myopectineal orifice of Rochard. The direct and indirect hernias pass through the anterior aspect, and the femoral hernia passes through the posterior aspect. Hernia repair by laparoscopy is regarded as a treatment of choice for failed or recurrent open inguinal hernia as well. A little bit about the laparoscopic anatomy. Here we have two important triangles, the triangle of pain and the triangle of doom. These triangles need to be avoided while placement of tackers intraoperatively. Corona mortis, it's an anastomosis abnormal anastomosis between the obturator artery and the inferior epigastric artery. And any damage to this area will cause a significant loss of blood. The arcuate line of Douglas is the posterior sheath ends here. It's a line of demarcation. And below the arcuate line, rectus is covered by fascia transversalis and the peritoneum. The inferior epigastric vessels pierce the rectus, and when cut laterally, this gains access into the lateral spaces. The advantages of lap TEP is that the extraperitoneal approach, this is an extraperitoneal approach, hence there is lesser visceral and vascular injuries. There is no suturing and no peritoneal flaps as in TAP, as with TAP. Lesser tackers are used, but the disadvantage is that there is limited space for dissection and mesh placement, restricted port placement, no triangulation, poor tolerance to pneumoperitoneum, and there's a very high learning curve. So after noticing all these drawbacks, the TEP was modified based on the principle that the preperitoneal space, it can be reached from virtually anywhere in the anterior abdominal wall. The preperitoneal space in the lower abdomen is continuous with the retrorectus space beyond the arcuate line. So the ETEP can expand all this traditional indications of extraperitoneal approach to patients with a difficult body habitus. This is a representation of the ETEP port placement for a left-sided inguinal hernia, for a right-sided inguinal hernia, and in the center for a bilateral inguinal hernia. This was done in our center. This is the first trocar position, followed by the second port placement. This was our ETEP positioning for a bilateral hernia. The main advantages of ETEP is that access to extraperitoneal area is easier, flexible port setup. There is ease in parallelization of cord structures. It can handle huge hernias. The size of a mesh is not a constraint, and accidental pneumoperitoneum doesn't hinder the surgery progression. And getting trained is generally easier than in TEP. Here we can see that even though there is damage to the peritoneum, there is no reduction of space intraoperatively. Here we can see for a bilateral hernia repair, the amount of space which was available for us using the ETEP technique, and a huge mesh could be placed. Coming to the results, demographics, the average age of patients we used were, mean age was 44, mean BMI 22 to 23, and the mean size of the swelling was, the number of tackers for fixation. This was a little bit of a disadvantage in the fact that for the TEP procedure, around 1 to 2 tackers were used. For the ETEP, we could use more tackers. This is because of the more availability of the space which was there. Intraoperatively, we had accidental pneumoperitoneum with 3 cases with TEP, conversion of TAP with 4 cases with TEP, and there was vascular injury seen with 1 case of TEP and with 2 cases of TEP and 1 case of ETEP. The intraop complications were managed by clipping and creation of additional extraperitoneal space. The duration for ETEP procedure was around 3 hours, but this was because this was a relatively new technique in our center, and a lot of time was taken for documentation and for teaching purposes. Immediate post-op pain was more with TEP, but after the post-op day 3, it was comparable with both TEP and ETEP. Post-op complications, we had seroma collection for our ETEP, for 2 of our ETEP patients, but this was attributed to the fact that we could handle larger hernias with the ETEP procedure, and hence they had a seroma collection post-operatively. Duration of return back to work was on an average more or less the same for both TEP and the ETEP procedure. So to summarize, we evaluated a total of 50 patients in our facility, where 25 underwent ETEP and 25 underwent TEP. ETAP was done for ETAP was done for sir.
Time is over.
E
Your time is up, so just give us the
Hazarpad,
conclusion.
just summarize.
Just summarize.
Sir,
Okay.
we did ETAP for 7 bilateral and 18 unilateral hernias, sir. And proline mesh for ETAP, we used a bigger size of proline mesh, around 12 into 15 centimeters, while for TEP, we used around 10 into 15 centimeters. And overall, the intra-op complications were more with TAP, only with the 3 cases which had an accidental pneumoperitoneum and 4 cases which were converted to TAP. And postoperatively, 2 patients had subcutaneous emphysema and 1 had seroma formation. While for TEP, we saw that intraoperatively there were no complications, and postoperatively only 2 patients had seroma formation. I would like to just mention that there were 2 limitations in our study. The patients were not been under long-term follow-up, so recurrences of hernia has not been included. And also we had a limited sample size of 50 patients, so it was not did not yield a sufficient statistical result.
Okay, you said simple random sampling. What does that mean?
Sir, actually, it was patients who presented to us.
Can you put your video on? Yeah.
Yes, sir.
Simple random sampling. What does it mean?
Sir, basically, any the patients with inguinal hernias who presented to our OPD, sir, we used their hospital ID and did a random sampling of them. But we preferred patients with larger hernias and for ETAP, sir.
So there was a bias in your study.
A little bit of a bias, sir, because we wanted to.
I think ETAP also you was a learning procedure. So I think now you should do it again. You will have better results.
Yes, sir.
Because now that you have learned now ETAP, so when your ETAP was your learning curve, while TAP was your regular curve. So you could really do this again, and you may find the same results, like same amount of time and less pain and all that kind of thing.
Yes, sir.
So now what is your choice for ETAP and what is your choice for TAP?
I'm sorry, sir. For TAP, sir.
Choice, the type of patients. How do you select patients now?
Sir, for larger patients with larger hernias and patients with bilateral hernias, we prefer ETAP, sir. For hernias which have a swelling of less than say 6 centimeters, we would do a TEP, sir, because a lot of us consultants here are already trained in TEP, and we still have a lot of them learning the ETAP procedure in our center.
So if you want to prove this in your study, how will you prove it?
That
doesn't matter. Think over it, okay?
No, sir. Prove that the
Doesn't
larger
matter. It's okay. Okay, you think over it. Based on your study, how will you prove this point? What you found?
Sir, we saw that.
Doesn't matter. It's okay. Okay.
All right, sir.
Okay, thank you, Dr. Tasman.
Thank you, sir.
Tasmia.
No problem, beta. It's okay. Okay, all the best.
Well,
thank you, sir.
Arun Mozi.
Good evening, sir.
Yes, Dr. Arun Mozi, go ahead.
Yes. Some delayed revascularization with limb salvage in a case of traumatic blunt femoral artery injury with linear long intraarterial thrombosis. With increasing use of heavy vehicles and increasing road traffic accidents, extremity injuries and loss are not uncommon. Most of the studies suggest early revascularization of the affected limb in case of any arterial injury, but which is not possible most of the times due to the delayed presentation of by the patient. But delayed intervention has also saved the limb in many cases. This is a case report of a 54-year-old male who was attacked by a buffalo and sustained a penetrating injury in the left groin region, which was profusely bleeding, and the wound was packed in a local hospital and referred to our institution. The patient presented to us with a swelling of entire left lower limb with reduced temperature. On examination, the distal pulses were not palpable, like dorsal pedis and posterior tibial artery of the left lower limb were not palpable. The movements at all joints were preserved except at the metatarsophalangeal and interphalangeal joints. Investigation done. Color Doppler of the left lower limb showed reduced flow in the femoral, popliteal, anterior tibial, and dorsalis pedis arteries. On exploration, after 44 hours of injury, the saphenous vein was found to be severed near its junction to the femoral vein. The femoral artery was found to be bluntly injured with decreased pulsation and suspected intravascular thrombosis. On surgery, the left femoral arteriotomy was done, and a thrombus of size 3 centimeter into 2 centimeter was found in the proximal part of femoral artery, and a 40 centimeter long linear thrombus was found in the left femoral artery extending up to the left anterior tibial artery region, which was removed with a Fogarty catheter. 1.5 centimeter of injured segment of the femoral artery was sacrificed, and an end-to-end arterial repair was done after minimal mobilization, and which was followed by a 2-incision fasciotomy of the left leg. Post-operative period of the patient was uneventful, and intravenous heparin was continued till 48 hours post-surgery. Distal pulses were palpable immediately after the surgery, and the temperature of the affected limb became comparable to the contralateral limb the next day of surgery. Movements recovered at all joints on about third post-operative day. Discussion. There is an increased risk of amputations in cases where revascularization is done after prolonged periods, but still revascularization should be considered if the limb is viable, even after prolonged periods of ischemia. Failed revascularization was found to be an independent risk factor for extremity loss, which should be done by experienced hands. Other necessary procedures such as fasciotomy and performing vascular report prior to the orthopedic surgery is useful in salvage of the limb. When coming to fasciotomies, Farber et al. Suggests fasciotomies done within 8 hours in selected patients showed improved limb outcomes when compared with delayed fasciotomies. Cargill et al. Showed that the mortality associated with femoral artery injuries were low, but there was significant morbidity. In femoral vascular injuries, the extent of associated soft tissue injury, bone damage, and nerve injuries resulted in acute limb morbidity and neurological deficits, and venous sequelae were attributed to chronic limb morbidity. Prophylactic fasciotomies done early in patients with mean ischemic time more than 6 hours showed improved limb salvage rates. Moini et al. Studied the effects of delayed revascularization after 24 hours in cases of traumatic popliteal artery injuries, and concluded that even in cases of complete paralysis without mottling of the limb, they could be salvaged. This is the first picture shows the femoral artery after the injured segment has been resected, and the second picture shows a long thrombus of around 40 centimeter extending from the femoral from proximal femoral artery. Conclusion. We conclude that in case of vascular injuries of the extremities, although earlier intervention is advised, if there is a delay in the presentation, still revascularization should be attempted, which could save an ischemic limb. And fasciotomy should be done in selected patients, which assist the vascular repair and salvage of the limb. Thank you.
Well, Arun, you had done this case after 48 hours.
Yes, sir.
Yeah.
So patient presented late to us. Sir.
So what were the problems you were thinking of when you do revascularization in these cases?
Sir, revascularization injury to the limb, affected limbs.
Because you were doing it after 48 hours.
Yes, sir.
What challenges you faced?
What
actually?
challenges were you thinking you will face?
And what did you find?
You got away with it easily, but you must have thought of some challenges that you were facing. You would have faced.
Yes.
Okay, where exactly was the injury? Which part of femoral artery was injured?
Sir, proximal femoral artery, the just below the inguinal ligament, sir.
Just below the inguinal
Just
ligament.
yes, sir.
That's where it was injured.
Yes, sir. Just the injury was before the origin of profunda femoris.
Okay.
Oh.
Does it make a difference if it is after the profunda femoris?
Sir, if it is after the profunda femoris, then the distal vascular supplies would have been still better.
Better. Would have been maintained.
Yes, sir.
Mhm. Did you look for back bleed?
Sir,
From the distal end, did you look for back bleed?
from the
Did the distal end bleed when you took out the thrombus?
Yes, sir. Distal end was also bleeding continuously.
Dr. Supe, anything you would like to ask?
No, I don't want to ask anything. Thanks.
Thank you.
Yes, sir.
Thank you so much.
Okay.
All the best.
All the best.
Thank you.
So that concludes our session.
And thank you so much. See you tomorrow.
See you
Okay?
tomorrow. Thank you.
Take care.
Okay. The organizers the event manager can take over the session.
Hello.
Yes, sir.
Yes, we have finished our session. One person
sir.
did not come.
Yeah.
So we will send the report to the organizers. Okay.
Okay, sir.
Thank you. Thank you so
Thank
much
you,
for
sir.
helping
Thank
us. Okay.
Thank you.
Bye bye.
Yes, sir.
Hello.
We are waiting for the chairperson.
Okay, sir.
Sir, please start the session. Our first speaker is Vivek Rathod. Please introduce.
Good evening, everyone. Myself. So, am I audible, sir?
Dr. Gore.
Yes, yes.
Yes,
Hello.
Yes, yes. Very much audible.
Am I audible, sir?
Sir, presentation time is 7 minutes and question time is 3 minutes.
Okay.
So, is my slides are visible, sir?
No, you can share your screen, sir.
Okay.
Who is the other co-host for the session? Anup?
Sorry, sir.
Hello, sir.
Sorry, sir.
Name of the other co-host with me, the other moderator with me. Who is the
Sir,
other?
other chairperson is not joined.
Not joined at all.
Yes, sir. I'll text him and I'll send the ID and password, but didn't join.
Okay, 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 okay. Sure. Okay.
So, should I continue, sir, or wait?
Report on clinical oncology.
The time.
Okay. Can you give me 5 minutes? I'll finish one patient, last patient. Just 5 minutes, please. Vivek,
Okay,
Dr.
sir.
Vivek.
Yes, sir.
I'll just log out and I'll log in just 5 minutes. Okay.
Yes, sir. Hello, sir.
Joining you.
Hello.
Hello, sir.
Yes. Yeah. Yes, this is Dr. Vivek.
Please start sharing, sir.
You can start
Yes, sir.
sharing. I'll be in the listening mode.
Sir, am I audible, sir?
Full screen. Make it full screen, sir. Yeah, audible. Start.
Am I audible, sir? My screen is visible. Is my screen is visible, sir?
Yes, sir. Yes, sir. Start.
Yes, it is visible.
Good evening, everyone. Myself, Dr. Vivek Rathod, second year postgraduate from Department of General Surgery in Patna. Today, I am here to present a first comprehensive report on clinico-pathological profile of breast cancer from Bihar. The background of this article was the breast cancer is the commonest cancer in women in both developed and developing countries and records for 14% of all women cancers in India. According to Globocon 2018 data, overall 1 in 28 women is likely to develop breast cancer during her lifetime. The clinico-pathological profile of breast cancer is very advanced and involves such as age, factors such as age, genetics, tumor size, axillary nodal involvement, histological grade, hormone receptor status. These clinico-pathological features help in guiding the therapy of choice and to determine the prognosis of the patient. In review available literature, the comprehensive and authentic data regarding the clinico-pathological profile of breast cancer from Bihar was not found. So cause may be due to the lack of treatment facilities and researches carried out. So this study was aimed to describe the clinico-pathological aspects of breast cancer from a tertiary care center in Bihar. Patients and methods of the study. It is a retrospective review of prospectively maintained database. Consecutive patients presenting to the Department of General Surgery AIMS Patna from January 2018 to March 2020 was collected. Data collected regarding the demography, clinical examination findings, tumor details, histological features, treatment received, and follow-up. Status at the last follow-up was confirmed either through medical records or telephonically. And SPSS version 24.0 software was used for statistical analysis. Breast cancer grading was standard on Scroff-Bloom-Richardson's grading system, and staging was done as per the TNM AJCC 5th edition guidelines. Coming to the results of the study, the mean age of patients in years was ranging from 47.2 plus or minus 11.6 years. Among 115 patients, 3 of them were males, and among females, most of them were belonging to postmenopausal age group at the presentation. On clinical examination of the tumor, the mean clinical tumor size was ranging from 5.3 plus or minus 2.6 centimeter of standard deviation, and in clinical tumor stage, clinically T2 disease was the most commonest tumor at presentation, and 80% of them of the patients were having nodal involvement during presentation. Among the nodal involvement, N1 disease, clinically N1 disease was the most commonest presentation found. Among the metastasis, 10 patients were having metastasis during presentation, and clinical stage 2 and 3 was the commonest found stage which is observed. On pathological evaluation of the tumor, the mean pathological tumor size was ranging from 4.8 plus or minus 2.3 centimeter, and pathologically also the T2 tumor stage was the most commonest one, and in lymph node stage, N0 was the most commonest found on pathological examination, and mean lymph node ratio was ranging from 0.4 to plus or minus 0.32 standard deviation. On histological examination, infiltrating ductal carcinoma of non-specific origin was the most which constituted majority of the tumor of 85%. Is among the grade 2 tumor was the most commonly found tumor among the patients, and majority of the patients were showing absence of lymphatic and perineural invasions. On assessing the hormone receptor status, ER negativity and PR negativity was found in most of the patients, and hormone receptor positivity was found in half of the patient, constituting 50%, and triple negative breast cancers was found in 26% of the patients. In treatment profile, patients 70% of patients underwent mastectomy, and 30 patients underwent breast conservative surgeries. In case of axillary surgeries, 95% of patients underwent axillary lymph node dissection, and 1 patient underwent sentinel lymph node biopsy. In case of chemotherapy, 43% of patients received chemotherapy in neoadjuvant settings, and 53% of patients received it in adjuvant setting, and 3% of patients had a palliative chemotherapy as a palliative treatment. Coming to the discussion part of our study, in our study, majority of the patient presented at a younger age with a larger tumor size and nodal involvement, and high-grade tumor with a low hormone receptor positivity, which are associated with low survival rates, and most of presented in an advanced stage compared to the developing countries where early stage is very common presentation, which implies that lack of education in people regarding the disease and lack of funding structure, infrastructure, and low priority in public health schemes were noted. In our study, infiltrating ductal carcinoma of non-specific origin variant constituted majority up to 85%, which is similar to the other studies conducted by Saxena and Sandhu et al., which shows around 80%. Our cohort also, in our cohort, the grade 2 tumor was more commonly found, similar to the study conducted by Ahmad et al. On 120 patients, shows that grade 2 was the most common frequently observed tumor, constituting 76% of their study. And higher the grade increases the chances of recurrence, metastasis to the regional lymph node, and higher mortality rates. It is evident that majority of the patients were of younger group with triple negative breast cancer and high HER2 expression and low hormone receptor positivity. Similar to the study of others conducted in AIMS Delhi by Gogi and et al., records the increased prevalence of triple negative breast cancers, nearly around 83% is in 23% is in their cohort. Conclusion of our studies: the clinico-pathological profile of breast cancer in Bihar is similar to that reported in other parts of India. Most of our patients are younger, presented with locally advanced disease, with low hormone receptor positivity and high HER2 expression and high incidence of triple negative breast cancer. These were my references. Thank you. Hello, sir.
Yes. So, can you just replay your last 2-3 slides, please, of the conclusions and all this, please?
Yes, sir.
Maybe the first slide and the last 2-3 slides. The first slide of your topic and discussion, and the last 2-3 slides.
So this was my first slide.
Go to the next one, please. Okay. Next. Next. Name. Go one step behind. Aim. Clinico-pathological aspects. My main question is, Dr. Vivek, your presentation was very nice, crisp, and I want to believe your data and all. You have taken hard work, but what exactly are you trying to convene from the whole study? Can you go back to your last 2-3 slides, please? Now, the results and the conclusion. Conclusion.
Result.
Yeah. Okay. The results means okay. So these are all your observations. Go to the conclusion part, please.
Yes, sir.
Sorry, conclusion. So, what exactly would you want to convey by this study, or what difference have you made by doing this study? Can you just elaborate on that thing, please?
So, to the best of my knowledge, sir, after searching on this topic, so there were limited publications which are published in the peer-reviewed journals. So, there was no authentic and comprehensive data which can suggest about the breast cancer patients in a Bihar population. So, I want to give at least a basic data regarding the breast cancer patients related to the clinico-pathological profile, how they present in our settings, sir.
So you wanted to give a local study, actually.
Yes, sir, which represents the Bihar population.
Okay. Now, well, that was a good job done. I would congratulate you. But the other thing is, so what is the take-home message, and does this result impact the outcome of your treatment protocols?
Yes, sir. The main most of our patients are of younger age and are of presenting in a locally advanced stage, and we need to implement some such awareness programs. We should have to inculcate in them that they can present us in earlier stages compared to a locally advanced stage, which can improve their survival rates and improve the
Good enough.
treatments.
So I think you should focus on screening modalities more.
Yes, sir.
And you may bring this down to this. Good. Thank you. Very nice presentation. That's a good one.
Thank you, sir.
Are the other panelists already there? Doctor, I can see Dr. Ramakant.
Good evening.
Good evening, Dr. Ramakant sir. Praveen here from Mumbai.
He was answering very well. I just would like to say that this is nice study he is doing, and then he should, as you suggested already, that he should have a protocol maintained for future, that how should screening be done and what sample should be done to make authenticated. So it is a good study. It's all right. Okay, fine.
Next presenter is Dr. Suman.
Am I audible, sir?
Next presentation, which is the person? Vivek Rathore? No.
Suman, Dr. Suman.
Suman Paul. Okay, fine. You're welcome.
Please share your screen, sir.
Okay.
Is it visible, sir? My screen?
Yes. Okay. It's all right.
Is it okay, sir?
It's all right. You go on.
Good evening, everyone. Honorable ASI President, esteemed judges, respected teachers, ASI members. Today I am going to present an paper on intraoperative use of ropivacaine as a local anesthetic agent in abdominal surgery, a randomized control trial. Introduction. Effective postoperative pain management not only provide comfort to the patient in postoperative period, but also reduces stress response, facilitate postoperative ambulation, and thereby it promotes early recovery and rehabilitation. In a multimodality approach of postoperative pain management, blockade of the parietal and visceral nociceptive afferent by the use of local anesthetics may be a simple, safe, effective, and a cheaper way. Ropivacaine is a amide group of local anesthesia which is available as an as antinomer, and it is metabolized in liver, have high clearance rate, and its half-life is shorter than bupivacaine and has less cardiovascular and central nervous system toxicity. Although many surgeons use pre-peritoneal injection and intraperitoneal flushing of the anesthetic agent in the surgical bed, but few literatures are available describing its role. Aim of the study is to study the role of intraperitoneal and pre-peritoneal use of ropivacaine in the post-operative pain management. Methodology: after obtaining ethical clearance, a hospital-based prospective interventional randomized placebo-controlled comparative study was conducted at Silchar Medical College and Hospital from 1st June 2019 to 31st May 2020. Written and informed consents were taken from the selected 148 patients, and the patients were then randomized and allotted to any of the four groups. The four groups are: Group A, ropivacaine in both intraperitoneal and preperitoneal space; in Group B, ropivacaine in preperitoneal space and normal saline in intraperitoneal space; Group C, normal saline in preperitoneal space and ropivacaine intraperitoneally; Group D, normal saline in both peritoneal space and intraperitoneally. Accordingly, the surgeon injected the drug in the preperitoneal space and flushed it in the surgical bed intraperitoneally at the end of the surgery, and the observer collect the data in the postoperative period. The patient, the surgeon, and the observer all were blinded. The postoperative data on the pain is collected by using visual analog scale, and the scores were taken at 6, 18, and 24 hours. The data on the number of postoperative parenteral analgesic required were collected at the end of the discharge, and the data were then compared using standard statistical test and interpreted. Result and observation. Distribution of the cases. In our study, Group A comprised of 40 patients, Group B 35 patients, Group C 38 patients, and Group D 35 patients. Distribution of the patient on open and laparoscopic cases in each group. There is no significant difference in between the groups in open and open and laparoscopic procedures. On comparing the age and sex distribution among the groups in both the open and laparoscopic procedure, there is no significant difference are found. Distribution of the patient according to the BMI also, there is no significant difference are found among the group and between the open and laparoscopic procedures. On comparing the VAS course of the patient at 6, 18, and 24 hours of each group after open cholecystectomy, we have found that at 24 hours, there is no significant difference between the group, but at 6 and 18 hours, there is a significant difference in the group. And the median of the VAS score at 6 and 18 hours shows that the lowest VAS score is in Group A, followed by Group B, followed by Group C, and the highest VAS score is found in the Group D. Similar results are found also in case of the open appendectomy cases. Comparing of the VAS score of the patient at 6, 18, and 24 hours of each group after laparoscopic cholecystectomy, we have found that at 24 hours, there is no significant difference between the groups. But at 6 and 18 hours, there is a significant difference between the group. The median shows that the VAS score is very lowest in Group A, followed by Group C, followed by Group B, and the highest in Group D, that is the placebo group. On comparing the VAS score of the patient after laparoscopic appendectomy, similar results are found as like their laparoscopic cholecystectomy. Comparison of the VAS score of the patient at 6, 18, and 24 hours of each group after exploratory laparotomy, we have seen that 24 hours there is no significant difference between the groups, but at 6 and 18 hours there is a significant difference, and the median values of VAS score shows that Group A has the lowest VAS score, followed by Group B and C, and the highest VAS score is found in Group D. Comparing the number of parenteral analgesic doses in each group after open procedure, we have seen that there is a significant difference in the parenteral analgesic doses among the four group after both open appendectomy and cholecystectomy, but no significant difference were found among the group after exploratory laparotomy. Among the group, the lowest number of doses required in group A, followed by group B, group C, and the highest number of doses required in the group D cases. Comparing the number of parenteral doses in each group after laparoscopic procedure shows similar results. In this part, we will discuss our results and also compare them with the other studies done by previous authors. The mean age and the sex ratio of our study is almost similar to above mentioned studies as shown in the above table. And comparing the VAS score of the patient for both open appendectomy and open cholecystectomy at 6 and 18 hours, it is lowest in the group A, that is who received both intraperitoneal and preperitoneal ropivacaine, and was highest in group D, that is the placebo group. The group B, where only preperitoneal ropivacaine, and group C, where only intraperitoneal ropivacaine are used, has similar results. On comparing the pain score of the four group in both laparoscopic appendectomy and laparoscopic cholecystectomy, like the open procedure, the pain score at the 6th and 18th hour is lowest in the group A, and that is when the ropivacaine is used both intraperitoneally and preperitoneally, and highest in the group D, that is the placebo group. But unlike the open procedure, the pain score at both 6 and 18 hours shows lesser pain in the intraperitoneal group than the preperitoneal group. That is, group B has more pain score than the group C. These are few studies that are conducted previously, and on comparing these studies with our study, we have found similar findings, but the study conducted by the Mark Brucey et al. And T. Levely et al. Have found reduction in the VAS score, which is extended up to 48 hours. Comparing the number of parenteral analgesic doses of the cases in each group, also similar trends, that is the lowest dose.
Time is over, sir.
Okay, Suman, what I would like to point out is that first of all, you tell me what was the exact your motive or aim of doing this study? What did you want like to find out?
Actually, sir, in post-operative period, we have seen that the post-operative pain management is very crucial for the early recovery of the patient. But the parenteral analgesics, which have lots of side effects, and it is also seen that they are more or less not being up to the mark in management of the pain. So we recommend that the intraperitoneal use, that is some author have done, but not much literature are available. So we have done this study to conclude that ropivacaine, which is a newly introduced local anesthetic agent, to reduce the pain in post-operative period.
Right. So I wanted to know about that. Did you test for this sensitivity? Because all these such anesthetic. Right.
Before the operation, we test the sensitivity of the patient.
Always.
All patient.
Despite of that, did you get any reaction sometimes?
No, sir. In our patient, we didn't get, in all 148 patients, we didn't get any hypersensitivity reaction.
Okay. So you tell me the best result and the worst result out of this study.
The best result we get is intraperitoneal, both intraperitoneal and preperitoneal used simultaneously. And the worst results we'll get in the placebo group. That is when normal saline is used, both intraperitoneally or preperitoneally. In
the sample size?
Sample size is 148 patients, sir.
148. Okay, sir. Thank you very much. Thank you. Thank you.
Dr. Suman, can I ask you one question, please?
Yes, sir.
What difference has this study made to you in your practice?
Yes, sir. In my practice beforehand, we didn't use intraperitoneal or preperitoneal local anesthetic agent. From now on, we use immediate post. Soon after the end of the operation, we use local ropivacaine both preperitoneally and intraperitoneally. This will comfort the patient in the post-operative period, so that the patient recovery as well as the stress factor of the patient is reduced.
Good. Okay, good enough.
Go next presenter.
I should be next. Okay.
Next presenter is Dr. Ashutosh.
Ashutosh Carpenter. Okay.
Good evening, sir.
Good evening.
Good evening, everybody.
Please make it full screen, sir.
Whether is it all right, sir?
Oh,
Can I
yes.
start?
Done.
Good evening, everyone. I am going to present my study. It's a pilot study of an ultra-low-cost vacuum-assisted co-needle biopsy technique for breast lump in a resource-limited setting. The authors have nothing to disclose. Coming on to breast cancer is the most common cancer in most cities, accounting for around 25 to 32% of female cancers, and second most common cancer in rural India, becoming the most common cancer of women in India overall. So basically, one woman is diagnosed with breast cancer every 4 minutes, and one woman dies of breast cancer every 30 minutes in our country. We can see that in this, according to this, the incidence is more in Western countries like Europe and Australia. The incidence is more in Western countries as compared to Southeastern Asia. But when we compare the mortality, it is actually more in Southeastern Asian countries as compared to that of their Western counterparts. So why is this? Obviously, it is due to lack of awareness and unavailability of resources. But one peculiar barrier to healthcare in low middle income countries that need to be overemphasized is gender disparity. An observational study based on outpatient data from a large referral public hospital in Delhi concluded that around 50% of their female patients were lost to breast, mainly constituted of 4 states. These are the graphs which shows that gender discrimination which the women face, as they are often undervalued and discriminated when it comes to funding of the medical bills, either by selling of asset or by borrowing or from siphoning the finances from multiple sources. All these factors contribute to delay in diagnosis and ultimately low cure rate, which is around 40 to 50% in low middle income countries, as compared to Western countries where the cure rate is more than 95%. As we all know, the triple assessment is the gold standard for diagnosis of breast lump, constituting of clinical examination, imaging, and tissue diagnosis. Coming on to tissue diagnosis, at around 2001 in Western world, fine needle aspiration cytology has been replaced with core needle biopsy for the assessment of for the triple assessment of breast cancer. But in our country, we still go for fine needle aspiration cytology as a method of taking tissue biopsy, tissue diagnosis. So why is this? The most important factor for choosing FNSE over biopsy is that it is less expensive. Other factor are that it is simpler, easier, and is usually carried by pathologists, and we get the result in one sitting. According to a study by Lancet, if a modality is available and accessible, but if it is not affordable, then it is as good as inaccessible. So to overcome this, we made an ultra-low-cost model of vacuum-assisted core needle biopsy for evaluation of breast lump in low-resource setting like ours, and our aim was to evaluate the diagnostic accuracy and the cost-effectiveness of this technique. So we did a prospective study from January 2020 to September 2020 in patients who had indication for surgery based on clinical and radiological findings. We evaluated this model only in this subgroup of breast lump of patient, as surgical biopsy remains the gold standard for final diagnosis, and we wanted to compare the result of vacuum-assisted core needle biopsy with final histopathology. We devised a new model of vacuum-assisted core needle biopsy using a 50 ml syringe, a 10 ml syringe, and a 12 gauge needle, as shown in the figures. This figure shows the biopsy being taken, and this is the sample of the biopsy. Coming on to the results, out of a small cohort of 25 patients, 19 patients were diagnosed of infiltrating ductal carcinoma, 4 patients were diagnosed as fibroadenoma, 1 patient had leptomyosarcoma, and 1 patient were diagnosed as idiopathic granulomatous mastitis. And final histopathological report were confirmed in all of the patients, and immunohistochemistry was possible in all. For the diagnosis of malignancy, vacuum-assisted coronal biopsy had a sensitivity of 100%, specificity and diagnostic accuracy of 100%. The important thing, the economic analysis, the overall cost of this device is less than $5, whereas cost of coronal biopsy in our country is around $41, and vacuum-assisted breast approximately $341. The limitation of vacuum-assisted coronal biopsy is that it has been done only in palpable breast lump. In conclusion, provision of quality healthcare for all should be accompanied by frugal innovation to safeguard the poor from increasing catastrophic healthcare expenditure. Vacuum-assisted coronal biopsy can be used as a replacement for the automated coronal biopsy, especially in resource-poor setting. However, its reproducibility in different settings and used by different personnel and larger cohorts need to be established. A prospective validation study is underway to answer this question. Thank you, sir.
Hello, Dr. Carpenter. I wanted to know one that because you tried.
Dr. Carpenter, you have really presented it very well.
Thank you, sir.
Please carry on.
I was just curious to know, is the yield more accurate in this vacuum assisted thing rather than the core biopsy thing? What
Yes,
is the difference in
sir, in coronal biopsy, as we get the chunk of sample which are somewhat thin, and the length is around 2 to 3 centimeter. But in this, we get a large amount of sample by a single pass, which can be rotated, and the chunks are much thicker as compared to that of coronal biopsy, sir, and we get a larger chunk.
Okay, but then doesn't, in case it is a malignancy, doesn't a larger tract involve a tumor seeding in the tract, converting maybe second stage tumor into almost a 3B or a stage 4 tumor, something?
Yes,
Isn't that a risk with?
Sir, usually the patient who came to us, the stage was already, sir, they were in stage 3 already. Lymph nodes were palpable, and in some patients, they were in stage 2. But in the follow-up, none of the patient has come with upstaging of disease, sir. We had a smaller cohort, sir. There might be, sir, seeding, but in our patients, sir, there was none.
Carpenter, Dr. Gore is asking a very right question. Did you follow this? There were some patients who did not subject to surgery. Did you follow them that this may lead to a really seeding of the malignant tissue into the area? Because he's asking a very valid question. When you are doing with such a vacuum biopsy and you're putting a white bone needle, then there's a possibility. And this possibility, even if the fine needle expression cytology. So what is important is, was there any patient who refused treatment, further surgical treatment, and you studied them further and found that the metastasis, this secondary infiltration was there?
Yes, sir. Out of the 19 patients, sir, 18 patients were, sir, out of the 19 patients, one patient was sent for chemotherapy. Okay. And rest of the patients are modified radical mastectomy has been done, sir.
All right. So what was the cost of this device you tried to make it?
So basically, this device is penniless for us because we have 50 ml syringe available in our department, and 10 ml syringe is available. The only thing is that sometimes we do not get the 12 gauge needle, so we have to buy that too. So it is around, sir, if we purchase it from outside, it is at around 350 to 400 rupees. We can easily.
That's fine. Right. Dr. Gore, please go ahead.
Yeah, all fine, absolutely.
Move to next.
Good, you confidently handled all the questions very well, Dr. Carpenter. I really appreciate that thing, and all the best.
Thank you.
Move to the next speaker, please.
Dr. Vignesh.
Dr. Vignesh.
Sir, can you hear me, sir?
Oh, yes, sure.
Make it full screen.
Is it visible, sir?
Sir. Please go ahead.
Yes. Good evening, sir. My name is Dr. Vignesh. I'm a third year postgraduate resident from Safdarjung Hospital, New Delhi. My study is on the evaluation of conservative management in cases of uncomplicated acute appendicitis. Acute appendicitis, as we all know, is one of the most common problems encountered by a general surgeon, and it accounts to about 6 to 7% of the 6 to 7% of the people will get appendicitis during their lifetime, and almost half of the cases occur before 30 years of age. The classical understanding of the pathogenesis, however, is that there is a luminal obstruction which may be caused either by a fecalith lymphoid hyperplasia or a malignancy, which leads to the inflammation. However, this teaching has been challenged by a number of studies which demonstrates a lower frequency of obstructing lesions in addition to the intraluminal normal pressures which is found in vivo during the surgery. This has also been backed up by the concept that not all appendicitis leads to appendicular perforation. This different understanding of the etiopathogenesis has led us to believe there are many other etiological causes for appendicitis, which includes dietary, environmental, and genetic factors. This has now formed the basis for a non-operative management approach for acute appendicitis. The advantages of the initial non-operative management are the avoidance of the complications related to both the surgery and anesthesia. But one should always keep in mind that there are risks related to the antibiotic treatment in this approach, and there may be recurrent attacks of appendicitis. Why should we preserve the appendix? Appendix was initially thought to be a vestigial organ, but now there are studies which question this hypothesis. It acts as a reservoir for the bacteria that normally constitute the gut flora. Hence, it will be essential to recolonize the bowel flora after infections such as diarrhea. And theoretically, the appendix is also capable of producing mesenchymal stem cells. Apart from these advantages, it also has uses in surgical field where it can be used as a conduit for ureters, and it can be used even in intraoperative colonic lavage. Hence, after deciding that we can preserve the appendix, we can only offer this as a equally genuine alternative to the appendectomy surgery only if it is equally effective at curing acute appendicitis. Hence, the aim of my study is to evaluate the conservative management as an effective modality of treatment in cases of uncomplicated acute appendicitis. The secondary goals which I kept in the study was to evaluate the number of cases requiring cessation of conservative management, that is, by converted to appendectomy, with special reference being given to incidence of appendicular perforation, incidence of recurrence of appendicitis, and incidence of complications such as infections, periappendiceal adhesions, and abscess formation. This study was conducted in the Department of Surgery in Safdarjung Hospital. 60 patients were taken, and the duration of study was 18 months. It was an observational study. We included all the patients about 12 years of age with the Alvarado score more than or equal to 5, and we did an ultrasound abdomen to rule out complications in other pathologies. We excluded patients of recurrent appendicitis attacks, those presenting with complications, immunocompromised patients, pregnant patients, and patients who are already started the treatment outside the hospital and who are allergic to the antibiotics in the study protocol. So we concorded along with the ethical standards of our committee, and informed consent was taken from all the patients, and the baseline investigations were done. Before we go into the study procedure, we need to have a clear definition of what the failure of conservative management means and what a successful conservative management means. Failure is defined as a lack of improvement of or clinical progression, which is indicated by increasing total counts, pulse rate, fever, and worsening periabdominal signs, which necessitates appendectomy while attempting conservative treatment in the admitted patient. Whereas successful conservative management is defined as when the patient had improvement in the symptoms after the antibiotic treatment and did not have recurrence during the 6 months follow-up period. Hence, the successful conservative management is the overall treatment efficacy, all the patients minus those who have had failure and minus those who have had recurrence. Study procedure, all the patients fulfilling the inclusion criteria were taken in our study, and they received intravenous antibiotics, ceftriaxone 1 gram BD and metronidazole 500 milligram TDS, and they were given IV fluids and kept an L per mouth. Repeated 4-hourly clinical evaluations were done, which included the vitals, periabdominal signs, and every day 24-hourly total counts were monitored. The patients whose clinical status improved were continued changed over to the oral antibiotics such as ciprofloxacin 500 mg BD and tinidazole 600 mg TDS for a total of 7 days. In the patients whose clinical status did not improve, the appendectomy was conducted. And in patients who had a successful initial management, they were discharged and followed up at 10 days, 30 days, 3 months, and 6 months in the surgical OPD, and they were assessed for recurrence both clinically, and an ultrasound abdomen was done during each follow-up visit. Statistics, we used SPSS 17 software version, and the association between the variables was done using chi-square test, and p-value less than 0.05 was taken as statistically significant. My observations: the mean age of the appendicitis incidence in my study was 25.6, and there was a male predominance in my study. The mean Alvarado score was 7.75 with almost maximum 31% of patients presenting with the Alvarado score of 8. This is the main observation in my study. 81.7% of patients had a successful oral conservative management. 11.7% patients had a failure of treatment, and 6.6% patients had a recurrence. Among the patients who had failure, only one patient had appendicular perforations, none of the patients had any abscess formations, and 2 patients had periappendiceal adhesion formation. This adhesion formation was found out to be clinically significant, thus emphasizing that a delay in surgery can lead to dense periappendiceal adhesions. And the mean length of hospital stay in a study was 3.17 days. And the recurrence, there was no recurrence at 10th day. There was one recurrence in 1 month, one recurrence again in the 3rd month, and 2 recurrence again at 2 patients recurred again at 6th month. On discussing my study, appendicitis is, as always, we all know, is the most common acute abdomen, and the surgery has been the gold standard for the management of appendicitis. However, it is associated with risks such as postoperative pain, wound infection, adhesions, sepsis, and a greater time to return to daily activities. There is a growing body of evidence in the safety.
Yeah.
Sir?
I say
I cannot hear you,
did well, but the point is that I want to ask that one standard gold standard surgery for cure, and with not many complications. Pain is a part which must even be conservative management. The pain must have been there. This cannot immediately go with the conservative management. So that is a part of the surgical treatment also, that you have to give some conservative management for pain and all that. What I'm asking is that don't you think it was an ethical question that there is a possibility of a cure by a simple surgery, which can be done by so many methods? And on the contrast, there is a very old-timer Ushna-Sharon regime and those things which are treated for perforation and those things by conservative management. So therefore, I just want to know that under these, observations, how did you think of doing such a study? That when you know there is a cure by surgery and a very small incision and all that.
Yes, sir. Actually, appendectomy even now is considered the gold standard for appendicitis.
You said
but, sir, appendectomy is not possible in all the situations. In a non-surgical setting, in patients who are far away from the hospital setup, the initial study for the non-conservative management started by this observation, where the patients who would not get to the hospital for the surgery, they started deteriorating, but they did not develop perforation. So these patients, when kept on NPO and antibiotics, they had improvement without any surgical intervention.
No, but then you had a hospital which has got everything, all facilities available in Vardhaman. There's nothing wrong, no problem. So you just wanted to evaluate that that if the treatment is done, what is the result? Do you feel so?
Yes, sir. Because many patients, on the fear of anesthesia, on the fear of surgeries, and fear of scars, they refuse surgery, and they always ask whether there is a considered non-operative option available or not. And we just wanted to see whether that this non-conservative management is as equally effective as appendicectomy or not.
Okay, where would you have avoided such conservative study at all? But do you know any age groups where you should not do such conservative study because they are more prone to perforation?
Yes, sir. Actually, we avoided patients with any immunocompromised state and comorbidities. We avoided patients who had recurrent attacks, and we avoided patients who had appendicolith on their ultrasound. And so all these patients who are prone for complications and prone for any underlying malignancies, we excluded them from our criteria.
What about old age? What about old age? What about young, newborns, infant, neonates, or even such persons?
Yes,
Right?
sir. Our study was only about 12 years of age, sir. Patients about 12 years of age.
12 year onward, right?
Yes, sir. Yes.
Okay. Thank you very much, and you
Move to
presented
next.
well. This is all right. Thank you.
Thank you.
Dr. Vignesh, I want to ask you one question, only one question, please.
Yes, sir.
Very nice presentation. Rather, I should make it two questions. You are a surgeon. Why are you doing a study against a surgery? You asked the same question. Okay, it's all right.
Right?
Yes, sir. Actually, this was going on a lot in our unit, sir, because many patients, mainly the known to patients and well-to-do patients, they don't want surgery directly. They are afraid of surgeries, and they always wanted a non-operative option for them, suggested to them. And we could not tell them strongly that you can go for non-operative treatment. It is as effective as appendectomy. We could not say that strongly to anyone. So we wanted to check whether non-operative management is as equally effective as appendectomy or not.
That's a very nice answer. Basically, we needed to avoid the virginity of the abdomen to be intervened by a surgery. In case it could be avoided, it would have been beneficial to the patient in the future life. So good. You answered the question in the similar lines. I had worded it in a different way. The second thing is, you had mentioned the conservation of appendix as a reservoir of the gut microflora, and it can be used in some additive procedures like conduits and all. I just wanted to ask, can a diseased appendix be used for such thing? And will a diseased appendix will actually serve as a reservoir in future for all these patients?
Sir, I didn't get you, sir.
One of your logics to doing surgery is why to preserve appendix, because
Yes,
there have been data which have been suggested that appendix acts as a reservoir of gut microflora, as well as appendix can be used as at a later stage as a conduit or some additional procedures.
Yes.
Right. So the role of appendix is there. So my question is, if can a role of appendix be still persistent if it is a diseased appendix? Like after an acute appendicitis or an attack of appendicitis, can the appendix still act as a reservoir for all the gut microflora? Can it be still used as a conduit in future if there is already a history of appendicitis in the past?
Yes, sir. Actually, further studies has to be conducted on that regard. But as we already know that interval appendicectomy is no more the norm for appendicitis which is managed conservatively, because recurrence is very low. And even if there is a recurrence, which is around 11 to 15%, it occurs almost exclusively within 1 year after the primary attack. So more than that, the appendix should be usable as if it was virgin appendix. But however, studies should be conducted on that regard.
That's a very intelligent answer. Thank you, doctor. Nice presentation.
Thank you.
Next
Thank you, sir.
presentation,
Thank you.
Dr. Sunny.
Dr. Sunny.
Am I audible?
Yes, Dr. Sunny.
Sir, am I audible?
You're audible. There's some echo. Can you make it better?
If somebody has logged in with two devices simultaneously, there would be an echo. So I would request, if somebody has logged in with two devices, kindly leave from one device.
Devices has been logged in, sir, with the same ID.
No, it's a poor sound actually. Possibly.
I think the room is equal.
All right, you go ahead. If you can't help it.
Good evening, sir. Myself, Dr. Sunny, audio postgraduate training.
Bit loud. Sunny, you're not audible.
Your audio is not coming.
audible, sir?
You are, but it's not a suspect sound actually. It's okay, you can go ahead. Contact.
Yes, you are audible. Please go ahead.
Myself, Dr. Sunny Suneshwar. I am presenting a topic a randomized control study of minimal dissection technique and conventional eversion of sacs in primary vaginal hydrocele. A hydrocele is an abnormal collection of serous fluid in some part of the processus vaginalis, usually the tunica vaginalis. It is common disease in tropical countries, especially where bilharzius is common. Hydrocele is the most common benign scrotal swelling and has been estimated to occur in 1% of the adult male population. There are about 27 million men with hydrocele worldwide. In India, the highest incidence is seen along the coastal belt. The treatment includes repeated aspiration and injection of fluorescent surgery. Aspiration and injection of fluorescent can cause severe and simple aspiration has to be repeated and carry the risk of infection and hematoma formation. The common complications observed during the surgery of hydrocele are bleeding, injury to the cord structure and epididymis, torsion of the testis after a faulty position postoperatively. Commonest among these postoperative is hematoma, which is due to the oozing from small vessels. It is apt to say that the patient comes for surgery of a tennis ball and goes back with a cricket ball, considering the size and weight. Pathophysiology of secretion. Tunica vaginalis is an invaginated serous sac with an vessel and parietal layer separated by a potential cavity. The cavity contains fluid to reduce the friction. Hydrocele can be formed due to excessive production of the fluid in the sac, effective absorption of the tunica vaginalis due to damage to the endothelial lining, interference in the drainage of fluid by the lymphatic vessels of the cord, and communication with the peritoneal cavity. Aim and objectives: to compare and study Zabolis procedure and Sermon-Jawad technique in terms of duration of surgery, post-operative complications, hospital stay, time taken for scrotal size to revert back, and reoccurrence. Review of literature. Here we are describing the steps of two surgical procedures, Zabolis procedure and Sermon-Jawad technique. In Zabolis procedure, the incision is of 6 to 10 centimeter size, whereas in Sermon-Jawad technique it is small, 4 centimeters. After dipping the incision up to the right layer of tunica vaginalis, delivered in the Sermon-Jawad technique, a stab is given and the testis is delivered out. This delivery inverts the tunica vaginalis layer. Then a subglottis space is created and the testis is placed back in the scrotal sac subglottis space. Whereas in the Zabolis procedure, the sac is reverted back and sutured with a continuous or reverted suture before placing into the scrotal sac. Methods and materials. Sample collection. All the patients admitted with primary vaginal hydrocele in the Department of General Surgery, DVMH, KIMS, after considering the inclusion and exclusion criteria. The inclusion criteria include unilateral and bilateral primary vaginal hydrocele, whereas the exclusion criteria, all hydrocele other than the primary vaginal hydrocele, that include congenital hydrocele, secondary hydrocele, dance cases, patients who are not willing for surgery, patients who have a immunocompromised status. Sample size. A sample of 108 patients were taken after applying inclusion and exclusion criteria. Then the randomization was done, and 50 were operated by conventional eversion of sac method described by the Zabolis, whereas 54 were operated by the minimal dissection technique of Sermon-Jawad. In the current study, both unilateral and bilateral hydrocele are considered as a single case. The period of study is from September 2018 to September 2020. It is a hospital-based randomized control study. All the patients were operated under spinal anesthesia. Then statistical analysis was done, and a p-value of less than 0.05 was considered as a statistically significant. Observation and results. The minimum age of the patient now our study is 22, and the maximum age is the mean age in the Zabolis procedure group is 54.1 years, whereas in the Sermon-Jawad technique it is 53.5 years. In study, 38 patients with unilateral hydrocele and 16 patients with bilateral hydrocele were operated by the Zagolis procedure, whereas 40 patients with unilateral hydrocele and 14 with bilateral hydrocele were operated by Sharma and Kaur technique. In our study, most of the patients presented with a complaint of duration 2 to 5 years in both the groups. Duration of surgery. In the unilateral cases, the mean duration of surgery in the Zagolis procedure is 38.2 minutes, whereas in Sharma and Jawar, it is 25.4 minutes. On a statistical analysis, the p-value is less than 0.05, that is significant. Whereas on bilateral cases of hydrocele, the mean duration of surgery is 66.3 minutes in Zagolis procedure, and Sharma and Jawar, it is 53.6. On statistical analysis, it gives a significant p-value. Post-operative complications, post-operative pain, post-operative fever, post-operative scrotal edema.
Time up, sir.
Time is over, somebody. Hello. Hello.
Can we just allow him the conclusion? You can just mention your conclusions, final conclusion.
Go ahead, please.
Both the procedures are comparable in post-operative hematoma, fever, scrotal edema, attainment of normal size of scrota. Then compared to the Zagolis procedure, Sharma duration of surgery, both unilateral and bilateral cases of hydrocele, Sharma and Jawar technique has a less post-operative pain and a significant shorter duration of post-operative hospital stay, and there was no reoccurrence noted in either of the cases. However, there are lots of dropouts in our present study to conclude on the secondary outcome.
Okay, Dr. Sadi, you've done a study on a very old and a very topic on which a lot of studies have been done in the past. I just want to ask one thing: that there is already a procedure called a DOTS, procedure in hydrocele, and there you find that dissection is not that much. I fully agree. If you do dissection less, the hematoma and those things and firmness and hardness will be less. But then, do you think it's really worthwhile for giving any such patient spinal anesthesia? Because they do very well in local anesthesia, unless somebody has got a special reason. So all these are operated, and moreover, no hospitalization. Most of the time, they are discharged, say, by evening. So when we are doing even thyroidectomy, when you're doing even so many procedures in daycare, even people are doing in a day, and this is, studies have been done. A lot of mega studies have been done that a lot of such done. And if you are hospitalizing hydrocele, unless there is a very special reason, then it looks this is only for study purpose, or you're regularly admitting every patient for spinal anesthesia.
And the patient gets operated and discharged on the post-operative.
It's a long period.
5 days, depending upon the.
So, do you think that the scrosants were put up, by even quacks? They were trying to do something like that, and sometimes very serious hazards occur. So, scrosant will always make it very firm, and that is possible. And this is described. But then, what ultimately you feel now after doing study? Was it only for a research protocol you did it, or you are happy that there's something new has been found?
A study found that a surgical procedure of Sharma and Jawar that gives a lesser post-operative pain and fewer complications. It's better to do in remote areas also, and the patient can be discharged even in the post-operative day 1 without much more complications. As the patient stays in the hospital, here that means have a post-operative complication or distance, so they cannot come back to the center. So we want
Dr. Gore, would you like to ask something?
No, nothing. As you rightly mentioned, there have been n number of studies already been done. So and Jabulis is a gold standard, and as you mentioned, under local anesthesia, I believe this was an attempt to venture into a new direction. But good job, Dr. Sani. Good one. No problem. I think we can move on to the next speaker. We only have 5 more minutes before the next session starts.
Okay.
So let us see. Yeah. Thank you.
Tavanga Devi, please share your screen.
Good evening, sir.
Good evening. Dr. Vanga Devi. Okay.
Am I audible, sir?
Yes, yes, sure.
Yes. Good evening. I will be presenting a case series of rare ambiguous swellings in the head and neck region. Schwannomas arise most commonly from the vagus nerve or sympathetic chain in the head and neck region. A preoperative diagnosis, rarity, and non-specific clinical and radiological presentation. The aims of this case series is to discuss about the rare swellings presenting in the familiar regions of head and neck and to discuss about the approach towards undiagnosed swellings. This is a single center study and patients with head and neck swellings who visited our general surgery OPD are included in the study. The inclusion criteria are those patients in whom definitive diagnosis could not be made even after clinical, radiological, and FNAC evaluation preoperatively. Exclusion criteria are all other swellings in which conclusive diagnosis has been made. Here are two cases where the first case is our index case. The patient came with a complaint of deviation of angle of the mouth to the left and accumulation of food particles in the right side of the oral cavity since 1 month, and swelling is noticed in front of the ear or lobule since 1 year, and the swelling is gradually progressive. In the second case, the swelling is present over the left side of the neck since 10 years. On examination of the first case, the swelling is of size 5 into 4 centimeters, and there is elevated right ear lobule, and the surface is nodular and firm in consistency, and the patient has right element facial palsy. On the second case, the examination, the swelling is of size 10 into 8 centimeters below the left ear lobule and smooth surface and firm consistency. On primary evaluation, FNAC of the first case showed monomorphic adenoma and the ultrasound showed benign cystic lesion. And FNAC of the second case showed cytological appearances in favor of pleomorphic adenoma. Ultrasound suggested a benign cystic lesion. CT evaluation of the first case showed a multiloculated cystic lesion in the right parotid gland involving superficial and deep lobe suggestive of benign neoplasm, whereas the CT of the second case showed a well-defined minimally enhancing hypodense lesion in the posterior aspect of the neck of triangle. On intraoperative findings, multicystic lesion of size 4 into 4 centimeters with clear fluid is present. The facial nerve and its branches have been preserved after superficial peritodectomy in our index case. A cystic lesion of 7 into 6 centimeters is present beneath the muscle layer with clear fluid within the seiche. Here, in this case, the facial nerve and its branches have been preserved without any superficial peritodectomy. On histopathological examination, revealed benign schwannoma in both the cases, which is from the extratemporal branches of the facial nerve. In the third case, here the patient came with a complaint of swelling in the anterior aspect of the neck on the left side since 1 year, which is gradually progressive associated with forces of voice. On examination, the swelling is of 7 into 5 centimeters in the lower part of the neck, left side of the neck, which has nodular surface and firm in consistency. On primary evaluation, FNAC showed a cytological features of non-specific inflammatory lesion, and ultrasound suggested a benign cystic lesion, and blood investigations are within normal limits, and the video laryngoscopy showed left recurrent laryngeal nerve palsy. On CT, the suggested a benign cystic neoplasm. Intraoperatively, the swelling is of 7 into 5 centimeters encapsulated mass identified behind the left lobe of the thyroid, extending into the mediastinum. The thyroid tissue is normal. Histopathological examination showed a benign schwannoma, which is from the recurrent laryngeal nerve. The next two cases are related to the branchial clefts, where the first case is our index case. Here, the patient came with a complaint of swelling below and behind the right ear lobule since 4 years, which is gradually progressive. In the next case, the patient came with complaint of swelling on the left side of the neck since 1 month, which is gradually progressive. On examination, the swelling is of size 4 into 3 centimeters below, behind, and in front of the right ear lobule with elevation of the right ear lobule. It has smooth surface and soft in consistency. An examination of the second case, the swelling is of size 7 into 5 centimeters present below the left mandible with smooth surface and firm consistency. Primary evaluation of both the cases showed FNAC is cytological features of non-specific inflammatory lesions, and ultrasound revealed features of benign cystic lesion. On CT examination of the first case showed a large benign cystic lesion of the right parotid, and presence of multiple small lesions may be granulomatous lesion. CT of the second case showed a 7 into 4 into 3 well-defined lesion, which is affecting the medial surface of left parotid, suggestive of benign neoplasm. Intraoperatively, a 5 × 4 centimeter cystic lesion with a clear mucoid material which is extending into the deeper of the parotid is found. Hence, a superficial parotidectomy is done and complete enucleation of the cyst is done. In the second case, a 5 × 3 centimeter cystic lesion with clear mucoid fluid is present within the cyst. Complete enucleation of the cyst is done. Histopathological examination revealed a branchial cleft cyst. The first case is of the first branchial cleft cyst, and the second case is of the second branchial cleft cyst. Coming to discussion, facial nerve schwannomas are rare ectodermal benign encapsulated tumors arising from the Schwann cell encapsulating the facial nerve. The estimated incidence of intraparotid schwannomas originating in the facial nerve ranges from 0.2 to 1.5%. Kogge et al. Had conducted a retrospective study of over 38 years of about 3,700 patients, where only 29 patients were related to the facial nerve, of which only 8 involved the parotid segment of the facial nerve. Here, the patients with intraparotid schwannoma presented with a parotid mass, therefore became very difficult to diagnose the schwannoma clinically. FNAC, ultrasound, and CT, which are used to evaluate such cases, fail to diagnose the schwannoma preoperatively. Following the index case, where an avoidable superficial parotidectomy has been performed and the patient had postoperative facial patches, the following case, which was done by anticipating the presence of schwannoma, we had prevented a parotidectomy and postoperative complications. Schwannoma arising from recurrent angial nerve is a rare entity which can lead to misdiagnosis as a thyroid nodule. Although FNAC has suggested for cytological diagnosis, a review literature suggests that it is rarely conclusive as in our case. Hence, a true cut biopsy or MRI can be considered for such cases. First branchial cleft cysts are extremely rare causes of parotid swellings and comprise less than 1% of all branchial anomalies. In our case, superficial parotidectomy has been performed, which could have been prevented if it is considered as a differential diagnosis since the beginning. A good understanding of regional anatomy and embryology is therefore imperative, can lead to an early diagnosis and thereby effective management. Concluding, an important conclusion that can be derived from this case series is that familiar regions can have unfamiliar diagnosis. So, a typical diagnosis should always be kept in mind for undiagnosed swellings in head and neck region. It's a little bit of clinical experience of facing these uncommon diagnoses that helps in reducing the clinical morbidity in patients. Thank you.
That was a nice presentation, Dr. Vangadevi Harsha.
Yes, thanks.
I just wanted, and it was a heterogeneous, not like a monotonous presentation. Your slides were really interesting. The only question I wanted to ask was, during your discussion, you had mentioned that in order to avoid the diagnosis, it would have been better if you would have gone for a true cut biopsy or something like that. But then your lesions on an ultrasound and all the other modalities of investigation are showing cystic lesion. So is there any possibility of a true cut biopsy in a cystic lesion? Doesn't it contradict itself? So how will you approach this complication?
Yes, not for cystic lesions. So the first two cases we have diagnosis came as a pleomorphic adenoma, which is suspicious diagnosis, but not confirmatory on the FNAC. In those cases, we can consider a true cut biopsy.
Okay.
For cystic cases, we can consider MRI. Because CT
Right.
Yes, sir.
And the second thing is schwannomas are usually a histopathological diagnosis rather than a clinical diagnosis.
Yes, sir.
So no matter how much amount of experience or anything a clinician has, it may not be very easy to diagnose a schwannoma or nerve sheath tumors very easily in a preoperative setting. What is your opinion about that thing? And does your study and observation make any difference in the mindset of a surgeon evaluating a cystic lesion in the neck or as well in the neck?
Yes, the main purpose of this study and this presentation is that in such cases where preoperative diagnosis is not made either by all the investigations such as ultrasound, CT, or FNAC, such a possible diagnosis should be considered so that intraoperatively we should be careful while dissecting the cystic lesion so as to prevent the nerve injury and preventing the postoperative patches or surgery. Not for every case, but preoperative diagnosis has not been confirmed. Such diagnosis can be kept in mind.
Great. As the dictum goes, rare diagnoses are rarely correct because they are rarely present. So I agree with your study point of view that these diagnoses should be kept in the back of the mind for atypical swellings and all. Nice presentation. Over to you, Dr. Ramakant sir, in case you wanted to ask him.
Sir, you're muted, sir. Excuse me.
Okay. All right. You presented well. But then what is coming to my mind is that it's not a very common diagnosis, a very rare one. As Dr. Gore said very rightly, there's a dictum that rare diagnosis, rare correct. So you always come as a surprise. Now, most of the times, I will say this can happen in parotid area, that you have to do superficial parectomy and then you find that something else is there. And it is difficult otherwise. I just wanted to know that was it really a real surprise in some cases when you were operating? It was, because you thought it was a parotid tumor. Every feature is there. The lobule was lifted up and then all study. CT scan was also must have been done in these cases.
Yes, sir. CT scan was done, but it's not diagnostic.
Right, you cannot diagnose. So any time you hit the nodule itself and got a report of schwannoma beforehand?
No, sir. Preoperatively, we did not receive schwannoma as a report preoperatively.
All right. It's all right. You presented well. Thank you very much. Thank you. Thank you. So the next one.
I believe that was the last presenter of the session.
All done for next session.
Okay.
Thank you, Dr. Ramakant sir. Thank you, ASICON and the team and the fantastic management by the software guys. Very nicely conducted.
Okay.
Thank you so much. We can call this session off.
Thank you all. Thank you very much. Okay, bye.
Please announce the session. Sir, please announce the session. First presenter is Dr. Haiti, Dr. Srinivas, Dr. Prakash.
Hello.
Sir, please start the session.
Yeah. Good evening, Dr. Prakash.
Yeah, I'm here.
Good evening, sir. Dr. Haripriya, good evening.
Good evening, sir.
Yeah. So we got how many papers in this session?
Total 6
5?
presenter, only 3 is
Total
joined.
6. Only 3 has joined. So shall we start? I think Dr. Prakash will take over, sir.
Yeah, we can start with the first presentation. Actually, we didn't have that list, so the host has to tell us who is going to present, and we'll start one by one. We'll call the first presenter, please.
Good evening, sir. I'm Dr. Haripriya. I'm from Chettinad College, sir. Can I start the presentation, sir?
Yeah, sure, please.
Yeah, please.
I'm here to present a comparative study between Ripasa and modified Alvarado scoring system in the diagnosis of acute appendicitis in a suburban Chennai population. Acute appendicitis is one of the most common causes of surgical emergencies, with appendectomy being done in around 25% of the females and 12% in male population. Diagnosis is usually done clinically based on history and examination. Scoring systems have also been used for the diagnosis. The most commonly used scoring systems, such as Alvarado and modified Alvarado scoring system, were initially designed for the Western population. Though these scoring systems have very high sensitivity and specificity, they, when applied to other groups, it is not the same. Comparatively, a new scoring system was developed in Malaysia, known as Ripasa, which has a better sensitivity and specificity. We have studied the predictive values of both these scoring systems in a suburban Chennai population. The aim was to compare the usefulness of modified Ripasa score and a modified Alvarado score in the diagnosis of appendicitis. Modified Alvarado score reduces the risk of perforation and number of negative appendicectomies performed.
So the modified Alberta score consists of migration of pain, which has 1 point, anorexia, which has 1 point, nausea and vomiting, which has 1 point, RF tenderness, which has 1 point, rebound tenderness, which gets 2 points, and elevated temperature, which gets 1 point, and leukocytosis more than 10,000 for 2 points. So when we get a total score of around 9 to 10, there's a high probability of acute appendicitis, or a definitive diagnosis of acute appendicitis can be considered. When it's 7 to 8, it's most likely it is mostly an acute appendicitis. When it's 5 to 6, it's probably a case of acute appendicitis. So when it's less than 5, it is usually not appendicitis. However, a score of 7 or above is considered as a cutoff for the surgery. In case of gangrenous appendicitis, the mean score is slightly lower than the mean score for suppurative appendicitis. This is validated by the famous Truccius Calm of Dufly, in which he describes the temporary absence or reduction in the pain and tenderness during the gangrenous stage of the disease. Lipasa score. Lipasa score has the following variables. When the patient is a female, we give a 0.5 score. When the patient is a male, we give a score of 1. When considering the age, if it's less than 40, a score of 1 is given. When it's more than 40, a score of 0.5 is given. RAF pain, 0.5 is the score which has been given. Pain migration to the RAF, 0.5 is the score given. Anorexia is given a score of 1. Nausea and vomiting is given a score of 1. Based on duration, if it's less than 48 hours, a score of 1 is given. If it's more than 48 hours, a score of 0.5 is given. RAF tenderness is given a score of 1. Guarding, if present, it's given a score of 2. Rebound tenderness, if present, is given a score of 1. And Roswing sign, is, if present, is given a score of 2. Temperature is given a score of temperature is given a score of 1. Leukocytosis is given a score of 1. Negative urine analysis is given a score of 1. And foreign nationality is given a score of 1. So when the total Lipasa score is less than 5, there's a probability of acute appendicitis is mostly unlikely. When it's 5 to 7, low probability of acute appendicitis is present. 7.5 to 11.5, the probability of acute appendicitis is high. When it's more than 12, there's a definitive acute appendicitis. There are many scoring systems which has been novel scoring systems which have been developed, and they have been on trial on and off. The most common, I like to mention a few. The C-reactive protein is one such. It has a sensitivity of specificity which has been very wide range among the various studies which has been conducted, of approximately 40 to 95%. So it's a positive score is given when it's more than 0.8 ml. Interleukin-6 is also been considered a scoring system. And SAA, which is serum amyloid A, is also considered as scoring considered as a scoring system. Granulocyte colony stimulating factor can also be considered. The value which is considered if it's positive is 28.3 picogram per ml. Then LRG, which is being usually measured in urine, is also considered. LRG stands for leucine-rich alpha-2 glycoprotein. Cal protein, which is S100, A8 or A9, it can also be considered for a scoring system. There are other scoring systems such as Sanaki scoring system or Ohoman scoring system. In Sanaki scoring system, the use of ultrasound is also being considered. A score of 6 is given if it's an ultrasound diagnosed acute appendicitis, and a score of 4 is given if the patient is having RF tenderness, and score of 3 is given for rebound tenderness, and a score of 2 is given if patient is having leukocytosis. When the total score is more than or equal to 8, then it's considered as positive. Omen scoring system. In Omen scoring system, material and method. Inclusion criteria. All the patients above the age of 18 years with a history and clinical features suggested to have acute appendicitis were included in the study. Patients willing to participate in the study with no previous history of appendicitis were also included in the study. Exclusion criteria. Patients who were not willing to participate or those with other coexistent pathologies were not considered in the study. The management of the patient was solely based on clinical radiological evidence and the surgeon's discretion. Patients who underwent appendicectomies were followed and their histopathological reports were collected. Acute appendicitis was diagnosed on the basis of neutrophilic infiltration in the muscularis propria. Here's the image shown for acute appendicitis. Introduction, the statistics which was the descriptive statistics was used to describe the statistical data. Categorical variables were represented by percentage, whereas the continuous numerical variables were represented by the mean and standard deviation. ROC, which is receiver operating characteristic curve, was used to assess the diagnosing effect of the two screening tests of appendicitis. Demographic information. Our study had 39 male patients and 19 female patients, which led to a conclusion of we had majority of male patients, twice the amount of male patients when compared to the female patients. And mean age was 28 years, plus or minus 12.5. Number of patients who had HP correlation, when HP came out as definitive HP came out as appendicitis, it was 85% of the patients had appendicitis, whereas negative appendicitis was present in about 15% of the patients. Negative appendicitis was considered when the final HP came as lymphoid hyperplasia or eosinophilic appendicitis was present. In our study, this shows an ROC curve for Alvarado score. The ROC curve is usually the mentioned by the line over here. If the ROC curve is more, then it's more. It has a more sensitivity and specificity when compared to a lesser curve. So this is how we analyze the ROC curve. Here in Alvarado score, we can see the curve is a little bit lower, and the area which was covered by the curve was around 0.739, and the p-value was around 0.23.
Time up.
Since you could not complete, do you want to conclude in a minute?
Yes, sir. I'd like to conclude, sir. In our conclusion of the study, we were trying to come to a conclusion that Ripasa is more sensitivity and specificity when compared to a Chennai-based suburban population when compared to Alvarado. But we are not. Alvarado is the gold standard, and it always has a sensitivity and specificity. But since Ripasa has a more number of variables, now it has a more definitive specific diagnosing, helps us in diagnosing the appendicitis more better. So.
I think you started the presentation well. The slides were good, but you spent a lot of time on literature review comparing other scores. First, important thing you should tell about your study population, your important results. Then you can come to the other review of literature and comparable studies. So you should be careful in while presenting when there's time limitation in such studies. But how many patients were included in the study? Total 50. How much?
58, sir.
58. Do you think that with 58 you can make a meaningful ROC curve analysis with two arms?
So I had a base article. So the article had a lesser number of patients, and based on that, I discussed with the statistician. And he told minimal number of patients required for the ROC curve to be put up was 30, and I went in for double the number. So we tried to get a 60, but we couldn't get a follow up of 2 patients, so we came up with 58. So.
Okay.
There is one question. Shall I, Dr. Prakash? Hello.
Yeah, Dr. Srivas asked.
How clinically useful was this scoring system in your study? So you were totally dependent on this scoring system, or you were?
No, so we used the scoring system. We used the scoring system, and we were just using it to compare. We took scoring system for all patients, but we still patient also still underwent an investigation of ultrasound. So before we were taking up the patients for the procedure, but sometimes in ultrasound we couldn't come to a definite diagnosis because the appendix could not be visualized or there's just some free fluid. In those cases, we were depending on the scoring systems. And we had a total number of 9 negative appendicectomies, out of which majority was because of Alvarado. So around 8 patients had negative appendicectomy because of Alvarado score, whereas only 1 was negative because of Ripasa scoring. So.
Okay. Now, did you at any time consider doing a CT scan in these patients when the ultrasound was negative?
Yes, so we have considered and we have done for a few patients, sir.
Are you justified in doing a CT scan in all these patients where USG is negative, or you have to depend on the scoring system?
No, so the idea of getting a scoring system was to avoid the use of a CT, especially when you're taking up a Ripasa. So when we had few difficulties around 5 patients, we were still going on for CT. But for most of the patients, we just wanted to come to a study conclusion, and then we thought we'll apply the scoring system. And just based on that, we can proceed further, sir.
Okay, thank you, thank you.
Please move to next.
Yeah.
Dr. Prithvi Raj is joined.
Thank you,
Next
sir.
presenter, please.
Thank you, sir.
Thank you.
Sir, should I start?
Dr. Prithvi Raj.
Prithvi Raj,
Dr. Prithvi
yes.
Raj.
Good evening, all. This is a study conducted in
Sir,
JNMC
your
Hospital,
screen is not
Belgaum.
visible.
Sir?
Your screen is not
Sharing
seen.
is not a start. Please stop share and again start sharing. Please share. Make it full screen. Go ahead.
Now is it visible?
Yeah, proceed.
Start, sir, start.
Yeah. This is a study conducted in JNMC Hospital. The study is a mini laparoscopic appendectomy versus conventional laparoscopic appendectomy, a 1-year randomized control trial at JNM Hospital. Coming to the introduction, appendicitis is the most common condition requiring immediate surgical intervention in all population. With the modern medicine improvement, the mortality has been brought down from 50% to less than 1 in 10,000 person. With modern diagnostic facility and surgical skills and fluid and antibiotic therapy, the morbidity is still more than 5 to 8%, mainly due to the wound infection because of delayed diagnosis and treatment. The aim of our study is to establish a better cosmetic outcome and assessment of post-op pain in a mini laparoscopic with the conventional laparoscopic appendectomy. Coming to the methodology, a randomized control trial of 60 patients who presented with complaints of recurrent pain abdomen, who presented to surgical OPD or casualty were taken for the study. Inclusion criteria includes all patients with chronic appendicitis or patients with recurrent appendicitis, recurrent lower abdominal pain, and patients who underwent diagnostic scopy and proceeded with appendicectomy. Or in our criteria, we excluded patients with acute appendicitis. Complicated appendicitis includes perforated or gangrenous appendicitis. Suspected or proven malignancy, previous history of abdominal surgeries, and appendiculomosis were excluded from our study. In group 1, the conventional laparoscopic appendicectomy patients were included. Group 1 consists of using 10 mm umbilical port and 10 mm suprapubic port and 5 mm left lower quadrant port. In mini laparoscopic appendicectomy group, 10 mm umbilical port and 3 mm suprapubic and 3 mm right lower quadrant port were used. Patients were post-operatively followed and evaluated for signs of pain or discomfort in post-op day 1 and on the date of discharge. Mostly in our study, the date of discharge was day 3 or day 5. Within day 5, all the patients got discharged. Sutures were removed in the follow-up on day 7 to day 10. The score of all patients were assessed by patient and observer score assessment scale after first week, second week, and first month and third month of surgery. This is the picture showing mini lap appendectomy. Here, a 10 mm umbilical port is there, and 2-3 mm suprapubic and left-right quadrant ports are there. This is the picture showing instruments for a mini lap appendectomy. A 3 mm trocar and a 3 mm grasper, and these are shown. Coming to the results, demography results includes the maximum number of patients in both the groups were ranging from 21 to 30 years. And in group 1, the male to female ratio are equal, and in group 2, the female ratio outvoted the males. Comparing to the two groups in terms of diagnosis, the patients with diagnosis of pain abdomen were 20% and appendicitis were 20%, wherein maximum in group 1, whereas in group 2, chronic appendicitis patients were maximum. This is a diagram showing comparison of two groups with pain score at different post-operative time. This is the POD1 and at the date of discharge. The pain scoring of both the groups were assessed by visual analog score on post-operative day 1 and on date of discharge. According to the above analysis, the mean value in group 2 is on POD1 is found to be 2.4 and in and 5.9 in group 2. On date of discharge, it is 0.8 in group 2 and 3.75 in group 1. This gave a difference value of 0.73 in group 2 and in 0.04 in group 1, which was significant p-value less than 0.05. In both the groups, the pain has reduced, but more significant in group 2, which is a mini lap appendectomy group. Comparison of the score between the observer scale assessment and the patient scar assessment, the difference in time points in two groups were given. With this analysis, the cosmetic outcome of the scar in both the groups is good, but in group 2 having a slightly better value at all times of interval and comparatively better score at the end of the third month. Coming to the discussion, overall last 2 decades, the lesser invasive techniques became more popular, and these techniques resulted in shorter recovery time, reducing the hospital stay and lowered complications. Instruments with a smaller diameter provide lower friction and gripping. Hence, they promote precise movement and delicate handling of tissue, causing lesser trauma to the abdominal structures and walls. Studies reported increase in surgical time in mini laparoscopic appendectomy on an average of between 35 to 130 minutes. Evil et al. Classified a minimal laparoscopic appendectomy, a minimal laparoscopic procedure as conventional, which used instruments between 3.5 mm to less than 5 mm diameter. A modern mini laparoscopy, which is from less than 3.4 to 2 mm. Micro is considered as less than 2 mm to more than 0.5 mm, and ultra was less than 0.5 mm. Any technique which used material less than or equal to 0.5 mm is in diameter were considered as mini laparoscopic appendectomy, mini laparoscopic procedure in different literature. Certain other articles also considered mini laparoscopic technique as a sum of incisions which is not exceeding more than 20 mm. Coming to the conclusion, mini laparoscopy should be better outcome in terms of minimal post-operative pain, lesser use of post-operative analgesics, yearly discharge, sooner recovery to normal lifestyle, and satisfactory cosmetic outcome. The drawback of mini laparoscopy were in few instances of difficulty retrieval of specimen. To conclude, mini laparoscopic appendectomy exceeds conventional laparoscopic appendectomy in selected patients with chronic and recurrent appendicitis. Thank you.
Yeah, Dr. Prithviraj, good study. 2-3 questions about the study method you haven't mentioned. When was the randomization done, and how was the randomization done? Which method, and why did you exclude acute appendicitis?
The study period was from 2018 January to 2019. 2009. The study period is in 2018, sir. 2018 Jan to 2018 December.
What method was employed? When was the randomization done?
Randomization is a simple randomization was used, sir. Every alternate patient was taken into mini lap, and every odd patient were considered for.
That's a sequential sampling. It's not randomization. It's not randomized study means we have to either make random generated computer numbers, make it in a sealed envelope, and use it just before the decision is made. Okay, so that's how randomization is done. And when was this randomization done? It was decided before surgery or on table?
It was decided on table, sir.
Okay, and about why acute appendicitis was, we can understand mass and difficult perforated ones you rule out, but why did you rule out acute appendicitis?
Acute appendicitis is ruled out because the surgical option given to the patients there on admission, those things were difficult in case of acute appendicitis, sir. We didn't with fever, we are not we ruled out the patient with acute appendicitis because of logistics and other reasons.
Okay. And how many patients started with mini laparoscopy then required conventional laparoscopy?
No, sir. The patients who started with mini laparoscopy, no patients were converted to conventional. Incision was also not extended in mini laparoscopic procedures, sir. All the specimens were retrieved within the 10 mm port. In conventional group also, there is no conversion of open or not done, sir. Total 30 cases has been done in each, sir. Conventional 30 cases and mini lab 30 cases has been done.
Srinivas, anything?
No questions. No. It's a good presentation.
Okay.
Thank you, sir.
Thank you. Thank you, Dr. Prithviraj. We'll move to the third presentation.
Yes.
Is Dr. Prasanna.
Good evening, sir.
Good evening.
Good evening to one and all. I'll be presenting on my topic to study the effect of bariatric surgery on urinary incontinence in obese individuals. It was done under the chief guidance of Professor Dr. Sandeep Agarwal, AIIMS, New Delhi. Brief introduction. Urinary incontinence is defined as the complaint of any involuntary leakage of urine. It may be of three types: stress, surge, and mixed. Obesity is one important cause of urinary incontinence. Odds of urinary incontinence are 2 to 3 times higher in obese individuals, and with every 5-unit increase in BMI, there is 30 to 60% increase in incidence of urinary incontinence. Coming to the mechanism, there is increased intra-abdominal pressure leads to increased intravesical pressure and increased urethral hypermobility. Also, associated hyperglycemia can cause autonomic sensory neuropathy, causing bladder dysfunction, and also hypertriglyceridemia has a direct effect on the causing neuropathy. Also, OSA, which causes oxidative stress, can lead to bladder dysfunction. The impact of bariatric surgery is that it decreases the intra-abdominal pressure, causing overall improvement in bladder and sphincter function. Also, the better glycemic control can halt the neuropathy. The primary objective of the study was to study the impact of the bariatric surgery on urinary incontinence, and secondary objectives were impact on weight, BMI, and other comorbidities. It was a prospective observational study. All patients aged more than 18 who underwent bariatric surgery in our unit between July 2018 to June 2019 were screened for urinary incontinence using the ICIQ questionnaire. Patients with urinary incontinence were diagnosed using the ICIQ UI questionnaire. And patients with prior urological surgery were excluded from this study. All patients filled up the ICIQ UI questionnaire preoperatively, and the patients underwent either sleeve gastrectomy, laparoscopic Roux-en-Y gastric bypass, or laparoscopic mini gastric bypass. Patients with urinary incontinence filled the questionnaire postoperatively at 3, 6, and 12 months in follow-up. And participants were also asked about the number of pads changed, and the same was recorded at each follow-up. This was the ICIQ UISF questionnaire used. It has 6 sections. Out of it, 3rd, 4th, and 5th sections evaluate the frequency, severity, and the impact of quality of life of urinary incontinence in men and women. It is highly accurate and validated questionnaire, and it scores. It gives us a score from 0 to 21, where 0 is no incontinence, and 21 is the worst form of urinary incontinence. Also, section 6, based on the answers given to the questions here, we can classify incontinence into urge, mixed, and stress incontinence. So also on the score, it was classified into slight incontinence, moderate, severe, and very severe type of incontinence. The primary outcome measures were the impact on urinary incontinence based on the ICIQ scores at 12 months. Secondary outcome measures like impact at 3 and 6 months, number of pads used at 3, 6, and 12 months, weight loss outcomes, and comorbidity outcomes. Appropriate statistics were used, and p-value of 0.05 was considered significant. Coming to the results, 148 patients were screened, and 41 cases were found to have urinary incontinence, prevalence of 27.7%, out of which 39 were female and 2 were male. Stress incontinence was the most common, with 29 of them having stress incontinence. At follow-up, all 41 patients were followed up, no loss to follow-up, and by the end of 12 months, resolution of urinary incontinence was seen in 36 patients and improvement seen in 5 patients. This was the baseline characteristics of the screen cohort and the group with incontinence. Majority of the cohort was females in both the groups, and sleeve gastrectomy was the most common procedure. Stress incontinence was the most common type of incontinence, while moderate severity of incontinence was the most common. This is the impact of urinary incontinence. So ICIQ scores decreased from a value of 8.8 at baseline to 0.7 at 12 months. The total cure rate was 87.8% at the end of 12 months.
Also, patients, the proportion of patients using any number of pads decreased from 92.7% at baseline to 9.8% at the end of 12 months. All values were statistically significant. This was the trend of the BMI ICIQ score and the pads used. Maximum impact was seen between 3 to 6 months. When we compared mean age, weight, height, waist circumference, and BMI in group with incontinence and without incontinence, it was found group with incontinence had a lower mean weight. Other values were not statistically different. It was found that women, diabetics, hypothyroid patients, and patients with higher waist circumference, lower weight, or older age had a higher risk of having urinary incontinence. Coming to weight loss, patients with urinary incontinence had a lower percent EBMI loss at all follow-ups. However, the values were not statistically different from those without incontinence. This was the table showing impact on comorbidities. Significant resolution and improvement rates were seen in all comorbidities. When we compared our study with the other studies, it was found that the cure rate was higher in our study compared to others, and also it was found stress incontinence was a higher prevalence in our study. Similar study by Shimonov et al. Also showed a higher stress incontinence prevalence, and they also reported a higher cure rate compared to the other studies who had a lower prevalence of stress incontinence. So on subgroup analysis, stress incontinence group had best outcomes in our study, leading to overall better outcomes of the whole study. No Indian studies were found in this case. When we compared objective test and the ICIQ questionnaire for grouping incontinence, it was found urodynamic study and ICIQ questionnaire comparably diagnosed stress urge and mixed incontinence. Kappa value of 0.77 was seen, so that is a good comparison. Hence, patients usually, when recruiting patients, they used to avoid if it was an invasive test such as urodynamics. However, in case of questionnaire-based studies, the recruitment of patients was easier. The strength of study was it was a prospective study and validated questionnaire was used, objective test number of pads used, and 100% of follow-up was seen. Weakness was there was no blinding of the assessor and sample size was small. In conclusion, bariatric surgery leads to definitive improvement of urinary incontinence in obese individuals, well-sustained results at 1 year follow-up, and other comorbidities also resolved. Patients with stress incontinence derived better outcome post-bariatric surgery, and bariatric surgery should be recommended for morbidly obese patients with urinary incontinence. Thank you.
Yeah, Dr. President, that was a very good study, very good prospective study, and the data you have compiled it very well. Only suggestion which I would make is to make the results charts little more simpler. It looks very complex and very difficult to comprehend. You could use a lot of diagrams or percentages in the picture, pie charts that would look nice. Why was that age not considered into stratifying the patients above, say, one cutoff of age and their improvement in the incontinence? Any patient required any supportive procedures if they fail to improve their incontinence level?
Sir, as such, age we did not consider in this study, and in this study, it was specific that patients who underwent any other procedure for urinary incontinence or taking any drugs for incontinence were excluded. It was purely the study to evaluate the effect of weight loss due to bariatric surgery, and no other procedures were done in these cases.
No, in follow-up, any patient required TBTO type of procedures?
No, sir. That's what. In follow-up also, up to 1 year of follow-up, we followed up all the 41 patients, and none of the patients underwent any other procedure or treatment for urinary incontinence. And if such a procedure was done, that patient was excluded because we wanted to study only the effect of bariatric surgery.
Dr. Srinivas?
Yeah, only one simple doubt. All these cases were taken for bariatric surgery for this incontinence correction, or this correction of incontinence was just added observation that?
Sir, all these patients underwent bariatric surgery for the indication of like BMI more than 40 or comorbidity with 35, and also they had incontinence along with that. So such patients were considered for this study. As such, specifically, we are finally forming a recommendation that even patients with just
I got it. I got it. Thank you. Well presented. Okay, thanks.
Yes, thank you.
Thank you, Dr. Prasanna. I think you
Thank
should
you.
try to put it as a paper because since there's no study in this context. Okay, we'll go to the next presentation. I think Dr. Noah.
Good evening, respected chairpersons and colleagues. Today I'm going to present the paper, A Gut Microbiome in Colorectal Cancer. And I am from Jawaharlal Nehru Medical College, AMU Aligarh, under the supervision of Professor S.H. Harris, Department of Surgery, and Dr. Nazish Fatma, Department of Microbiology. Colorectal cancer ranks third in terms of incidence and second in terms of mortality worldwide. According to Globocon 2018, around 1.8 million people were diagnosed with colorectal cancer in the year 2018, and around 8 lakh people died because of it. And the incidence in India is less, but it is increasing slowly. Uh, Colorectal cancer is considered a marker of socio-economic development. Its incidence is about threefold more in countries with high development index, human development index with high HDIs, and it is lower in low HDI settings, but the mortality is increasing in lower HDI settings. In countries showing transitioning economies, there is an increasing incidence as well as mortality in such countries. The reason for increasing mortality is because there are no screening programs and because of low healthcare setups in such countries. Now, the increasing incidence in transitioning economies is due to westernization, which is because of a sedentary lifestyle, smoking, alcohol consumption, diet which is composed of high fat, low fiber diet, and red meat consumption and obesity. And all these factors have been shown to affect the gut microbiome. In a study conducted by Dove et al. In the year 1992, they pointed out that if germ-free mice were inoculated with bacteria, they started showing inflammatory changes in their colon, which later on developed tumor. So the bacteria, they live in a form of a biofilm in the colon, and there are millions and millions of bacteria living there. Now, these bacteria interact among themselves and also with the epithelium of the colon and produce pro-inflammatory changes, which increase polyamine metabolism, T cell inflammation, colonic epithelial cell proliferation, and gene mutation, which leads to and decrease E-cadherin, which leads to dysbiosis and oncotransformation. Now, these biofilms were taken up from the human subject with colorectal cancer and inoculated in germ-free mice, and in 12 weeks they showed the development of these of colorectal cancer. And when this biofilm was again inoculated in a new cohort of mice, they also developed the disease. Keeping these things in mind, the study was conducted with the aim of assessing the role of gut microbes in colorectal cancer. So endoscopic colonic mucosal samples were taken of patients with colorectal cancer, and those coming for lower GI endoscopy for other reasons. The samples were subject to tissue culture, aerobic in my hospital, and then the data was analyzed using MedCalc software. The patients were similar when compared, the male and female composition was similar in both the groups. However, the positive findings were that the age of the patient, the mean age was more than 50 or around 50%, 50 in patients with colorectal cancer, whereas the mean age was less in patients who did not have the disease. Along with it, the positive tissue culture was seen in about 70% of cases with colorectal cancer and only 22% in the control, and the p-value was less than 0.001. The site of the disease. The patients in my study, the left-sided colorectal cancer, patients, out of which 29, around 82% had positive, 82% were left-sided, had left-sided disease, with 29, that is around 70% had positive culture, and in right-sided, around 60%, 66% had positive culture. The bacterial tissue culture showed mostly E. coli in the colorectal cancer groups. Logic models were created for both the bacteria and also for the other risk factors. And it was seen that when culture was added to the other risk factors, the area under the curve increased from 0.910 to 0.938. Today, I received the electron microscopic image of a colon mucosa sample that I had taken from a patient, and it shows these bacteria, these cocci, within the mucosa, and they are attached to themselves and also attached with the mucosa, showing a characteristic biofilm formation. So the mean age of the patients in India, and generally seen in the Indian cities, Indians is less than 50 years. In my studies, it was about in my study it was about 51.1, whereas in Western studies about 90% of patients are more than 50 years of age, and about 40% are more than 65 years of age. So in Indian setting, the age of incidence is generally lower. The sample that I collected were mostly left-sided because symptomatic patients come to the clinic for lower GI endoscopic, those who have symptoms of bleeding PR or constipation. In Western world, there is an increasing trend towards right-sided tumors that is involving the cecum and the ascending colon. The bacteria that I could cultivate were only aerobic, that is E. coli and Proteus, whereas in other studies, the other bacteria that are implicated are Streptococcus galacticus, Enterococcus faecalis, E. coli, and Fusobacterium nucleatum, and Bacteroid fragilis. These bacteria were cultured, and also genetic analysis were done, and they were also observed by scanning electron microscopy. So there is, by this study, I can, because 70% of patients of colorectal cancer showed positive culture. So this study proves there's an association between gut microbiome and colorectal cancer, and the fact that the area under the curve increased because of adding culture to the risk factors. Therefore, it can be used as a screening tool for the diagnosis of colorectal cancer and early screening of patients that have a positive family history of colorectal cancer. The limitations of the surgery was a small sample size, the aerobic culture induced, and many of the patients that were admitted in the hospital had taken antibiotics. So sometimes their bacteria might have been missed because of, they might have died because of this. And the future work envisioning the importance of this paper, we can see that the gut microbiome can be used as a method to screen and diagnose the disease, and also the modulation of the gut microbiome by diet and antibiotics could be used in future to in the treatment of colorectal cancer. Thank you.
Thank you, Dr. Noha. That is a novel concept. And may I ask you 2-3 questions? Your conclusions, you have said that this can be used as a screening method. Is there any evidence, or is there any study saying that this can be used as screening method? As far as I know, only polyps are being considered in the screening colonoscopic finding, never the culture or gut microbiota. But
so actually, it's a very recent study. The earliest work that is being that is a 2014 paper of John Hopkins University, in which they have studied around 200 samples, and they have tried to study the temporal association. They have studied it during the adenoma period and also in the carcinoma period. So they are trying to develop methods, and they are trying to use fecal sample for using or biofilms. Assessing the biofilms for using it as a screen, like a screening tool, like fecal blood analysis guaiac tests are used. Similarly, they are trying to use it, and in certain recent studies in 2020, they are trying to trying to assess what metabolites are being produced by these specific bacteria, so that that similar tests can be developed for uh, screening these in colorectal cancer, especially in this is more useful in places where the disease is more prevalent.
That if this comes true, then you would say that periodic dose of antibiotics will decrease the incidence of colon cancer, is it not?
Not exactly, because there was one study where they had shown that using probiotics and improving the diet of the patients, like increasing the fiber content and decreasing the fat and red meat consumption, could affect the bacterial population. It will prevent dysbiosis, because what happens here is that the biofilm forms because the normal commensals they die because of the bad diet, and they are replaced by these pathogenic bacteria which produce a pro-inflammatory state. So the butyrate producing bacteria, they become less, whereas the bacteria that are pathogenic, they are pro-inflammatory, they increase, like E. coli and specific strains of bacteroids and enterococcus and Fucibacterium nucleatum, and many other anaerobes and viruses and fungi are also implicated in this.
Any further questions?
No, sir. No questions on my side.
Thank you, Dr. Noah. Thank you.
Thank you. Thank you.
Thank you.
Are there any other papers to be presented?
No other presentation will join.
Okay. So then shall we wind up the session?
Okay, sir. Okay. Thank you.
Thank you. Thank all the presenters for coming up with good papers. And thank you, Dr. Srinivas.
Thanks, sir. Thanks.
Thank you.
Thanks.